Hello everyone. Hello everyone. Good afternoon. So we are just done with the INI-CET exam, and a lot of students have joined us. Must be a mix of feelings. Some of you have done well, some of you a bit doubtful. But whatever it is, this is just going to be a session where, we as a team at DocTutorials, we are just trying to guide you on the initial insights of the exam first, followed by the recall video. And all of you can just stay tuned to this particular link, and all the subject recalls we'll be doing in this link itself. So first of all, before any insight, I just want to congratulate each one of you for the effort that all of you have put in. It's not easy spending a lot of time with books, but you all have done that. You all have given your best effort, and we all are so proud of you. And see, irrespective of the outcome of the exam, see it from a positive point of view. Like if you get it, good, catch the next flight to Central Institute. But otherwise, you've got a NEET PG exam coming up in a few months' time. So you've got necessary time to make corrections. So don't feel disheartened if the exam did not go your way. You have definitely got time to correct your mistakes and then move forward, right? Now, regarding the initial insights of the paper, so based on what initial insight, I would say initial insights, because sometimes what happens is that you feel that exam is relatively easy to moderate, but once the options, start coming, and then, a few options might be twisted. So maybe an easy to moderate paper can later turn difficult, or even vice versa as well. So we are actually collecting questions from the students, and we are coming forward with the recall as well. But based on the initial analysis, what I assume is that the exam was of a moderate difficulty level. Now, on just to have a few more insights about all subjects, we have got other faculties also joining with me. We have got Sandeep sir, we have got Gayathri ma'am, we have got Khaleel sir, we have got Vandana ma'am. So all of us are here. So let's have Sandeep sir on screen. Sir will tell you based on the initial insights that he has got from the students. Sir, how was the paper, sir?
Good afternoon, Rahul sir. Good afternoon, all the esteemed faculty, my colleagues, and good afternoon to all the students who are joining in here. Now, I'm Dr. Sandeep Sharma. I'm the pediatric faculty at DocTutorials. Let me share it with you that these, as you can see on the screen, this is the overall input that we have got. The sample size is relatively small. It will keep on coming the more inputs and insights are coming in. But based upon what almost 50 plus students of different exams, different difficulty level students. When I say difficulty level students, I mean there are people who have appeared before, not done. There are people who have cracked the exam before, but now reappearing in the exam. And there are people who are still in internship and sitting in the exam. So there is a mixed bag of students who have shared with us. Now, this INI CET exam, it is very important to understand that the exam is never going to be easy. It is definitely going to be moderate, depending upon your preparation level and whether questions were according to your liking or not. You may perceive the paper as moderate or difficult. It was somewhere between moderate to difficult. It was definitely not easy. That is the first takeaway. Then there are some general trends you can definitely make out. There were many factual questions. As you know, generally the paper is becoming more and more clinical scenario based. This time scenarios were there, but there were still some factual questions. Previous year topics were heavy. Almost 50 to 60% paper was previous year topic. When I say previous year topic, I do not mean PYQ. I mean previous year topic. Topic being the same, details being asked. For example, milestone question was there. Milestone, we know it is always going to be there. It is a previous year topic. But it was a red flag sign kind of question which was asked in milestones. Harrison updates were asked. Harrison updates means things in which Harrison has changed. For example, Rahul sir is better one to judge about it, and we'll be coming to Rahul sir back on this. So, for example, you have these fatty liver diseases, metabolic syndrome, associated liver disease. You have resmetirom. So there was a question asked on resmetirom. Now, it looks like a pharma question, but it is actually a medicine question if you are thorough with the updates of Harrison. There was a good weightage of OBG, surgery, and pathology. Traditionally, These are the three subjects from where a lot of questions are asked every year, and this was the same this year as well. Apart from that, medicine was integrated hugely with physiology, with pathology, with biochemistry. Uh, Core one-liner based medicine was relatively less, which is again not unexpected. This is the thing we have been going forwards. First year subjects had a good weightage. We know that first and second year subjects are heavily asked in INI-CET exam, so no change over there. Next step, best step, what is the next investigation to do, what is the next step in your management. Trauma, there were a lot of questions on this. So surgery is again scenario based, protocol based surgery questions were asked. Ophthalmology, I don't think a single student has messaged out of the 10 or 12 students I was able to talk before we made this slide. Not a single student out of them, including one of them who got a rank within 10,000. That student, that girl also said, sir, Optha had a lot of bouncers. So Optha was very tough. Magnification factor, calculation kind of questions were asked on ophthalmology. Three ECG questions were there. Rahul sir will talk about them. Dermatology, there were heavily asked on vesicobullous MCQs and image-based questions. There were two physiology graphs. ENT was relatively routine level and relative weightage was slightly on the lesser side. Image-based questions were there on imaging. Khaleel sir will be talking about it. Milestones, red flag signs were there. Refeeding syndrome was there. And some of the relatively easy questions, questions which will not register, but the answer is easy to mark. Those kind of pediatric questions were there. There was some integration in pediatrics as well with other subjects. And as I said, mechanism of action of new drugs. There were at least 2 to 3 new drugs asked. One of them was resmetirom. So overall, it was a moderate to difficult paper. At the same time, the exam is not easy, and this is something that we expect. Was it unsolvable? Definitely not. If there is something you have never read before, and if you have left out that thing, avoiding the negative marking, yours attempt is somewhere in the range of 180, and you feel that about 130, 140, 150 you have done well, and remaining you have taken intelligent guess, my advice to you, you are very much in the game. After this entire session of 10 to 15 minutes is over, please don't go anywhere. We will be one by one, all the faculty members at DocTutorials will be coming, and rapid fire in a blitz way, we will be discussing individual subject recalls in the same very session. So over to you, Rahul sir. Please share your views and please ask other faculty also to share their what input they are getting.
Yeah. So, sir, I completely echo your thoughts regarding the exam. And sir, for me, I felt that students, they told me that quite a good number of assertion reason based questions actually came. Now, that was definitely a highlight of this exam. Assertion reasons, which were multiple in number. And also, I think orthopedics, a few students told me that orthopedics questions were a bit tough. Again, as I said, sample size is small as of now. But I'll just quickly take you through a few topics and from medicine. And one question I want to tell you is regarding the focal seizure related to piloerection. And I was happy that that question came because I told in class a case scenario, an actual case scenario based on this. It's the first time that question has come for INI CET, but if you've attended the lecture, you've got it right. I told you about temporal lobe seizure with piloerection. Resmetirom. I told in class, I'll just put a snippet of that as well. I told in this class that this is going to be an expected question on the mechanism of action. Then Cushing syndrome investigation, quite expected. Look at the topics. That's what I want to tell the students. Tubercular regimen, mechanism of action, amyloidosis related, tremor in Parkinson's disease mechanism, pheochromocytoma, then complete heart block, antibody association. Then I think there was a question on renal calculi, atrial fibrillation ECG, again, quite expected. A question on the inferior wall ST elevation MI and the blood vessel involved. This again, we have discussed in class. Question on neurofibromatosis, calcium metabolism, complications of blood transfusion, again, very important. And often I think Vandana ma'am also in her class also, she always mentions about this particular topic, and that also has been asked. Again, another question related to the complications of systemic sclerosis as well. So overall, if you see the medicine questions, most of them are from expected topics itself. Okay, now I would be interested in knowing from you students, again, we are collecting the questions because see, the merit of the question also will depend on, is it single response type or multiple response type. A couple of students who actually messaged me said that, sir, I wrote the November exam, but their elimination was a bit more easy. But here, since the options were a bit confusing, I was not able to eliminate easily. So, I've got to wait for the other options as well to see, how tough the question was. Because just based on the scenario alone, you cannot give the merit to the toughness of the question. So that's what I am also expecting from the students as well. So this is what I want to tell you with regards to medicine. Decent representation, expected topics, quite a few new questions, but luckily, we were able to discuss that in class. And yeah, that's it about medicine. And OBGY, I think we'll hear from, Dr. Gayathri. Dr. Gayathri, what do you think about OBGY questions? Any feedbacks that you've got from the students so far?
Yes, sir. This time, as compared to the previous November attempt, the students told that the paper was easy to moderate as such in Obs and Gyn. And comparatively, last time, when we compared the November attempt, the relative number of questions were less. We got nearly 11 to 12 questions last time. This time, there was fair representation from Obs and Gyn as well. Nearly, I could get nearly 20 up to 20 questions. And there was fair representation from Obs and Gyn also. And mostly students were telling it was more clinical and both factual questions were there. I would say, as compared to what I have been getting feedback regarding other subjects, the question has been easy to moderate. We'll be going deeper into the topic wise division as well in the upcoming video, where we'll be discussing all these questions individually.
Okay, ma'am. Thank you so much. And Khaleel, sir, radiology, short and sweet subject, but again, definitely can be rank deciding.
Yes,
sir, what about
yes,
the questions, expected areas? How was it, sir?
yes, sir. Yes, sir. Good afternoon, everybody, and good afternoon, sir, and all the faculty members. And the exam definitely was a moderate to difficult exam this time. And the many students after the exam must be feeling, some of them may be actually confident, some of them may be, confused, and it is normal feeling to have. The overall result depends on how everybody has performed. So need not panic, take a deep breath, relax now, and take the recall to understand the trend of the exam. And what I have seen with related to radiology questions is from direct questions, it has shifted to critical thinking and decision making. They're asking the sequencing of imaging. They've given all the investigations, which investigation would you do first and followed by next. There's the contrast safety has increased. The question on contrast safety has come up, and there has been questions on some image based questions. MRI images have been asked, and some decision making, pediatric imaging. What would you do first? Just X-ray, CT scan, okay, or you would go for even TB is fine. So a lot of weightage has been given to HIV and TB also, the routine topics, but the trend is more conceptual. And I think if you have done the classes well, and if you're developing the conceptual thinking, don't expect straightforward questions now. Conceptual critical thinking is important, especially for exams like INI-CET. And pretty much we had around 5 questions in radiology, and most of them were asking the image sequencing, to pick up which age group or which renal function test the contrast agents would not be safe. They'd ask you about ultrasound image of appendicitis and what would your management be. If a patient with a loin pain is coming, what would your order of investigations be? So these were some important tested topics, and I hope our students have done well after these sessions. And I believe this should be just a baseline preparation for upcoming NEET PG. So don't get too disappointed or too worried if you have not done the exam well. This is not something you should be taking it forward. The NEET PG exam is very nearby, so I think if you can just learn from the mistakes from here, understand where you have to put in more effort and focus, a more important exam is coming very soon. Yes, sir.
Sir, and one thing I want to tell all dear students, because I can see good number of students have joined us for this recall, and let me just tell you one thing. See, in case, if you feel that you have not done well, I still would say that you have got to watch this recall session, and that is for a reason. Because you have got NEET PG exam coming up. Now, you've got sufficient time to make corrections, but you need to know now, where have you gone wrong? Are you weak in certain subjects? Or is there a mistake in the way you're thinking? Because in the actual exam, your thought process is also very important. Okay, it's not just about learning, understanding. how you apply your mind during the exam is also very important. So every student listening to us, don't panic thinking that, look, if I listen to the recall, what if I get questions wrong? Then what next? Look, you have got to correct your mistakes. And I know that some of you might crack the INI-CET. They would be interested in knowing the answers. They would be interested in knowing the scores. But even for our children who have not done well, I would still suggest listen to it just with a calm mind. Analyze where you have gone wrong. Look, these are the subjects that I feel I have not done well. I've got to take corrective steps. So when faculties discuss questions and they tell, okay, these are the areas where you'll have to focus, maybe your perspective also gets refined. So that's what I would urge each one of you. Just watch the recall with a calm mind, okay? And don't be too critical on yourself. Sometimes what can happen is that, look, you might have made careless mistakes. Obviously can happen. If your revision has not been that great, you can have scenarios where you got stuck with two options. And just want to tell you that, look, that happens in the heat of the moment. And don't be too critical on yourself. And you please make some corrective measures as you move forward to the NEET PG exam. So don't put yourself under too much of pressure, because sometimes I see that watching the recall session can stress you even more than the actual exam per se. So that is upfront what I want you to understand before we start the recall in a very short while. We are just a few minutes away from starting the proper recall session. But again, we'll have Vandana ma'am as well joining us. Vandana ma'am, I hope you're live here.
Yeah,
Yes?
yeah, I'm here.
Yeah, ma'am.
Hi.
So, ma'am, what is your analysis, ma'am? I'm sure that you would have got feedback from the students. So, according to you, was it a typical INI-CET paper, and pathology questions, especially, ma'am? How were the questions?
So, hi everyone. Thank you, sir. Thank you for this. And I feel it was a moderate difficulty, as everyone has already told. But so there was a lot of tricky questions which were there. Some questions at this point of time might look very simple, like PSTN question was there, but there might be some hidden clues which we need to see to identify who is actually, correct. So there were a lot of questions on the stain color. So there was 4 questions from the Jinx question, which if you were able to see that PDF that I posted yesterday, there were 4 questions directly from that. One, mass and trichrome stain came, MI came, neutrophils came, CRISPR image came. That was very important. And HPV was a predicted question. It came. So there were 4 to 5 questions from that. But apart from that, I think there was a lot of images which came in pathology this time. And so the most important, if you have learned the concepts well, you would be able to answer. There were previous year topics. There was no googly there. I feel 1 or 2 questions was there which students are telling. Some that paraffin protein question which some students are telling. We are yet to get the options on that. But yes, overall it was an okay question, and there were rare topics also that was given. Rare which you like prostate question came, Gleason scoring, or some mandibular gland image came. So there were some tricky image based questions and tricky options, but they were not tough. They were tricky, I will say. So that's all I think you should hear. Recall, it is important for your NEET PG, and these small things will change the rank. But yes, finally the exam is finished, and I am sure you will be relaxed now. So stay cool, stay calm, and I am sure all of you will learn a lot from the recall session, which is going to start next. Thank you, sir. That's all.
Okay. All right. Thank you so much, ma'am, for joining. And just looking at the comment section as well. And we are actually looking at your comment section. So in case you have got inputs regarding the questions, please feel free to ask, especially, questions that had, multiple correct, especially those questions can be tricky. And please do actually mention that in the comment section as well. And if somebody can actually let us know that, approximately how many number of assertion reason were there. From what I get from students, approximately 10 is what I understand. Can you just confirm that? 10 is what I understand, correct? Right. Okay. So yes, I think, most of you must be eager to start with the recall questions. So I think we can start with the subject-wise recall questions. So you can stay tuned in the same channel itself. We are very soon, in a couple of minutes, starting with the first recall. I think we'll be starting with the anesthesia recall up front. So all of you, just stay tuned. Madam is joining in just 1-2 minutes, and we are starting with the recall session. So we'll be having one by one. We'll be having first anesthesia, and then in an order, we'll be having subject-wise recalls. Okay, so as I said, don't panic. Don't be too critical on yourself. Just listen to the recall, okay, with a calm mind. Okay, right. Let's try to correct our mistakes, in case the exam did not go well. So I'm telling from that point of view, because those students who have done well, they might be feeling comfortable, but I know that the majority people, they'll be anxious on, what lies ahead. Just a few months for NEET PG. Don't worry, we'll correct the mistakes and improve. Okay, so anesthesia recall coming up shortly. Okay, right. Don't go anywhere.
Hello, everyone. So let us start the question discussion, and I hope you had a great exam. My best wishes for your result. Whatever you have given the exam, be confident. You definitely will have a rank. So let us start with the few questions that I got of anesthesia. Now, first question from a very predicted topic, which we repeatedly say, complication of anesthesia, perioperative malignant hypothermia. So a 45-year-old undergoes surgery for parotid swelling under GA 10 minutes after induction. Rapid rise in EtCO2. So rapid rise in EtCO2, increasing body temperature, tachycardia, hypertension. These two are enough to make a diagnosis malignant hyperthermia, right? So patient most likely diagnosis is malignant hyperthermia. So in chat box, anyone can put anything which is there on the screen of this question was not there. Not NMS. No, no, no. This is a perioperative complication, right? It cannot be neuroleptic malignant syndrome. Neuroleptic malignant syndrome, they have to write it. That patient was on long-term antipsychotic. This is the patient is undergoing surgery under GA, any inhalational anesthetic, even if it is not mentioned, we will assume it is. And patient has rapid rise in EtCO2, increased body temperature, tachycardia, hypertension. It has to be malignant hyperthermia. It cannot be neuroleptic malignant syndrome. Okay, next question. Regarding the hemodynamic effects of halogen anesthesia, which of the following statement are correct? So regarding halogen, which is the correct statement? So on cardiovascular system. So two things about halogen cardiovascular system we have to remember. Halogen causes myocardial depression. It causes dose dependent decrease in blood pressure, and it sensitizes the myocardium to catecholamine and can cause arrhythmia. So let's see the options. Okay. Halogen causes direct myocardial depression, reducing cardiac output. This is a correct statement. It causes a reduce in cardiac output. It causes reduced myocardial depression by decreasing the heart rate. It causes decrease in cardiac output. It decreases the SA nodes activity. Blood pressure initially falls after induction and subsequently plateau at a lower level. So let me just put a dot on this and then I'll come back on this option. Blood pressure progressively decreases throughout the surgery, irrespective of anesthesia depth. Now, blood pressure would fall more if the depth is more, because dose dependent decrease in the blood pressure. More the dose, more the depth, more the decrease in blood pressure. So this is wrong. Halogen increases the myocardial sensitivity to catecholamine, increasing arrhythmia risk. This is also correct. So 1 and 4 is for sure correct. 2 can also be said correct. So because if a fixed dose is given, initially there is a fall, and then if we don't increase the dose, there could be a plateau, right? So this can also be correct. So 1, 2, and 4. 1, 2, and 4. So let me see in the option. Okay. They give A, B, C, D as option 2. No, if they gave A, B, C, D all as an option, then blood pressure progressive decreases throughout the surgery, irrespective of anesthesia. Depth is wrong. If the depth is less, the blood pressure will not fall that much. It is dose dependent decrease in blood pressure. Dose dependent fall in blood pressure was there. Okay. Yes, if dose dependent decrease in blood pressure was there, it's a correct option. If this was not there, and if it was that it causes dose dependent decrease in blood pressure, if this was the statement, then this is also a correct statement, right? Then it would become 1, 2, 3, 4 if it was there in the option, right? So what I'm trying to tell you, just the effect of halogen on cardiovascular system, it causes decrease in cardiac output by causing myocardial depression. It has dose dependent decrease in blood pressure. It increases the sensitivity of the myocardium to catecholamine, increases the risk of arrhythmia. And if we don't increase the dose initially when we give, there is a fall, and there may be there would be a little plateau till we further, if we increase the dose, the blood pressure will decrease, right? What about it, ma'am? So in this option which I have been provided, 1, 2, 4 is correct. But in 3, if there is a dose dependent decrease in blood pressure by halogen, it was the statement, then that statement is also correct. Fourth statement about baroreceptor activation. Baroreceptor activation. Halothane inhibits all inhalational agent inhibits the autonomic reflex response. So they inhibit the autonomic reflex response by decreasing the SA nodes activity. So if baroreceptor reflex something was given, it inhibits that baroreceptor reflex, right? Okay. What was the? Okay, got it. So next question. Which of the following drug does not cause respiratory paralysis, depression in overdose? So which does not cause respiratory paralysis or depression? Most of the IV anesthetic increase dose, more respiratory depression. Dose dependent decrease effect on the ventilation happens. More the dose, more respiratory depression. Phenobarbital is a barbiturate. It causes dose dependent respiratory paralysis. So in overdose, it will cause respiratory paralysis. So this will cause respiratory paralysis. This cannot be the answer. Opioid, more the dose, more the respiratory depression. So this cannot be, because not is in the option. Thiopentone, more the dose, more is the respiratory depression. So this cannot be the answer. Now answer would be ketamine. Ketamine to some extent does not, let's say, to some extent, it maintains the respiratory drive of the patient, right? Respiratory drive of the patient. So if these 4 were the options, ketamine would be the answer. That following drug does not typically causes respiratory paralysis, depression in overdose, right? Okay. Acha. Gelsemium, barbiturate. Barbiturates, that is phenobarbital and thiopentone, both are barbiturates. This was not the question. Okay, what was the question? Okay. 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 So some students are saying that ketamine was not in the option, and phenobarbital was not in the option. Opioid and barbiturates were in the option. Both opioid and barbiturate causes dose-dependent respiratory depression in overdose. Dose-dependent respiratory depression, right? Okay. Next. During lumbar puncture, the following structures are pierced. So lumbar puncture, that is for spinal anesthesia. Following structures are pierced. Okay. So first is skin, then subcutaneous fossa, then supraspinous ligament. So this is the first one here, 5th. Then interspinous ligament, that is the 3. Then ligamentum flavum, that is 1. And then your dura mater, that is 2. And then arachnoid mater, that is 4. So 5, 3, 1, 2, 4. 5, 3, 1, 2, 4. 5, 3, 1, 2, 4. Right. So 53124 is the first option. 53124 is the first option. So these were the questions which I got, right? So there may be some differences in the questions which we will come back with more, let's say, more better options if you will contribute. Can anyone tell me, was there any question on CPR? Was there any question on CPR? Any question on CPR? Okay, subdural space and arachnoid space was there in the option. So lumbar puncture is arachnoid space, subarachnoid space. Lumbar puncture is subarachnoid space. Okay, wait. Okay. Rishu, I will listen and incorporate. Can you give me? Yes. Capnography, there was a capnography question on capnography. ATLS question, primary ATLS. Give me the question. Give me the question. Capnography, what was the capnography question? Epidural also. What was the question on epidural? What was the question on epidural? Or the same question, the epidural space was mentioned. Don't write just ATLS or like this. Give me the question. Overdose was not there. There was option strychnine and okay. Strychnine and gelisamine. Strychnine and gelisamine. Okay. Let me write it. Okay. Strychnine. Okay. Strychnine and gelisamine. Yeah. Okay. And any question on ECG? Now, strychnine causes respiratory paralysis on overdose. Strychnine, in the second question, if you're saying that which causes respiratory paralysis, strychnine causes, if strychnine was in the option, strychnine was in the option, it causes respiratory paralysis. So barbiturate causes, opioid causes respiratory paralysis, barbiturate causes, strychnine causes. So what was the fourth option? That would be the answer for this. That would be the answer for this. Order of breathing circulation and controlled breathing in disability. Acha, ATLS management order. If the question was on ATLS management order, A, B, C, D, E. So A would be the airway, whatever. Airway secure would be the yes. Airway secure would be the first. Then the breathing, and then the blood loss, the circulation, and then neurological assessment, and E was exposure. Okay. The strychnine would cause respiratory paralysis. Okay. Gelsemium. I don't know about it. Airway management, circulation, disability, compression for devastating bleeding. Okay. Yes, airway management would be first. Then, yes, then would be the breathing. Okay. Circulation, compression for devastating bleeding. Now, circulation and compression for devastating bleeding will come after one another. And then your neurological. Okay. Arrange the order in airway and spine stabilization and massive hemorrhage correction and controlled blood loss. Okay. Spine stabilization would be first, then airway, then the control of hemorrhage, the catastrophic blood loss, yes. Then disability. So spine stabilization would be first, then airway, then control of hemorrhage, and then disability. So I will incorporate this question. Massive bleeding is one step. Control of massive bleeding is, okay, control of hemorrhage I have taken in one step only. In circulation, that will come in C. No, catastrophic bleeding, airway, disability. Yeah, it will be like this only. Spine, airway, control of hemorrhage, and then disability. Right? Catastrophic bleeding and hemorrhage दोनों था. Okay. Patient on anesthesia with elevated capnography and elevated temperature. That would be your malignant hypothermia question. Okay, ketamine wala nahi tha. I have taken it. We'll try to find the better options for that question. Okay. Okay, guys. So these were the 4 questions which I got. So thank you so much. My best wishes. I will try to, whatever you have given me the feedback, I will try to incorporate it in my options and make it and bring it the better questions again. Okay. So over to the next subject. Thank you so much and best wishes for your rank.
Hello, my dear students. I hope all of you have done very well. And in forensic medicine, very well. And in forensic medicine toxicology, it is very easy. Definitely, I think you have done all 10 to 12 out of 10 to 12. You must have got. Okay. Let me discuss one by one in brief. What is the ideal depth for the pigment deposition in this image? Image, you can see the tattoo. Tattoo know very well. If it is in epidermis, it will fades off by tear and wear and tear. Meantime, if it is deeper layer of the skin, it will be taken away by the phagocytosis. If it is beyond the skin, only the muscles can see. So answer A, superficial layer of dermis is the best answer. Okay. Number 2, match the following. Carbon monoxide. All of you know very well, it gives rise to cherry red discoloration of postmortem lividity. Midpoint pupils with lot of secretions are seen in case of organophosphorus poisoning. Cyanide gives rise to bitter almond smell, and phosphorus give rise to garlicky odor. All these are very easy. So answer is A2, B4, C1, and D3. Number 3. Burn injury to the face and head in case of bomb blast injury is categorized under, there are 5 different category of bomb blast injury. Primary blast injury is because of the shock wave where you get rupture of the tympanic membrane. By the flying missiles, the injury is known as that a Marshall triad, that is secondary blast injury. Blast wind throws away the person and he may hit against the tree or on the ground or against any building. That is tertiary blast injury. And quaternary blast injuries are due to the flame or by the inhalation of any toxic gases or any other crush injuries which are not categorized under primary, secondary, and tertiary. Finally, quinary or late effects like biological bomb or radiation bomb. Okay, so here the answer is quaternary blast injury. Number 4, identify the injury. Of course, I don't know exactly the picture. We don't have a pose. Okay, what I got from recall is there is a stab wound over the abdomen. And anyway, time you see an injury, suppose if it is caused by a point sharp weapon,
Recording in progress.
Good afternoon, sir.
Good afternoon, Vinod. Just sharing the screen. I think it is visible.
Yes, sir. Sir, actually, JP sir has some internet issues. Shall we go for live meanwhile?
I've got very little questions for so far, but let's do it. No problem. I think we should not break the flow. Students will go. Hello, Vinod.
1 second. Sir, yes, sir. We'll wait, sir. We'll wait. Sir, please unmute yourself. We'll wait, sir.
Vinod, is sir coming?
Yes, sir.
Because we are losing students. All students have gone to other YouTube videos.
Let's start. Vinod? Let's start.
Please start.
Okay, I'm extremely sorry for the power cut. Now let me continue. The next question, number 5. Identify the range of pheromone. And here, you know very well, you can only see the wound of entry with abrasion color, maybe grease color not visible. There is no tattooing, no blackening, no burning, no singeing, nothing. And only abrasion color with wound of entry is seen in distant shot. If you see the tattooing, it is intermediate shot. Along with that, if there is blackening, it is near shot. Along with that burning, it will be close shot. And muscle impression or cruciate shape is contact shot. And here, it is very straightforward image. The answer is distant shot. Number 4, 6. A man from Afghanistan came to India. He's a drug dealer and came with the toxicity. features and image is given. You can see the multiple threads inside the abdominal cavity. It is an X-ray. Even CT scan is the best to rule out body packer syndrome. All of you know very well. It is body packer who swallows the illicit drugs in his abdominal cavity, abdomen to conceal the drugs. Body pusher means who conceal drugs in rectum or vagina or both or maybe nasal cavity or maybe sometimes in the mouth, that is body pusher. Body stuffer is hurriedly swallows or conceals illicit drugs in body cavities as a desperate attempt to hide evidence to avoid arrest. So answer, this is also very easy question. Body packer, also known as mule, M-U-L-E. What is the antidote for opioid? Absolutely 100% easy question. The answer is naloxone. Methadone is used in opioid use disorder. Flumazenil is used in benzodiazepines. Oxams, organophosphorus. One of the following is used in case of organophosphorus poisoning as cholinesterase reactivators. That is also a very, very easy question. The answer is oxams. Okay. Number 9, sparrow-feet lacerations or sparrow-feet injuries or dicing injuries may be seen in case of road traffic accident, especially in case of driver and front seat passenger. Because of the broken windshield glass, the small dices may fall over the face wherever it is uncovered by the cloth. It may give rise to multiple small superficial laceration known as sparrow-feet laceration. And number 10, a 16-year-old girl with history of abdominal pain comes to the hospital. Ultrasound revealed 16 week of gestation. What you are supposed to do, as you know very well, you have to inform all cases of penetrative sexual assault, whether it is under POCSO Act or even if she is an adult. But this comes under POCSO Act. You have to inform the police. FTP can be done by the opinion of one doctor, of course, till 20 weeks. One doctor's opinion is sufficient. Preserve the fetus for DNA analysis. Yeah, in case of MTP, you have to preserve the fetus so that he can have the DNA analysis along with the person who is accused of having sexual intercourse. Consent of the parents is required for medical legal examination. You know very well. Minimum age of a girl to give consent for medical legal examination is 12 years, but only general physical examination. PV and PR should not be done. So here the best answer is D. But parvaginal and parectal, you have to take consent from the mother. Otherwise, general examination, everything he can do. And regarding 10 questions in forensic medicine, wish you all the best. Thank you.
I think we are live. So, a very good afternoon to all the students who have given the exam. I'm Dr. Sandeep Sharma. I'm the pediatric faculty at DocTutorials. And before I start with the recall, because the exam has been held just now, so there will obviously be more questions coming in. And once the questions are there, a detailed recall, a more correct recall, reference-based recall, we will be coming out. But the purpose of this recall is many of the students who have taken the exam, they are anxious and they need to know where exactly the things stand for them. And we also need to connect with them in some way, and we need to make sure that they understand that this is where the questions were asked, and this was the general overall pattern. Again, because the question answer depends upon the exact recall, one change in the option or one change in the sequence or one except getting added or deleted will change the answer entirely. This is not me talking. This is entirely based upon what many of you have shared with us. Again, previous year topics are more important. Without wasting any time, I will take just 6 or 7 minutes to finish off the pediatric questions. So let us start with first question. Which of the following is a common cause of meningitis in infants younger than 6 weeks of age? To help you out, I'm also opening up my YouTube comment section so that I can see if you are able to help me out with better answers or not. So which of the following is a common cause of meningitis in infants younger than 6 weeks of age? Remember, when less than 2 months of age, meningitis in newborns is mostly caused by group B streptococcus, gram-negative bacteria like E. coli and Klebsiella. Sometimes you have Acinetobacter. Apart from that, you have Listeria monocytogenes. Remember that Listeria is a common cause of meningitis less than 2 months of age as well as above 80 years of age. And thirdly, in patients who are having T cell immunodeficiency. T cell immunodeficiency. If they had asked a single correct answer, the answer will be Listeria monocytogenes. You need to understand that Streptococcus pneumoniae and Neisseria meningitis are not common causes in infants younger than 6 weeks of age. If single answer was there, I'm answering according to what was mentioned. If single answer was there, the correct answer is C. If multiple correct options are there, then the answer will be C and D. And if you say that one of the options was Staph aureus, then Staph aureus will also be the answer. That is C, D, and E. Why? Because Nelson, there is a table given. When I take a detailed recall, Nelson 22nd edition talks about the common causes of meningitis in newborns and below 6 weeks of age. And there Nelson mentions that Listeria monocytogenes as a cause, it mentions H. influenza as a cause, it mentions Staph aureus as a cause, along with E. coli. So I'm writing, if it is less than 6 weeks of age, the correct answer will be E. coli, Staph aureus, H. influenzae, Listeria monocytogenes, Klebsiella, and Acinetobacter. Acinetobacter, right? So based upon this, I'm putting a star here. Whatever was given in the question, you people are better judge. You can change the answer correctly. My hands are limited by the recalls I'm getting from the team. So E. coli, Staph, H. influenza, Listeria, Klebsiella, Acinetobacter, these are the 6 important causes. Streptococcus pneumoniae will not be the answer. Neisseria meningitis will not be the answer. You have to take C, D, and E. That is Listeria monocytogenes, H. influenzae, and Staph aureus if there was a multiple correct option kind of question, right? So it depends how many options were given to you and what was given to you. I have given you the explanation. You have sit in the exam for your own marking. You see what was given and what did I mark. If I am in your place, I will mark Listeria, I will mark H. influenzae, I will mark Staph aureus, right? If any 2 options of these were given, I will be marking 2 options out of them. And if combination was given, you have to look at the best combination of options given to you. You need to understand again, this is just the exam has just been done. The exam has just been done. So we are sticking to it. Let us move to the second question. A child with Dravet syndrome on multi-drug anti-seizure therapy is being trained for fenfluramine. Now, Dravet syndrome is a pediatric syndrome which is characterized by low IQ, developmental delay, refractory seizures, and fenfluramine is one of the second-line agents useful in them because the traditional anti-epileptics do not work. It is a tough question. It is a very tough question, and it is integration between pediatrics along with pharmacology. So the child has been planned for starting on fenfluramine. What side effect profile you need to watch for? The answer to this question is B, serial echocardiography. Why? Because fenfluramine is considered to be a 5-HT2B agonist. It has serotonin agonist action 5-H2B receptor, and because of that, it has a tendency to produce cardiac valvular disease and pulmonary artery hypertension. And because of that, these patients require echocardiography. Any patient, especially young children, because young children's the valvular size is less and the pulmonary caliber of the vessels is less, they develop valvular disease and pulmonary artery hypertension relatively faster, and they need echo at baseline whenever you are starting the drug. Plus, you need to do it every 6 monthly till the drug is given to the patient. And the last echo should be done, if you have to taper or move to some other drug, then you have the last echo should be done about 6 weeks after the last dose of fenfluramine. So correct answer to this question is B. Moving to the next question, a child presents with fever, altered sensorium, and signs of meningeal irritation. Cerebrospinal fluid analysis. LFT monthly will not be the answer. Dear friends, LFT monthly will not be the answer. If stiripentol is being given as a co-administration, then you have to consider LFT. But for a patient on fenfluramine, the better answer will be serial echocardiogram. Again, I'm assuming this is a single correct answer. Next question, which a child presents with fever, altered sensorium, signs of meningeal irritation. CSF analysis shows lymphocytosis, high protein and low glucose. If this kind of pattern is given, the likely diagnosis in the patient is tubercular meningitis. Tubercular meningitis is the most likely possibility. The answer to this question is tubercular meningitis. Moving to next question, a child presents, this is a repeat INI CET question. This is a repeat question. A child presents with prolongation of jaundice, umbilical hernia, and hypotonia. Which of the following is likely diagnosis? Prolongation of jaundice, umbilical hernia due to reduced tone of the muscle, and hypotonia is there. This is congenital hypothyroidism, also called as cretinism. Congenital hypothyroidism is the most likely possibility. Next question, a child had normal development milestone till about 6 to 8 months of age, after which there was a progressive decline in language, social interaction, and adaptive behavior. There was loss of eye contact, repetitive hand clapping or head wringing movements, slowing of the head growth, which is the likely diagnosis. Everything fitting into Rett syndrome as the likely possibility. In case of Asperger syndrome, regression of milestone does not happen, although they can have reduced language milestone and lack of eye contact. Down syndrome again will not have neuroregression, and childhood degenerative disorder is the first one to be ruled out because that does not manifest like this. The answer to this question is D, that is Rett syndrome. Moving to the next question, a 20-month-old child walks without support, scribbles and obeys commands appropriately, but speaks only one meaningful word. What is the most appropriate next step in management? If you have gone through the recall, this table I had discussed in my classes also, in the CPR session also, and in QRP session of DocTutorials, and it is there in regular videos. It is there even on the recall section. This table says what is the milestone and what is the upper age by which it should be attained. If it is not attained by the upper age, the patient requires detailed evaluation and possible pathological assessment. So if you see, speaking single words should come by 18 months of age. Upper age of attainment is 18 months. Here the child is 20 months and he's not speaking more than, he's still speaking only one meaningful word. In such a patient, you will suspect isolated speech delay and hearing assessment needs to be performed. The first possibility is hearing loss. It can be partial or complete. Secondly, you will be evaluating the child for hearing related disorders. Many times patients with autism spectrum disorder also have delayed speech delay happening in the patient. So answer to this question is B, that is the correct answer. Again, suspected isolated speech delay and performing hearing assessment, B is your correct answer. Autism will not be the answer to the previous question. And for those who have mentioned, related to the previous question. Moving to this question, again, it is a indirect repeat question. It is an indirect repeat question. A 6-year-old child presents with oliguria, hematuria, and hypertension. Renal biopsy findings are shown in the images. Immunofluorescence reveals coarse granular C3 deposits, and there is subepithelial hump-shaped deposits. So subepithelial humps, and the photograph also very characteristic of post-streptococcal glomerulonephritis, everything fitting into the diagnosis. PSGN. PSGN is your correct answer. PSGN is correct answer. If the baby had normal hearing, again, the normal hearing is intact, will again depends upon what question has been given to you. If in this question they say that hearing is normal, then you have to assume isolated speech delay, and isolated speech delay will require referral to a speech therapist. And you also need to perform neuroimaging in the patient. Again, because the other two options are not there, this child reassurance will not be the answer. 100% you can be sure reassurance is not the answer. The other two options, we have to see what the options were. If you say that hearing assessment was normal, then you have to suspect isolated speech delay. It can be benign, it can be pathological. There are so many patients I see in my OPD who are having isolated speech delay. Reassurance is needed, but if it persists, then we have to refer for imaging and a detailed evaluation. Moving to next question, there was one question asked on refeeding syndrome and the electrolyte abnormality associated with it. Refeeding syndrome again has been discussed in the detailed videos as well as CPR session. Refeeding syndrome is seen in marasmic children. It is seen in marasmic children whenever high carbohydrate or high calories are given in the rehabilitation phase. This causes disruption of sodium potassium ATPase and causes high insulin surge. And the hallmark in these patients is hypophosphatemia. Hypophosphatemia. If it was mentioned in the question, the answer was hypophosphatemia. The hallmark option, electrolyte abnormality they had asked, hypophosphatemia. If it is not in the option, then hypokalemia and hypomagnesemia can also be seen. Whenever in marasmic child you give suddenly high amount of calorie, all the phosphate goes rapidly inside the cells. This causes a sudden dysfunction of cardiac and neuronal level that is called as refeeding syndrome. The patient can have congestive cardiac failure. The patient can have seizures. You have to give anti-CCF drug. You have to reduce the calorie content, reintroduce it slowly, and you have to give oral phosphate supplements in these patients. If hypophosphatemia was mentioned, then this is your correct answer. Options were potassium, sodium, magnesium, phosphate. If single option was there, then phosphate. If multiple options were there, then answer will be phosphate, potassium, and magnesium. Because in these patients, hypophosphatemia is hallmark. Apart from that, you can have hypokalemia also and hypomagnesemia also. If single correct answer was there, the answer is phosphate. The answer is phosphate. No, calcium will not be the answer. Calcium will not be the answer. And I'm not 100%, I'm 200% correct. We manage these patients, right? And this is a trap. We always ask, which one is not involved? Hypocalcemia is not involved. It is also a super specialty MCQ. Moving to the next question, again, not a feature of Kawasaki disease. 4 options were given. Now, it was a case scenario or a simple one-liner. We are not sure. It is a indirect repeat question from NEET PG exam. It is an indirect question from NEET PG exam, which is not a feature. Purulent conjunctivitis. Purulent conjunctivitis, because in Kawasaki disease, we always see non-purulent conjunctivitis. In Kawasaki disease, we always see non-purulent conjunctivitis. As I'm speaking and talking with you, I have got some additional MCQs in my. They're asking me to add more questions they have added, but there is no way I can actually now show it to you because it has been uploaded. So I'm just adding it here. Other pediatric questions. If there is a maternal mother with anti-Rho, anti-La, or SSA antibodies in pregnancy, what congenital problem which will be seen in the newborn? What congenital problem will be seen in the newborn? The answer will be complete heart block. Complete heart block. Remember, it is a Simple thing, because whenever there are anti-Ro or anti-La antibodies in the mother, they have a tendency to cause damage to AV node. Complete AV node damage happens if the mother has either SLE or mother has Sjogren syndrome, or even normal mother who has some tendency to develop anti-Ro, anti-La antibodies in the pregnancy. The newborn will not get SLE or Sjogren syndrome. The newborn will be born with complete heart block. Some of the options given were TOF, coarctation of aorta, PDA. TOF, coarctation, and PDA are all congenital heart diseases. They are not related to the presence of autoantibodies in the mother. So this is the other pediatric question which was given to you, and this is the answer. Another question has been added. Okay, this is a medicine question they have added. This is a derma question. This is a photograph they have added. So these are the pediatric questions. If you look at it, about 7, 8 questions or 9 questions we have already recalled. There must be a couple of 2 or 3 questions more. So the detailed recall we will all be coming out with, and we will be managing. There is another question. Another pediatric question is there where the baby had hypoglycemia. There was hypoglycemia with blood glucose 38 milligram per deciliter, and the baby was asymptomatic. What next needs to be done? Let us try to see what next is to be done in the question. So whenever you have hypoglycemia, whenever you have, just a minute, whenever you have hypoglycemia and the blood glucose is 38 milligram per deciliter, if asymptomatic, you will give a trial of oral feed. You will give a trial of oral feed and recheck the blood glucose in 30 to 60 minutes. If still hypoglycemic, if the patient is still hypoglycemic, you start IV dextrose infusion in the patient. If giving breastfeed or giving sugar solution or giving oral feed was given, that was your correct answer. If it is symptomatic patient with hypoglycemia, the answer will be IV dextrose bolus. IV dextrose bolus. That will be the answer. So hypoglycemia, 38 milligram per deciliter. This is your correct answer. There was another pediatric MCQ they have just sent to me. Image of caveole macule was there. Some eye findings were mentioned. It was a panel of images with one line mentioned. One of the option was neurofibromatosis 1, and that was the correct answer. So neurofibromatosis 1 was also the correct answer. Apart from that, I have been told that there was also a question on congenital heart disease. So if we try to count how many questions were there from pediatrics, we start from the beginning, you will find 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and a 13th question on congenital heart disease. Out of these 13 or 14 questions in pediatrics, there were about 10 to 11 questions which were core pediatrics, and about another 2 to 3 questions were integrated with other subjects. What it means is pediatrics was doable. At the same time, 1 to 2 questions were very, very tough. How would I label pediatrics so far? Pediatrics, you should have 80% success rate for any student who has prepared well, but he or she is getting a score of about 70% or 60% in the grand test. If luck is on their side and you mark smartly, you can have up to 80 to 90% success rate. The fenfluramine question and the multiple correct option questions were on the tougher side. And there were 2 repeat questions in pediatrics. More detailed recall I will be putting up as the more information and correct options come to us. Thank you so much, and I hope all of you do well. Fingers crossed. I'm praying for all of you. May the best man, best woman win, and may God bless all of you. And please carry on the momentum for NEET PG exam. I hand it over to my other colleague now. Thank you.
Hello, good afternoon, everybody. Let's get started with the INI CET May 2026 radiology recall questions. And the first question we'll discuss here. Please feel free to communicate for any inputs that you have regarding the questions or the options. We'll be happy to involve make them up rectified in the upcoming proper recalls that we would do. The first question: in which of the following patient contrast MRI contrast is contraindicated? Gadolinium-based MRI contrast is contraindicated in which of the following conditions? Remember, gadolinium, this is toxic. Okay, it should always be coupled with DTPA and given to be removed in the kidney. So whenever you have poor renal function test, gadolinium will be contraindicated. And when the eGFR is less than 30, right, it is contraindicated. So let's look at the options that are available. A 30-year-old male without kidney function test, a 60-year-old male without kidney function test, a child with the kidney function test report, a 50-year-old male with GFR 30. So obviously when GFR is good, it is safe. It is safe when the kidney function test is there. It is avoided in pregnancy, but not in children. Gadolinium is contraindicated in pregnancy. It crosses placental barrier. It is contraindicated in pregnancy, but it can be given in children with a proper kidney function test. Among 30-year-old, 60-year-old, if you have to choose a single best answer, a 60-year-old patient without kidney function test would be the correct answer, right? So GFR less than eGFR less than 30 should be the answer. Okay, is this okay? GFR was 50, right? Even then, okay, so obviously eGFR less than 30 should be the contraindication for gadolinium, right? So that is the correct answer here. So answer B would be the more suitable one, right? Next. The next question: a 60-year-old male with low backache has an MRI image given, and he has a history of treatment for tuberculosis. What is the next step of the management? Now, this is a tricky question. They gave an elderly age group, an MRI of the spine was given, and if only the vertebral bodies are involved, not the disc, right? So he's pointing towards lesions involving the spine. It could be multiple myeloma. And already there is a treatment of tuberculosis done, right? So it's just a distraction history of treatment for TB if that is given. So the better answer is to screen for multiple myeloma, right? 60-year-old patient. If only the vertebral body is involved, you look for metastasis to the spine. And to rule out multiple myeloma, you would like to go for serum electrophoresis. This would be if it all is involving the disc only. If it is involving the disc space, right, involving the disc space, a paradiscal involvement, you would like to think of TB spine. But if it is involving the vertebral body only, think of multiple myeloma and rule out multiple myeloma by doing serum electrophoresis. A child came to OPD with upper respiratory tract infection. What is the next step in the management? Now, would you go for CECT of the chest, HRCT of the test, digital radiograph, or no further investigation involved? Now, when you have an upper respiratory tract infection, which is also, not a complicated ones that are given, obviously there is no role of imaging. You need not give radiation. It would not change the management of the patient. So if it is just an uncomplicated upper respiratory tract infection, no further investigation would be required. Next. Coming to another question here. A patient comes with, there was multiple answers in gadolinium question. Okay, so if you can give me the all options, we would go. eGFR less than 30, right? That would be the contraindication. Okay, next thing. A patient comes with right iliac fossa pain for more than 48 hours. Right iliac fossa ultrasound images are given. What is the next appropriate step in the management? And based upon what was seen on the ultrasound image, okay, so if the history is more than 48 hours, you are given a appendicular lump. If there is an appendicular lump, if it was a simple non-complicated appendicitis, you would have directly go ahead with surgery. But once there is an appendicular lump on the ultrasound, the manage would be Oshner regimen, and you go for ultrasound guided drainage only, right? So you would go for an ultrasound guided drainage, image based drainage. Percutaneous and ultrasound, a better is ultrasound guided drainage. Okay, that should be a better one. If pure just appendicitis image was there, you're just seeing the blind ending tubular structure and you're seeing the target sign. Okay, there is no other, but more than right iliac fossa pain, more than 48 hours, the image showing a collection right around the appendix. You're thinking of an appendicular lump, there will be adhesions and omental, and bubble adhesions there. Better to go for ultrasound drainage and rather than try directly going for an emergency surgery. Another question, a HIV positive male, CD4 count less than 40 and presents with headache, fever, focal neurological deficits, MRI is shown, ring enhancing lesion. And some students said that it was mentioned at basal ganglia. So ring enhancing lesion, AIDS patient, less than 40. This answer would be what? This would be toxoplasmosis. So ring enhancing lesion, AIDS patient, and especially ring enhancing lesions. And if the question was also mentioning basal ganglia region, the toxoplasmosis tends to be near the basal ganglia, right? So these were some important questions that came in this. So pretty much but there's a lot of decision making, critical thinking that was being tested. It was not just a straightforward one-liner questions in radiology, but you had to had a lot of decision making to understand which steps to be there. And also there was a question on, I think, kidney stone also. There was one question on kidney stone also. What would you do? Patient with a loin pain, renal colic. And what would be the investigation for that patient? Would you go for NCCT followed by CECT? Would you go for NCCT along with ultrasound? Would you go for CECT followed by NCCT or abdominal X-ray KUB like that? So renal colic, you will go for NCCT, right? Kidney stones, you'll go for NCCT, and ultrasound can be used as a complementary investigation. So NCCT along with ultrasound would be a better investigation when you have a loin pain and you're suspecting renal colic in that patient. So this is, if no image was given and basal ganglia was mentioned, I think answer is more toxoplasmosis. Okay, so if the image is not given and they clearly mentioned basal ganglia in the question, then that answer definitely is what? Toxoplasmosis, a ring enhancing lesion in basal ganglia region, AIDS patient. I hope we have done most of the questions on radiology, right? And I think we'll move on to the next subject.
Welcome, dear students. And else, this is a quick session trying to recall some of the questions which appeared in this exam, INI CET. I have received some of the questions which we'll be discussing, but as you know, the questions are incomplete. We may not have proper choices. So we'll be working upon these questions, and once we get authentic details, then we can move on to discuss them properly. So as you will notice, the very first question which I have received is this one. It is asking us which of the following region of the adult central nervous system is recognized as a site of neurogenesis. Now this appears to be kind of a vague question, and we generally don't focus upon such questions, but as such, if you ask me a question regarding this neurogenesis, I think we will go for dentate gyrus. Now, why? We'll have to move into more details, but here at the moment, because this session is quick, I'll just give you a quick answer, and I still have to do research on the topics. So this is going to be the first question, and second question is identify the marked muscle, which is X. You can see there's a diagram based question, and some aponeurosis they are forming. So as I can notice, most probably they would have asked about the muscle which is external oblique muscle, and which is going to form the inguinal ligament, floor of the inguinal canal. So I'll take my answer as A, external oblique, and which is going to form this floor of the inguinal canal, the inguinal ligament. It is a modification of the external oblique muscle. That is what I can tell you right now. And as we proceed further, which are the following labeled muscle acting as abductor of the vocal cord? PCAM, posterior cricoarytenoid muscle. So posterior cricoarytenoid muscle is the safety muscle or the only abductor of the larynx. Posterior side it is present. Marker A should be the answer. So as we are going quickly through the details, this is going to be the posterior cricoarytenoid muscle, and it is the only abductor of the vocal cord, also called safety muscle of the larynx. Otherwise, you can see this is thyroarytenoid muscle here. You have lateral cricoarytenoid muscle here. So we'll be working upon the details, but at the moment, just the questions and the answers. So marker A, that should be our answer. As we are proceeding further, labeled muscle attached to cartilaginous part of eustachian tube and soft palate. So another question came in the similar fashion previously also. They were focusing upon some of the muscles related to eustachian tube and basically muscles of pharynx and eustachian tube. But if you have the marker like this and telling that it is attaching to eustachian tube and the palate, then I think we'll be better going for levator valley palate. I'll be giving you detailed discussion, but not yet, later. But let us take our answer as levator valley palate and do some more research, get the proper questions, and then the proper discussion will come later. Match the following organs with their embryological origin. That is the question. Thyroid gland, we know, develop at the foramen cecum, tongue, endoderm. So it is endodermal origin. Thyroid follicles are endodermal in origin. If you say adrenal medulla, we understand it is coming from neural crest cells. Neural crest cell will give the sympathetic neurons of adrenal medulla. And if you say kidney, then kidney of course come from intermediate mesoderm, which will form adrenal cortex also, but not the medulla. So in that sense, you can take your answer as A, because thyroid gland is endodermal and the adrenal medulla is neural crest cell, and then kidney is the intermediate mesoderm. So here we can take our answer as choice number A. As you're proceeding further, identify the organ histology image, and they have given some names. If I zoom, I can see they are all serous SNI, some duct is given, and though it may not be very evident, but there must be some striations, and striations and duct, striated duct will be a feature of salivary gland. So since it is too many of levator valley palate not given, only tensor valley palate given, that is what I am telling. We don't have proper questions, so that is why we have to work upon the questions. But as far as the question which I got, there I will give my answer as levator valley palate. And in this question, I'll take my answer as the parotid gland, because it is a serous salivary gland with the striated ducts. Cannot be sublingual because it will be mucinous and it will be empty looking cells, washed out appearance. Cannot be pancreas because there is no islet of Langerhans gene, plus pancreas doesn't have striated ducts. And if you say liver, liver will have other things like, of course, you'll have hepatocytes, you'll have sinusoids. That feature is not there. Detailed discussion coming later. At this moment, you keep your answer as I am suggesting, choice number C, parotid salivary gland. No parotid. Now, Supraj Vishwa is telling no parotid. That's what. This is very quick recall, and we may not have proper options available. I'll go into details, I'll find out all the options, then we have proper discussion. But team has given me this slide. Looking at this slide, I'll take my answer as parotid. Otherwise, I got another slide where it was all empty, washed out appearance. So that would be sublingual salivary gland. Then, as I can see, that cell nucleus is at the base and triangular kind of appearance, then the answer would be sublingual salivary gland. So that will be another slide, not this slide. It will be like, there will be cells which are giving a mucoid secretion here, and nuclei pushed to the base and empty looking because mucus give empty looking. So most probably your answer was sublingual salivary gland in that case. Now, as you move further, remnant of embryological hindgut, retrocecal area, and which are the following lesion? Again, a vague question. I really don't understand that what they are trying to ask. Maybe in this question, I cannot actually go into too much of detail. Maybe they were asking about some tail gut cyst or something like that. So I'll have to work upon these questions. It is quite premature to discuss these questions here at the moment. And if you're talking about this organ and their histological feature, that we can do very well. Ileum is the small intestine. It'll have pair patches. If you say let me zoom. Ileum, the pair patches in the terminal ileum, you have this ovoid, transverse oval, longitudinal collection of the lymphoid tissue, that is pair patches. Transverse colon, if you say, then we will go for A, that is tinea coli, that is longitudinally arranged, one here, one here, one here, tinea coli, like tinea is the tapeworm. So like tapeworm type muscles, tinea coli. Esophagus, we understand non-keratinized stratified squamous epithelium, and duodenum will have villi as to increase surface area of absorption. So in that sense, if you are asking, A will be the answer. And center filled with triangular cell. Chordoma, yes, maybe as I see, they have written chondroma, it could be chordoma. So chordoma could be your answer, but I'm not very sure what is this tail gut cyst. So gut is coming, then they are telling hind gut. So I'm having a confusion whether they were asking about tail gut. What is this tail gut cyst anyway? And maybe chordoma. So as I'm telling, we have to work upon the topic. When it comes to this question, they haven't given me the diagram at all. So that diagram is not there. If diagram is not there, then how will the team has not given me any diagram? You can tell me, like, what was it? Chordoma, yes, if you say chordoma, then let us take it as chordoma. And then it is not chondroma, it is chordoma, and there will be some other questions will have different stem then. So as I'm telling, we'll get the proper questions, proper discussion will be prepared. But what about this question? Was it unilateral or was it palate also included? Depends upon what type of question image was there. So accordingly, we can plan our answer. But let me take you to the first question again. And as you look at the first question, the answer is dentate gyrus. I'll give you the details. It is asking adult central nervous system where neurogenesis is still happening. And one of the other place could be, as I can see, but here I'll take my answer as dentate gyrus. Now, when you are looking at this question, it is external oblique making inguinal ligament. That is what I mentioned. And if you are talking about the third question, which muscle is the abductor of vocal cord, then I'll go for here, marker A. because that is posterior cricoid muscle, the only abductor of vocal cord. If you go further, as you are telling, it was not there, tensor, this tensor veli levator was not there, you have mentioned. So tensor veli palatii, maybe that was the answer, tensor veli palatii, that could have been the answer. And this question, as you can see, we already have mentioned thyroid gland, endodermal, adrenal medulla, neural crest cell, and kidney, it is intermediate mesoderm. So in that sense, I'll take my answer as A. And if you are focusing upon this question, you can see that this is, I have given the answer as parotid, but you are telling that it was different kind of appearance and nuclei were pushed to the base. So maybe it was washed out appearance and sublingual salivary gland could have been the answer. And if you are looking at this question, it is asking us about some retrocecal area and related with gut. I'll go with tail gut cyst. I still have to find what do you mean by tail gut cyst, but that will be my answer, not chordoma as you are suggesting. And as you look at this question, ileum, you have pair patches, transverse colon, you have the tinea coli because large intestine, and esophagus, if you say it is non-keratinized stratified squamous epithelium, duodenum, if you say there will be villi. So here I'll go with option A, that is your answer, just the question and answers at the moment. And this I don't know, like what was the question. So depending upon, say whether it is the maxillary process not meeting with the median nasal process, so cleft lip. If it was the lateral nasal process not meeting with maxillary, you may have oblique facial cleft. So it depends what was the question. Retrorectal, it was retrorectal, that is what the cleft lip question was, match the following. So there was match the following, I do not have that match the following here. So what will I match here? And then midline cleft was given. Okay, if it was midline cleft, then you know. Medial nasal process, which is contributed by frontonasal process. Frontonasal process will give one medial nasal process here on the right side, one medial nasal process here on the left side, and there will be a midline cleft lip, which is the, you can say, hair lip, like the hair. Then if you had midline cleft lip, then medial nasal process of either side are not fused, that will be midline cleft. If you're telling it is midline cleft, then medial nasal process of the right and left side, they have to fuse, then only upper lip philtrum formed. So if they're not fused, then hair lip, or what is you calling midline cleft lip. And then tail gut cyst, yes, that is the answer. You are using internet, I am also using internet, but we have to look at the details. So that's all. This is all I have got. And as I promised, we'll find out the exact stem of the question, exact options, and then work upon the options. Then the proper discussion will be uploaded within a week. Take care. Bye bye. And my best wishes for your results. Let us hope you get good results and bring us the happy news at the earliest possible. Bye bye.
So hello friends. So how's the exam and all? I suppose exam was a bit tricky and not so easy what it seems. And obviously these all are recall sessions. I also don't know how much correct recall I have got from the students. But as such, if you have any points to add upon for this, you can add upon in the comment section that this was there, that was not there, and the final one will do later. Okay. So let's have a quick review of the things, guys. The first question, as you can see, a 24-year-old woman presents with high fever, hypertension, okay, diffuse erythematous rash, vomiting, multi-organ dysfunction during menses. So one thing is for sure that it is regarding the TSST1, and which is a super antigen. Okay, which is a super antigen. Super antigen of what? Super antigen of Staph aureus. Now, what is the mechanism of action of this particular one? So obviously, guys, it's a super antigen and definitely MSC restricted. And this class 2 molecules with the T cell receptors leads to what? Polyclonal T cell activation. If these were not in the options, you can also tell that. So these were not there in the option. And what were there in the option exact? That also you can tell. Okay. So the information which I have got that this was asked regarding the TSST1 and how does they act upon super antigen, they come and they bind lateral side of the V beta domain, and that V beta domain leads to the T cell activation and they release the lymphokines and they will release leads to the shock like conditions. Okay. So guys, regarding this, the answer will be B. And if you have anything else regarding this, then do tell me. Okay. Just a minute, I'm like seeing up in the. Okay. So one option was V beta domain of T cell receptor. Hello. Hello, guys. So fine. Acha, V beta option was there. So obviously I'm still like variable beta option. If it is there, then that would be the best answer. But along with that, which is being written off. Okay. Now the second one, underwent splenectomy 8 years ago. Now present with a road traffic accident, fever, hypertension, septic shock is there. Empirical antibiotic treatment was being given up. Which of the following organism, most importantly, is to be covered? So guys, you know that recurrent capsulated infections, they are very common in the splenectomized individuals. So I suppose it was regarding the Streptococcus pneumoniae. Okay. So like in the comment section, you're telling us, Suku, the V beta was there, sir, MSC2. So that would have been the best answer in that question, the first one. And in the second one, it is regarding this Streptococcus pneumoniae. And the Streptococcus pneumoniae, why? Because planet-wise individuals, you cover up the Streptococcus pneumoniae. Why? Because it's a capsulated organism infection. Other than that, in this list, Pseudomonas is there, but more it is towards the Streptococcus pneumoniae. Okay. E. coli was also in an option there. But like splenectomy, all what is there, na? So you need to cover this particular one. And that's why you give the vaccine also for this one. Achha, give the vaccine pre-splenectomy. Achha. This is what is there. That's what. Now the version which is there in the exam doesn't come exact. But still, let's see. See this particular one, the HIV infection presents with headache, fever, altered sensorium. The CSO examination shows budding yeast forms with the unstayed capsule on nigrosin preparation. What is the most likely organism? So capsule is unstained and you're getting budding yeast form. So obviously, what should be the answer of yours? Yes, come to this question, guys. What should be the answer of yours in this one? Soumya, was it a multiple option question or like specifically they aren't want a single answer or what? Then what sort of question it was? So that is also important. Now come to this. We'll discuss them later with whichever they're having some what do you say, controversy. We'll look out for that. So here you say regarding this, it's a clear-cut question, I suppose, and you would have answered a budding yeast forms with unstained capsule and nigrosin preparation. It's towards the Cryptococcus neoformans. If it is budding yeast cells, because it is what is termed as yeast-like. Okay, it is what is termed as yeast-like, or yeast-like is candida actually. And here, if these particular things are given budding yeast cells or no yeast-like forms and all, so it is not towards the candida, it is towards the Cryptococcus and typically associates with HIV. But if it is, what do you say, what sort of question they wants to make it more tricky, so they might give in this only, but yeast-like forms are also observed and all that. But capsule, if it is clearly mentioned up, it is towards the Cryptococcus. And you know it's a true yeast. Okay. Cryptococcus is what, guys? It's a true yeast. So unstained halo. Unstained halo means it is unstained. Okay. And CD4 count is less than 40. You're talking about crypto only, single only. Okay. Okay. Now I'm getting your charts. Okay. Fine, 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 fine. Okay. So answer is clear cut. Cryptococcus neoformans in this. I suppose no confusion. Now this was a repeat only. This one HIV infection, CD4 count 60 cells. I don't know exactly, CD4 count was this only. Chronic diarrhea is there. Significant weight loss, fever, fatigue, colonic biopsy. If it is given up, histopathological image of that sort. Okay. So obviously this is a repeat one in which they have asked regarding the Cryptosporidium parvum. So is it Cryptosporidium parvum? Histoplasma is also yeast, but it is not having capsule, na? Histoplasma capsulatum is not having capsule, Shekhar. So obviously that will not be the answer. Okay. See this particular question, this particular one, Cryptosporidium parvum. Any confusion in this? It is having 4 to 6 micron oocyst, acid fast, shows up auto-infection, and it's very common in HIV positive ones. So I suppose everybody must have marked it at Cryptosporidium parvum. So no confusion in that. And it's a repeat question, actually. It's a repeat question. Previously also, this particular question came. Now talking about this, a sexually active one, multiple painful vesical lesions over penis and scrotum, burning sensations, dysuria, grouped vesicles, erythematous base of the genital region. So guys, grouped vesicles, painful stuff, is a clear-cut indication towards the herpes simplex virus infection, and that too which one? HSV2. Okay. They were round Cryptosporidium. Acha, in that image. Okay, 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 okay. That is not RBC. There might be those stained one. You say, na? So it's towards the Cryptosporidium only. With the history of HIV, it's towards the Cryptosporidium only. So that would be the answer. So HSV2, I suppose that is what is the answer of this particular question, and all of you must have marked it correct as per my point of view. Tourism history, multiple investigations done, and lesion was present. Ankit Kumar is telling. Okay. So I suppose everybody agrees up now. There's a HSV2 or any other with something else wants to come up. And this question also was not being properly given up. The multiple scaly patches of the scalp, itching, patchy hair loss, examination reveals well-defined scaly lesions, broken hairs, tinea capitis. That is obviously a dermatologic stuff. What is the most appropriate treatment? Obviously, it is antifungal. And I suppose it is not being given up with these options for sure. Something must have been different there, that this particular one was given up and all that. Assam question, yes, sir, elevation given. Achha, Assam tourism history was there and multiple investigations done. Ankit, you are telling about which question? This HSV 2-1, you are telling this thing. Yeah, tell. Yes, please. What about this question? Tinea capitis was there or not? No, sir. Asamoah histoplasma. Okay. Okay. Scaly lesion mentioned. Scarring, alopecia, and scaling. So I suppose this more the ma'am in the DMAT will also like take away this question and will explain up what exactly, though you can tell there. Yes. Talking about this, a 40-year-old woman presents with malar, this skin tightening suggestive scleroderma, dyspnea or exertion, fished mouth appearance on the mitral valve, chronic rheumatic heart disease, which microorganism? So obviously this is a straightforward one, Streptococcus pyogenes, and if some twist is there, that also you can tell. Okay. So this is regarding the rheumatic heart disease, molecular mimicry stuff, and this is Streptococcus pyogenes. Group A strepto, which associates with rheumatic heart disease, type 2 hypersensitivity, and rest of all you can yourself can see all. Now, this 6-week old infant remained hospitalized since birth due to prematurity, prolonged NICU stay, develops fever, poor feeding, lethargy, seizures, and the CFS findings suggestive of bacterial meningitis, which is the most likely causative organism. So obviously we know that in the neonatal meningitis stuff, it is Listeria and a group B strepto mostly. And if you have something different for this, like it was not the same question or like that, so you can tell about that also. Okay. Acha, the question was what heart lesion seen, not the organism. Okay. So this is a modification which you get in the recalls that they have asked the organism and all that. So anyways, in this, what you have marked up, if we talk about the recent question, like which you are seeing up on the screen, what exactly like that? The CSF findings suggestive of bacterial meningitis, what is the most likely? Know this question, sir. Acha, this question was not there. You're telling. It was a multiple choice, but not sure of choices. Okay. Fine. So one of these Listeria, other one might be group B strepto written up, and Listeria plus other bacteria. Staph can also do. So like the neonatal meningitis is being the number of bacterias. So E. coli, if it is one of the options, that also associated with neonatal stuff. If it is E. coli and all, if it is Staph aureus, then also it can be accumulated in that. So Listeria along with Staph will be the better answer if these four are the options. Otherwise, E. coli and group B strepto. Now, this is like a good question, which was there regarding the ESBL producing organisms. Which of the following statements are correct? So guys, if we see one by one, the ESBL enzymes are commonly plasmid mediated. Yes, extra chromosomal mediated. The first option is correct. The ESBL producing organisms are resistant to the third generation cephalosporins and aztreonam, but characteristically susceptible to what? Penicillin and cefoxitin. This statement is wrong. They are not susceptible to penicillin and cefoxitin if they are that sort of resistant. Okay, E. coli was not there. Listeria staph. Then Listeria staph would be the answer in that neonatal stuff. Carbapenems have proven activity against the serious ESBL infections and often referred to as treatment options. Yes, very true. Piperacillin tazobactam may be used as an alternative in selected ESBL infections depending on the source, susceptibility, and severity. So that also sounds correct. So answer is first, third, and fourth. Second is not the answer. Acha, 6 months old. Okay, 6 months old. Still, these particular things will be holding up fine. Listeria and staph here. Okay. And this question, the answer is first, third, and fourth. Second is not correct. And I suppose how many of you have done this question, I don't know. It's a tough one. But if you have done this, it's a good one, which you get. Okay. First, third, and fourth. Okay, Dr. Anonymous. Now, this was their 28-year-old woman, greenish vaginal discharge, vulvovaginal irritation, negative AMSELS criteria. You know that, pH of all that particular stuff. Positive whiff test. Some were telling it is a negative whiff test. Whiff test was negative or positive? Anonymous. What was there in this particular question? Whiff test is positive or negative? So this is also a confusion. Whiff test is positive or negative. And fishy odor can be there in the bacterial vaginosis, but you're telling negative Amsel's criteria. So whiff test is negative, na? That's what. So this particular one is wrongly being recalled. Obviously, it's whiff test negative. And we are talking about what then, guys? We are talking about the motile pear-shaped flagellated trophozoite with undulating membrane, and this is Trichomonas vaginalis. Okay, having which sort of a motility? Twitching motility. Okay, so twitching motility. So it's clear cut, I suppose. You must have marked it correct. Then another confusion is regarding this particular image. The stool microscopy image is shown below. So, and somebody was telling like in this fatigue option was also there, and they have given up ankylostoma duodenale egg, but in the options I'm not seeing it anywhere ankylostoma duodenale. Okay, so if it is having this type of a thing like blastomeres attached to this like this, so obviously we are talking about what? Ankylostoma duodenale. So I think none of the options matches this particular one, because in my group I am getting up that fatigue was there. The fatigue might be because of iron deficient anemia. So that fatigue is iron deficiency because of ankylostoma duodenale. And even ankylostoma duodenale is having 4 blastomeres. If this picture is like that, so that mimics that particular one. A barefoot, but simple. Just Marin is saying barefoot, so it is 100% what? Ankylostoma duodenale. So we are talking about what, guys? Ankylostoma duodenale, and that is the hook form. That is the hook form. And you know that these particular fellows, A and S, ankylostoma duodenale, Nicator americanus, and Strongyloides cercoralis. Okay, fine. So, no, not ascaris then. If it is larva penetrating the skin, then it is regarding that. Picture, I suppose, was given up, and picture is of having the blastomeres and all. If that picture is of ascaris, then the things will go towards the transmission, ingestion of eggs and all. Simple enough. I told you this. Okay. The mnemonic for this is EAT. EAT for the nematodes, and ANS for the penetration of the falciform larvae. Okay. So this you need to remember. The option was squint foot penetration. Then it is ankylostoma duodenale, guys. And having the 4 blastomeres and all. And fatigue is a definitely one. Fatigue associates with this. Why? Because fatigue is due to iron deficient anemia, which is being done. Okay. Okay, fine. Got that. Now, this was there. I think this is a PSM question which have come here, but I can tell you this. Epidemiologists studying an outbreak notes affected individuals developed symptoms within a short interval, with incidence peaking at nearly the same time. So at a short stuff, and it is peaking at a short time. This typical epidemic curve is seen in this staphylococcal food poisoning. Okay, staphylococcal food poisoning, and this particular one, incubation period, you know, it is around 1 to 6 hours. Sir, I don't remember the fourth option, but they were wrong 100%. Unfertilized egg and skin penetration. Okay. So this is what the create the confusion. I told you whatever the question is, if it is regarding the ascaris picture, then you have to mark up eggs are ingested. If it is regarding ankylostoma duodenale, then it is penetration of the sole of the foot. And I told you which all penetrates ANS. And what about the those eggs are ingested? In that the mnemonic is EAT. Entropius vermicularis, ascaris, and Trichoris trichiura. Okay. Achha, this is also a wrong recall. Okay. Okay. Fine. So PSM ma'am will able to recall it better. But I have told you with this nearly the same time and all, then it is staphylococcal food poisoning. I am not saying it is correct. Okay, guys. So you are the best judger of this. And if you're telling that propagated epidemic and all with difference of one incubation period, then it is obviously a different one. Okay. So fine. I got that. Regarding this, a 35-year-old with HIV infection presents with headache, fever, altered sensorium, focal neurological deficit, CD4 count have fallen below 100. MRI shows multiple ring enhancing lesions, basal ganglia, corticomedullary, they are involved. What is the most likely diagnosis? Typical case of what? Cerebral toxoplasmosis. Done by Toxoplasma gondii. Okay, fine, smash. I got that. Okay. But they have given me that, so that's why, like I told. Otherwise, if it is not, so rectified. We'll rectify that. Fine. So remember, regarding this multiple ring enhanced rough, this is a typical case of cerebral toxoplasmosis, and in the HIV it presents with seizures, and CD4 count mostly is 40, like below 100. This infection will happen up, and done by Toxoplasma gondii. Definitive host is cat, intermediate host is rat. Okay, it was propagated one. Got your point. Now this was their 9-month-old infant present with intense itching. Skin ma'am will also take it. Multiple papillovascular lesions only in the palm, soles, and periumbilical region. So this is a typical case of Sarcoidosis scabiei. Okay, if everything is given fine. So are you with this question that this was asked regarding the scabies? So this is typical of scabies only, involving the palm, soles, periumbilical region. Intense itching, eczematous, skin changes are there, eczema, and this type of picture. So this goes in favor of that. Is it fine? Or in this also something different was there? Scabies options were there. So it is towards that, and no. Okay, for this also a no have come. But some students were telling that this was there. And guys, like somebody was telling, one question was there, Vibrio cholerae, regarding that Vibrio cholerae is having what? Double-stranded circular DNA, or just the circular DNA? It will not be exactly double-stranded. Excoriation also there, paramelical also there. Scabies only. Anonymous is right, scabies only. Can you tell me regarding this Vibrio cholerae stuff? What was Vibrio cholerae stuff? Circular DNA was being given up, that which particular bacteria is having circular DNA. This was there, and another circular DNA is observed in whom? It is observed in Brucella. The Brucella also is there, which associates with having a circular DNA material. Two circular DNA material, yes, exactly. So if these two options were there, so this also is being done. Okay. Acha, these all options were there. E. coli, Vibrio cholerae, M. leprae. Okay, so in Vibrio cholerae is there. Fine. Any other which you are recalling up? One or two options. 1 or 2 minutes we have. So any else particular question if you're recalling up? Acha, atomic dermatitis. In that particular one. Previous question you're telling, Ankit. Any other guys? Any other microbiology question? Nothing was there from immunology side? Nothing was there for immunology side and all? Anything from immunology and all? So it is only TSST1 and all. Acha, somebody was telling like there was a question regarding diphtheria toxin. So diphtheria toxin, that elongation factor 2. One sterilization image based question was there. Okay. If you can tell, Athar, it is regarding what? Sterilization image based. And diphtheria toxin, ADP ribosylation of elongation factor. Papain and pepsin I used to tell up in the what do you say? In the sessions also, that when the papain cleaves up antibody, how many particles release? That sort of question was there. Tenzin palsum or something else like papain and pepsin. Okay, that was a yes, sir. Sterilization was the image of what? If anybody can tell. So that will also be help in the final recall. So when you cleave up an antibody with papain, how many things are produced? 2 FAB plus 1 FC. And if it is by the pepsin, it is FAB dash twice plus FC dash. 2 are there. Okay. So anything else, if you are there remembering up any confusion or any particular language is being told up wrongly, so you can tell up in the comment section, we'll correct it. Okay. And very best of luck from my side. Thank you so much. Take care. Acha, autoclave was there. Autoclave was there. Fine. The autoclave, what was the question regarding sterilization? Have they asked regarding the biological indicator? What they have asked them in the autoclave? Actinomyces wall composition was asked. Filamentous bacteria. Sterilization in the case of autoclave is 121. How come 100 degree? It is above 100 degree. It is above 100 degree. Actinomyces cell wall composition was also being asked. So I am noting it down. So we'll come back with a proper recall. But as such, yes, we have done like these particular topics are being touched, and it seems like the question seeming something and it was something. So not a very straightforward questions, but some of them, they are do straightforward. Okay. So thank you so much. And let's go with the next recall in the one. Capsule question. Okay. What is the capsule question? Like you're telling Naveen, what was the capsule question? It is made up of what? Polysaccharide. That's what? What?
Everyone, good evening. I hope your exam went well and audio is fine. So all good. Should we begin dermatology recall? Most of the questions were from what we had studied, but yes, they as expectedly rephrased a few questions. So starting with the first one, in which, good evening, I hope your exam went well. And so I hope your exam went well. Was there any echo? I hope not. So coming to the first question, in which layer is the tattoo present? So this is an image of a tattoo that was given, and they are asking in which layer does the ink deposit when the tattoo is made? Dermis, epidermis, subcutaneous layer, or the muscles? The tattoo deposits in the dermis. When the tattoo ink is put, it is taken up by the macrophages, which remain within the skin in the dermis. These are called as melanophages. So this is where the tattoo ink deposits. Now, going to the next question, a 2-month-old infant is brought with multiple erythematous papules, vesicles, excoriations over the palms, soles, and around the umbilicus for the past 1 week. So the question here is telling us that there are papules, vesicles, and excoriations. When it says excoriations, that means the disease is itchy. I always tell you, whenever it says excoriations, even if it does not say any other symptom, you have to understand that the disease is itchy. The baby is irritable, cries excessively, especially at night. So the symptoms increase at night. Similar lesions are noted on the scalp and the face. That means the entire body of the infant is involved. Mother gives similar history of itchy lesions on the hands. What is the diagnosis? So the text here is in itself sufficient to tell us what it is. But let us look at the image. You see these vesicular lesions and excoriated lesions. So we see vesicles, we see excoriation. Some of these are scratched, and we also see papules over the soles. When you see all this, it is itchy. The mother has similar history. What do you think it is? It is bullous impetigo. That would be pus-filled bullae, a few of them, so not the answer. Infantile scabies can consider. Atopic dermatitis will also be an itchy rash, but that will be an itchy rash in an infant. It will be on the face, it will be on the extensors, not at the sites that are described. And there is no reason for the mother to have atopic dermatitis. Mother may give us history of allergic conditions, but not this. So out epidermolysis bullosa would be fluid-filled blisters or bullae at trauma-prone area. So none of them is the correct answer. The correct answer here is infantile scabies. Everything matches. Excoriated lesions, especially on the palms and soles, nocturnal exacerbation, family history of itchy lesions gets our correct answer to infantile scabies. So infantile scabies was anyway expected. There was a question last year also on scabies. So they had to ask infantile scabies. Now, coming to the match the following question. That's the favorite for the INI. So what are they asking here? They're asking us, where is the Nikolsky sign seen? Pseudo-Nikolsky sign, false Nikolsky sign, and cerebriform tongue. So Nikolsky sign is a very simple one. We all know that Nikolsky sign is seen in pemphigus vulgaris. Pseudo-Nikolsky sign is also something that we always study. This happens because of the death of the epidermis, epidermal necrosis. So the necrosis separates the epidermis from the dermis. It will easily slide or peel off when you put a tangential pressure over it. So where does epidermal necrosis happen? That happens in the drug eruptions SJS and 10. Now, what do we have in the options? We have SJS. We don't have 10. Had they put 10, that would have been very easy. But it is also seen in SJS. So where do we see epidermal necrosis and thus peeling? SJS. Where do we see a detachment due to acantholysis, which is the true Nikolsky sign, that is pemphigus vulgaris. So two options we have. Let us match. One goes with A, two goes with B. So one goes with A, but two goes with B. So the only correct option here becomes option B. Now, I don't know where is false Nikolsky seen. I don't know where is cerebriform tongue seen. So even if I don't know that, then also I can come to the correct answer. But just remember, false Nikolsky sign is seen in bullous pemphigoid. False Nikolsky sign is generally seen in subepidermal disorders like bullous pemphigoid, like epidermolysis bullosa acquisita, bullous SLE. So these are all subepidermal disorders. When the roof ruptures on its own, you can just pick up the roof and you can pull the roof off the skin. So you're not really putting a tangential pressure on the skin and peeling it off. You are actually picking up a roof from this bulla and you are stretching it. You are, peeling it along the skin. That is called as the false Nikolsky sign. This is seen in bullous pemphigoid. So this was a new thing. Generally, true Nikolsky, pseudo Nikolsky, you all study. But false Nikolsky was a new thing. So this is seen in bullous pemphigoid. And cerebriform tongue is a special finding which is seen in pemphigus vegetans. So these are the two new things. Even if you didn't know, you could have just marked these two, that is the beauty of match the following. What we know lets us find the correct option. So the correct answer here is option B. Now, coming to the next question, a full-term neonate. So this is a neonate. That means around a child just a few days old, noted to have multiple flaccid blisters, area of skin peeling over the feet and the hands on day 2 of life. The lesions developed after minimal handling and friction. So what is the question here telling us? That there are multiple flaccid blisters which are on trauma-prone sites like the hands and feet, and they have developed early, just about a few days into getting born. On examination, similar lesions are seen on sites of pressure such as buttocks and umbilicus. There is no fever, no systemic illness. Mother reports a history of similar skin fragility in the sibling. What is the diagnosis? So this question, the question on scabies, I had put in the INI RDX series, which we had, just before the INI CET. So these are two questions that are coming up direct from the dermatology LFT sessions. A child with history of bulle, peeling of skin on trauma-prone areas in the few days after birth with history of similar lesions in the mother tells you that there is a skin fragility. There is a skin fragility. The skin is weak, and wherever there is a slight trauma on the skin, where you are handling the baby or the baby is lying down, there the skin weakens, forms trauma-induced bulle. So where is this seen? Trauma-induced bulle in a newborn. That is seen in the disease which is called as epidermolysis bullosa. And this is a genetic disease. Therefore, a history in either the parents or the siblings is mostly given in the questions to take you to the diagnosis. And here, the lesions being present in the mother also take you towards the same diagnosis. So the correct answer here is epidermolysis bullosa. Neonatal herpes, the mother would have history of genital herpes, the baby will have fever, baby will have systemic signs and symptoms, and there will be vesicles all over the body, not just at trauma-prone sites. Bullous impetigo would be a few bullous lesions filled with pus. Again, not here, and not at trauma-prone areas. Bullous impetigo is generally present in the skin folds, neck, underarms, wrist, the cubital fossa. These are the common sites in a neonate. And staphylococcal scalded skin syndrome would have a history of staphylococcal infection, will present with peeling of skin, not with this kind of a presentation. So the correct answer here is option C, that is epidermolysis bullosa. Now, coming to this question, a sexually active adult presents with painful genital lesions for the past 3 days. So this is a short history of painful genital lesions. On examination, multiple grouped vesicles on a red base are seen over the penis. That is something you can see in the image as well. There are grouped painful vesicles on the penis. Some lesions have started to rupture to form shallow ulcers. The patient reports burning pain, mild fever. What is the diagnosis? A pretty simple question here, often asked in the INI in the last 6 exams itself. This question has been asked at least 3 to 4 times. It is that important. So whenever you read painful genital lesions, I tell you, when you read painful, you have to think of either chancroid or herpes. And here, the fact that these are grouped vesicles on a red base, they can rupture, they're forming shallow ulcers. You see the same thing on the image. Where does that take you? That takes you towards herpes, because chancroidal ulcers are also painful, but they're slightly deeper. They have a yellow necrotic slough, undermined edges. You don't see any vesicles in chancroid. So this is not chancroid. The correct answer here is herpes. So this is the correct answer. Chancroid already ruled out. Syphilis is painless. LGB does not present with genital ulcer. This presents only with bubo. So all the other options also we can rule out, and we come to the correct answer. That is option B, genital herpes. Now, in this question, a patient presents with a painless black lesion over the heel, as shown in the image. What is the investigation of choice for confirmation? So what do we see here? This probably looks like an adult heel, although we cannot make out, the age is not mentioned in the question. And so the age is not mentioned in the question. So we can't really tell whether it is an old patient or a child, because that actually takes your DDs to a very different tangent. Age is very important thing. I think that should have been mentioned in the question. Let me just see. I just want to see your chat. So what are you all, what did you see in the question? Okay, excoriations was not mentioned. I'm reading it now. Okay. Okay, we'll make those changes in the questions. And after that, mother history also not given. Okay, so the questions here seem to be a little different. Okay, 70 years was given. So I'm being told that it was written as a 70-year-old man. Very good. That is something that I was, looking forward to, because without that, it was not possible to differentiate between an entity which is called as tinea nigra, which is seen in children, versus the melanoma, which I was suspecting here. So this is a 70-year-old man. This is a painless black lesion. When you look at this lesion, what do you see? It is black. It is asymmetrical. It has uneven borders, and somewhere you see black, somewhere you see brown, somewhere you see whitish blue. So it has multiple colors. In an old patient, on the hands and the feet, when you see a black colored asymmetrical lesion with uneven borders, especially in a country like India, what do you have to suspect? You have to suspect the diagnosis of acral lentiginous melanoma, because this is the most common variant in India and it is found on the hands and the feet. And this is a question, again, this was there in the INI RDX. I'd exactly put up the same question. Patient presents with these lesions. What will be the next step for diagnosis? So in such a patient, the malignancy can only be confirmed when you do a skin biopsy. And in skin biopsy also, this has to be a excisional biopsy and not an incisional biopsy. You have to take out the whole lesion, biopsy it. You don't take incisions. You don't increase the risk of it being spread along the lymphatics. So if this was a full answer, this would have been excisional skin biopsy as the investigation of choice in this patient. I'm also being told lymphadenopathy was given for the ulcers. Thank you. We'll include that in the formal recall. So here, this was a melanoma. You would do a skin biopsy. KOH would have been so if this was a child suspecting tinea nigra. Gram stain we wouldn't do. Zack smear we wouldn't do. Now, coming to this question, a patient presents with a well-defined scaly plaque over the scalp. Again, this is a patient here. Yes, if it's a kid, then tinea nigra would have been a more important differential, and we would have marked KOH. That's why age is very, very relevant when you are looking at your DDs. Now, in this question, was it mentioned as a child? Because again, a child here is a very important thing to make the diagnosis. A patient presents with a well-defined scaly plaque over the scalp with silvery white scales as shown in the image. What is the most appropriate treatment? So if it is a child who presents with a patch of alopecia with silvery white scaling, but I would prefer to call it grayish scaling here. Even if it was silvery white, it is grayish only. Silver is gray only. So this is a grayish scaling with a patch of alopecia in a child. Yes, I'm being told that this was a child. So when it's a child with this kind of a lesion, what is it that you have to suspect? You have to suspect tinea capitis. And when you suspect tinea capitis, what do you see? What do you give? You give oral antifungal. So pretty simple, asked multiple times in the NEET PG, INI CET. Again, this as a question is very expected when it comes to INI CET because it is a very important PYQ. So the correct answer here is oral antifungals. What is the oral antifungal? Okay, silvery scale was not given. Thank you. Silvery scale was not given. So child with a patch of alopecia with scaling is tinea capitis, and the correct answer is oral antifungals. Why in the world would we give methotrexate? If you confuse it with psoriasis, you might, but psoriasis would not have alopecia. Okay, so psoriasis on the scalp can happen, but these would be red plaques with silvery white scaling. They will not have alopecia. Remember, psoriasis, when it involves the scalp, does not cause hair loss. Topical steroids, this is not areata. This is not a bacterial infection. So the correct answer is oral antifungals. The last question that I've got in dermatology, a 28-year-old woman presents with a greenish vaginal discharge, vulvovaginal irritation, negative AMSELS criteria, but a positive whiff test. I think there is a discrepancy here. When it says negative AMSEL criteria, then it also has to be a negative whiff test. What was there in this? So what was there in this? Was it mentioned as negative AMSEL criteria? Was it mentioned as negative whiff test? I think I've been told this was a negative whiff test. So when a woman presents with greenish vaginal discharge, the diagnosis that has to come to your mind is trichomoniasis, the classic greenish frothy vulvovaginal discharge. Vulvovaginal irritation can be there in all of them. There can be mild dysuria also. There can be burning micturition also in these patients. Negative whiff test, negative AMSELS criteria takes you away from bacterial vaginosis. So this is not bacterial vaginosis. What would you see in the wet mount? What will be the morphology of the causative organism? Clue cells coated with adherent cocobacilli? No, that is something you would see in bacterial vaginosis. Intracellular gram-negative diplococci within the neutrophils? No, this is something you would see in gonococcal cervicitis, in which case this would have been a purulent discharge from the cervix. Budding yeast with pseudohyphae? No, this is something we see in vulvovaginal candidiasis, where it would be a milky white curdy discharge with itching. Motile pear-shaped flagellated trophocytes with undulating membrane? Definitely yes. That is what is the description of Trichomonas vaginalis. Yes, I've been told this is a negative if test. So this was a negative if test that takes you away from bacterial vaginosis towards trichomoniasis. So the correct answer here is option A, motile flagellate trophozoites. So these are the questions that I have in dermatology. If you have any other questions, you can always put them in the chat. Okay, intense pruritus. If intense pruritus was given here, then that can confuse you with candidiasis. But remember, the greenish frothy discharge or the greenish vaginal discharge is what takes you towards trichomoniasis. Irritation, burning micturition can be there in trichomoniasis also. So that is there. And this is also a question which is very often expected in the INI and the last 5 years, multiple questions on trichomoniasis have been asked. So dermatology was relatively easy. I hope you all got it correct. Thank you. So we move on to the next subject. Any other questions, please put them in the derma chat or in the live chat here. We'll include them when we are doing the formal recalls. Thank you. All the best for your result.
Hi friends, there are a good number of questions from surgery. The questions are of moderate level. There are so many new questions out of syllabus from Bailey and Lau. So good evening all. Let us start with the surgery questions now. A young man presented with a penetrating abdominal injury. During laparotomy, a colonic laceration was found involving more than 50% of the circumference of the bowel. So without complete transection, according to AAST. So this is a new question. It is not there in Bailey and Lau. It is not being asked in exams before. We had only liver and spleen before. The same grading of AAST grading of liver and spleen is asked before. This is the first time this question is coming. So it's a simple classification, but it is out of syllabus from our material as well as from Bailey and Lau. If there is a small hematoma, it is called as grade 1. Grade 1 is there is a small hematoma or a small pericolonic injury that is called as grade 1. Naturally, less than 50% of the bowel lumen involving laceration is grade 2. Laceration involving less than 50%. But the laceration involves more than 50% of the bowel, it is called as grade 3. Grade 3 is more than 50%. And grade 4 is, there is a disconnection of the bowel. So like this, there is complete transection of the bowel is grade 4. This is grade 4. So transected bowel. So transected bowel is grade 4. So the question is asking, involving more than 50% means answer is grade 3 in this question. So grade 3 involves more than, why I am not seen there. So there is a small video issue. So maybe they would have, camera is on only. They might have, I'll ask them to put my video. So this is a grade of the lacerations 1, 2, 3, 4, and very simple. Just remember, grade 1 is small hematoma, 2 is less than 50% laceration, 3 is more than 50%, and grade 4 is transected bowel. So histopathological image of a G junction is given. So the moment you see this, you can easily understand. I should enable in the iPad. I already enabled only. My video is enabled only. It's enabled. I'm not closing it. That's an issue. So now there is an image of G junction. Now, okay, thank you. There is an image of G junction. This is a classical goblet cells, you know very well. So this goblet cells are seen in Barrett's esophagus. Goblet cells are the cells which have a wide, narrow base and a wide shoulder. So this is a classical goblet cells. This picture is that there are a lot of goblet cells with a wide shoulder and a narrow base are found in this. So this is a classical goblet cell images. So therefore, it's a case of Barrett. So it's a simple, straightforward question. Maybe pathology as well as surgery integrated. A patient undergoing massive transfusion develops metabolic complications, which is not a complication of lethal triad of trauma. So this is a classical question, and this is a repeat question. Lethal triad of trauma is nothing but HAC. So H means hypothermia, A stands for metabolic acidosis, and C for coagulopathy. So this is a 3 lethal triad we get usually in trauma. So to prevent this lethal triad only, we do a procedure called as damage control resuscitation is done to prevent this 3: hypothermia, acidosis, coagulopathy. So I don't know what are the choices given. So the one answer in this selected recall I got is coagulopathy is one of the choice. There is multiple option question. So this coagulopathy is one answer. So hypothermia, acidosis, coagulopathy. So no problem. Just see the class. There is an issue with my iPad. I'm just doing a fast, quick session. We'll be having a detailed session later. Which of the following involves division of the lower anal sphincter during treatment of fistula in ano? So please understand the fistula tract related issues. This is a anus. This is a internal sphincter. This is internal sphincter. So it's okay. This is an internal sphincter. What you have is an internal sphincter, and this is an external sphincter. This is external sphincter. What is happening here is we have multiple options of operation. So this is a fistula tract going like this. This is an intersphincteric tract. The commonly done surgery, which most of the surgeons we will always do, is like this. We will remove this tract, including the sphincter which is inside also will be cut. This is called as fistulectomy. So this is a commonly done surgery. In fistulectomy, we will cut the internal sphincter also. When we are removing the tract, we will cut the internal sphincter also. So fistulectomy is most commonly done surgery. We will be cutting that. So there are another one surgery in which if this is a fistula tract, we will just lay it open like this. We lay it open like this called as fistulotomy. So in fistulotomy, I will just lay open the sphincter. I will not cut it. So just lay open. So there are new techniques which are mentioned here are video-assisted fistula tract excision. Video-assisted fistula tract excision is a new surgery. Fistula excision by laser. Fistula by laser method is FILAC. Lift is ligation of intersphincteric tract. These are all new procedures done in the recent days, but the best answer here is fistulectomy. Fistulectomy is a conventional treatment where the anal sphincter is cut. The internal anal sphincter, it's not lower anal, it is internal anal sphincter is cut during the surgery is called as fistula in ano. So I hope this is clear for you. This internal sphincter is cut is in this. So any doubts you can post. I will be answering the queries, but don't worry, soon we will have a detailed recall of what is essentially needed in the exam. So this is just a fast recall of what is happening. This is a hernia anatomy. This is a hernia anatomy. We should not forget this is a hernia anatomy. In this anatomy, you should keep the mesh in front like this, in the two spaces. This is rettious space, retropubic space of rettious, and this is Bogra space. This is Bogra space, and this is rettious space. So we are going to keep a mesh in front of this, like this, crossing the pubic tubercle. This is a pubic tubercle, it should cross more than 2 centimeters. The answer is 2 centimeters. This is also a new question. So we have to cross the pubic tubercle is what we discuss in our classes, but they're asking the facts and all is not an ideal thing for a PG entrance exam. So it should be more than 2 centimeters. You should cross to the opposite side of the midline. That is the meaning. So it is more than 2 centimeters is the answer for this question. Young patient presented with fever, constitutional symptoms. Evaluation of the mediastinal biopsy confirms it's a lymphoma. In the staging system, X is mentioned. What does X denote? Any idea? What does X denote? in which procedure anal sphincter not involved is asked. So if the question is asking in which procedure the anal sphincter is not cut, means it is lift. In lift procedure, we will not cut the sphincter. We will cut only the ligation of intersphincteric tract only is cut. Tract only is cut. This is a treatment. So lift is cutting of the internal sphincter tract only is called as lift. So let us see. Don't worry, just understand the questions and the concepts. You'll have a detailed, once you get the complete recall, you'll have a detailed session. So X is mentioned. X stands for bulky or large mass. So bulky or large mass is X. If you have B symptoms, fever, night sweats, that will stand for B symptoms. In that, X stands for a bulky mass. A huge mass is called as bulky mass. What does X denote? Okay, that is answer is X denote is bulky tumor mass. So in a patient with scrotal swelling, examination of the superficial inguinal nodes should always be performed. Reason, most lymphatic drainage from the scrotal skin goes to the superficial inguinal node. So please understand this. This is a scrotal skin. So scrotal skin spreads to superficial inguinal nodes. Testis, if there is a tumor in the testis, it spreads to para-aortic nodes. So please remember there's two difference, because last year they asked the question on para-aortic nodes, where para-aortic nodes are involved in testis. That is why we in case of testicular tumor, we should not take transscrotal biopsies advised, not advised. If you take a transscrotal biopsy, we may spread the tumor to superficial inguinal nodes. Otherwise, usually only a scrotal issues only will go for inguinal nodes. Testis tumors will go for para-aortic nodes. So answer is a scrotal swelling goes to superficial nodes. Most lymphatic drainage from the scrotal skin goes to the superficial nodes. So both A and R are true, and R is the correct explanation of A. So there's a reason assertion question. Usually this type of questions will come in UPSC exams, and here this is an easy question, but reading the choices will make you more time. So just remember the answer, both A and R is correct. An elderly patient comes to you with a cecal volvulus. An elderly patient comes to you with a cecal volvulus. Which of the following is a common predisposing factor? Can you tell me which is a common predisposing factor in this? Yes. See, this is also a new question. Sigmoid volvulus is a common MCQ. Sigmoid volvulus, the common predisposing factor is laxative abuse. And there is a lot of laxative abuse, or if there is a high fiber diet, all this can predispose to sigmoid volvulus. But here the question is asking about the cecal volvulus. In a cecal volvulus. Cecal volvulus, the important predisposing factor is multiparity and repeated pregnancy. Cecal volvulus is due to multiparity and repeated pregnancy. So another important reason for cecal volvulus is previous surgery. So previous colonic surgeries can cause detachment of the attachment. So previous abdominal surgery is another reason. So if previous abdominal surgery is there in the answer, go for that. That is the best option. If you have a previous, as Supraja is telling, there's a previous abdominal surgery question. If there is some previous abdominal surgery, that is the best option among anything else for a cecal volvulus. See the answer. This question was mostly giving points about the sigmoid volvulus, but they're asking what is a predisposing factor of cecal volvulus. Previous abdominal surgery is one of the important predisposing factors. Please don't forget this. Okay, that is correct. Previous abdominal surgery is correct. Prophylactic antibiotics before any surgery is given. When will you give antibiotic? Means 1 hour before skin incision. This is a classical question from surgical site infections. 1 hour before skin incision, you have to put a prophylactic antibiotics. Answer is B. Testis lymphatic draining into superficial nodes and not. If testis is being asked, it is not superficial inguinal nodes. That is why I'm telling you. If testis and scrotal skin are different. Scrotal skin drains into skin. Scrotal skin drains into superficial inguinal nodes, and this one drains into para-aortic nodes. Testis will drain into para-aortic nodes. Multiparous females, repeated pregnancy may be another option. If it's a multiple option question, I'm telling you, repeated pregnancy in a multiparous woman, previous colonic surgery, these are the two important risk factors of cecal volvulus. Please remember this. A patient with a solitary nodule thyroid undergoes FNAC. So FNAC of solitary follicular neoplasm, what is the answer for this? See, follicular neoplasm, this is the protocol. If there is a tumor in the follicular neoplasm, we don't know whether it is benign or malignant, because benign or malignant is based on capsule invasion. Since we cannot find out capsule invasion, what we do is, we will first do hemithyroidectomy. This part will be removed. And this will be sent for histopathological examination. And based on the report comes, if it is benign, the procedure is that's all, no more treatment. If it becomes malignant, I have to go for a completion thyroidectomy. I should remove this also. It's a malignant means I should go for a completion total thyroidectomy. So the answer here is hemithyroidectomy is the single best answer for a patient showing follicular neoplasm. Stimulant laxatives are contraindicated or should be avoided in which type of constipation? So stimulant laxatives are avoided in Ogilvie syndrome. This is a repeat MCQ. Ogilvie syndrome is nothing but pseudo-obstruction of colon. Pseudo-obstruction of colon. This is a repeat question, but they have asked a different pattern. Pseudo-obstruction means there is decreased parasympathetic activity. Therefore, the colon goes for atonic colon. So when the colon is atonic, when you give laxatives, they will only accumulate in the colon. So therefore, best answer here is atonic constipation. Okay. So ideally, it's an anesthesia cum surgery question. 1 hour before incision is the correct answer. 30 minutes also is there, but it is not the correct answer. 1 hour before skin incision is the correct answer for prophylactic antibiotics. 30 years old female presents with a trauma in the right leg. Initially, the distal pulses was feeble, but later the limb becomes pulselessness and severe pain and swelling. She is diagnosed with acute compartment syndrome. Lower limb compartment syndrome is a common issue due to closed fracture of tibia or fibula. So this closed fracture of the bone will cause acute compartment syndrome. The compartment pressure is very high. Compartment pressure becomes more than 30 millimeters mercury. It becomes, that is the late sign is absence of pulses. So late sign is absent pulses. Early sign is pain on passive stretching. Late sign is absent pulses means it is a time, take a knife and make a long incision on either side of the tibia like this, called as fasciotomy. So already there is an absence of pulses from the question. So immediately you should put a emergency fasciotomy. 2 incisions are made on either side of the tibia like this. This is very important question and it's a repeat question. So it is a repeat question. So when there is a absence of pulses, immediately you should make the incision. 90 will not be there. 90 will be very high. I don't think it will be 90. And there is the question on Glasgow Coma Scale. I have not got a proper recall of what is being asked, but I'm sure all of you would have done eye-opening, motor, verbal, and motor response. It's a simple question. It's a repeat question. So eye-opening, motor, verbal question, all of you would have answered. There is a question on this. Please go through that. And there is another question on total mesorectal excision. Total mesorectal excision. We are still collecting the questions, so we may have some time to collect the questions. But let me tell you, mesorectum is nothing but this is a sacrum. This is the rectum. This is a rectum. So rectum is 12 to 15 centimeter, and this is a mesorectum. This is a mesorectum of. This is a mesorectum. So mesorectum is nothing but which is containing all the blood vessels of the rectum. So blood vessels are running in the mesorectum. Apart from that, all the nodes are also there in the mesorectum like this. All the nodes are there in the mesorectum. So therefore, if you have a cancer in the rectum, so we have to give, for upper rectal cancers, we should give 5 centimeter margin of mesorectum. So for upper rectal cancers, 5 centimeter margin of mesorectum is given. So for middle and lower rectal cancers, we should completely excise it, called as total mesorectal excision. We have to completely excise it, called as total mesorectal, means we have to remove along this plane. We will go in the holy plane and we have to remove it completely up to this place and we will take it out like this. So TME, total mesorectal excision. Because why it is done total mesorectal excision? Because it contains the nodes and all the tumor spreading area. So the nodes are, minimum nodes are 12 nodes. Minimum nodes are 12 nodes removed. Okay. This mesorectal excision should have a 12 nodes. Okay, that is the answer for this question. So TME, that is a question. Answer is total excision should be done. Total mesorectal excision done is the answer for this question. So with all nodes, should be the answer in this. There may be some other choices. We'll be collecting the choice, but answer is total mesorectal excision. And there is a question on investigation of painless jaundice. Painless jaundice, obstructive jaundice. They have asked the investigation of choice If it is a pancreatic cancer, if it is a pancreatic pathology, investigation of choice is CECT. If it is a bile duct pathology, in a jaundice with a bile duct pathology, the best answer is MRCP. If it is a pancreatic CT, bile duct, it is MRCP. This is a classical question, already many times discussed also in the classes. So CT is good for pancreas, bile duct, it is MRCP. So there is a question on investigation of jaundice. And there is another question on a patient comes to you with a enlarged gallbladder like this. And this is a classical question, already a repeat question asked related to Courvoisier's law. In which condition you get a enlarged gallbladder means it is usually seen in any cancer in the distal part. So any distal bile duct cancer, distal bile duct, pancreatic cancer, in all these cases, you get a enlarged gallbladder. You won't get gallbladder in hilar cancer. If there is a hilar cholangiocarcinoma, the gallbladder will not enlarge. So it will enlarge in distal bile duct and pancreatic cancer. So this is related to a question on Courvoisier law. So please go through Courvoisier law. They have just simply asked a question on Courvoisier law. And there is another trauma question on C, A, B, C, D, E. So they have asked a question, arrange in sequence, and they have asked, first what will you do is, first they have asked airway. All of you will be answering airway, breathing, circulation, disability, all those things. And there is a question on C. What is C stands for? C stands for control of exsanguinating hemorrhage. Control of exsanguinating hemorrhage is called as C. So please remember, control exsanguinating hemorrhage. In that question, there is an active bleeding going on. So what will you do for the control of exsanguinating hemorrhage? So prostatic cancer is, there is a question on prostatic cancer related to grading, Gleason's grade. Prostatic grading is asked in the Gleason's. So I'm not sure with the question, but there is a question on Gleason's grade. Please go through that Gleason's grade also. Okay, these are all the questions which are collected, but this is just a simple recall. We will do a detailed recall soon. Have a basic ideas. Any queries, we will soon catch you in the regular session. We are still in the process of collecting the question because the surgery paper is moderate to tough paper. So we could not get all the questions from the students. We are still on searching of the question. Scoring 4 plus 4 comes 8 means it is Gleason's grade 4 only. Gleason's grade 4. If the score is given as 4 plus 4, it comes under 8. 8 points comes under Gleason grade 4. There is a question on Gleason's score. Mostly, I think our pathology faculty will be covering that. Don't worry, that question will be discussed with pathology faculty. Yes, they didn't give that question to me. Okay, thank you. See you in a session, detailed session soon.
So, hello, my dear students. I think I'm visible, audible to you. Yeah. So, very good evening to all of you. So, INI CET done, dusted, everything. You're free, fine, doing good. So, friends, I think that the paper didn't go too well for many students. It was a little on the harder side. If you talk about ophthalmology, the questions were not great. As an educator, these questions are doable questions, like everything has been discussed in the DocTutorials app, but there are topics which we don't discuss very frequently in the regular classes. Less discussed topics, I would say. So I got surprised when I find no question from the cornea. I didn't see any image-based question. I didn't find anything from case-based scenarios. I mean, it was quite unusual kind of paper. So one question is integrated with medicine. We will be discussing that. One question is from optics. Not a very good kind of question. And, some things from different kind of things. Like we were expecting a lot from squint, test for squints. Nothing came and they gave us a question on nystagmus. So let's get started with the questions. Ophthalmology hard tha. I know, beta, I know. but they were little doable questions. देखते हैं हम करके क्या आए हैं, है ना? Let's get started with the questions. So guys, power of accommodation मैंने पढ़ाया था. I told you about power of accommodation, that this is 1 upon the focal length, but they ask you something different. They ask you what is the power of accommodation in a 7-year-old child. Now guys, we have to use our common sense here. बच्चा है तो accommodation ज़्यादा ही होएगा. It cannot be 2 and 5. Maybe some of you are confused between 25 and 14, but guys, 25 तो होता ही नहीं है ना? So 14 is the best answer here. Now, if we go into details of that, you know, as the age increases, the amplitude of accommodation decreases. Obviously, my accommodation is lesser than your. So we have this chart by which we know, but little difficult for you to just, you know, to make a difference between 25 and 14. But somebody who's using the common sense, he should be able to answer that it is not 2 and 6. It is 14, somewhat between 10 and 15, we will say, in a 7-year-old child. तो यही लिखा है ना? 25 थी ही नहीं ऑप्शन में, ये तो और भी अच्छा है, बढ़िया है, ऑप्शन में थी नहीं 25. अच्छा, so 14 is the best answer here guys. 10 भी नहीं बोलेंगे, but it is like 12 to 15. So 14 is the closest answer. Okay, Dr. Suresh, 14 is the closest answer. Now let's talk about the question. ये सबसे प्यारा question था. This was a good question. I think everybody got it right. So what is it? It says that there is a patient presents with unilateral painful loss of vision. I think it was painful loss of vision. And when I examined, there was a relative afferent pupillary defect. Fundus was normal. So when patient cannot see anything, doctor cannot see anything in the retina, quickly you can say this is retrobulbar neuritis. Yes or no? And you can rule out other options as well very easily. Papilledema में तो vision normal होता है ना? CRAO में retina normal नहीं होता. You see a white retina with a cherry red spot. AION doesn't present like that. AION may, it's not painful. It can be painful, and if you have the, you know, arthritic type of AION, you can have a painful loss of vision, but you will not have a normal retina in AION. So you rule out other options. Then also optic neuritis, retrobulbar neuritis is the best option. ये तो easy था, ये हमने expect किया था, है ना? And I've told you the buzzword, whenever you have a painful loss of vision, patient can't see anything, I can't see anything, it is retrobulbar neuritis. So ये easy था, है ना? ये है easiest सवाल, because it is also, you know, something from the anatomy. इस बार उन्होंने glaucoma की trabecular meshwork का anatomy पूछ लिया. So what was the question? They ask you what is not a part of trabecular meshwork. So guys, common sense says that these three, they are part of trabecular meshwork, though this is a part of the outflow. है ना? If we talk about the outflow, you know, the drainage occurs through trabecular meshwork and then this goes through the Schlemm canal. So Schlemm canal is a part of the network, but it is not the part of your trabecular meshwork. Trabecular meshwork is of 3 types. UVL होता है, corneoscleral होता है, juxtacanalicular होता है. उसके बाद next question भी आ सकता है. अब इनके छेदों के बारे में पूछ लेंगे पक्का. They'll ask you something about the pores of trabecular meshwork in the next exam. Okay, NEET PG students, kindly get ready with that. ठीक है? RAPD था ना question में? सडन ऑनसेट भी था, आरएपीडी भी था, आई थिंक आरएपीडी था, आरएपीडी नहीं था. Okay, so if there is no RAPD, let us talk about this also. Some students are saying, Madam, RAPD nahi tha. If there was no RAPD, then you can think about AION also. AION also. Okay, guys, you can think about AION. In initial stages, in AION, your RAPD may be absent in initial stages. है ना? Otherwise, it is matching with retrobulbar neuritis. Absolutely. Agar RAPD hai, then it is retrobulbar neuritis for sure. If RAPD is not there, I have to again look at the question, what exactly was that? You may go with AION also. In early stages, AION may not show you RAPD. Okay? तो ये controversial बना दिया हमने, उल्ले. I thought this was the easiest question. Retrobulbar neuritis का. Chalo, we have discussed both the scenarios, if RAPD is there or if RAPD is not there. Okay, so this is the question which was there in physiology also. Physiology sir will also discuss hyperpolarization. These are some neurons, visual neurons जो होते हैं different type के होते हैं, so they work on hyperpolarization. Okay, sir will also be discussing. I think this was easy. ये तो सबका सही होएगा. Hyperpolarization, it's not auditory, it's not gustatory, it's olfactory, no, visual होता है. ये easy था. Now आ जाओ इस पे, guys, nystagmus. Though nystagmus has been well taught in the app, But nystagmus is something which I do not discuss in my regular classes. So they asked something about central and peripheral nystagmus. Probably this was the language of the question or this was the language. Beta unhone kaise pucha tha? They asked you about this except wala thing or they asked you about this thing. So all of the above is the answer if this was the language of the question, because central and peripheral can be differentiated on the basis of these three things definitely. Because in a central nystagmus you don't have any latency, suppression भी नहीं होता, fatigue भी नहीं करता, बार बार होने से there is no fatigability, and definitely the duration is more than 1 minute. Okay, central क्यों होगा? Cerebellar cause है, mid brain का cause है. Peripheral क्यों होगा? There is some auditory cause है ना, something related to your middle ear. So peripheral is short lived, थोड़ी देर के लिए आता है, ड्यूरेशन थोड़ी देर की होती है, थक जाता है, फटिगेबल होता है. ठीक है, there is only one direction, one. But central can have multiple directions. So there are so many differences here. Okay, उन्होंने आपसे एक्सेप्ट पूछा था, तो आई कंसिडर दिस इज द क्वेश्चन. सो यू कैन से फटीग नहीं होता है ना बेटे. सो डिड यू गेट इट राइट गाइस? क्या ये सही था? If this was the question, language, I think fatigue should be the best answer here. Na? Present in multiple head positions. And this should be the best answer here. Okay. चलो नेक्स्ट पढ़ते हैं. ये बड़ा इजी क्वेश्चन था गाइस. दिस वाज इंटीग्रेटेड विद मेडिसिन. सर विल आल्सो बी डिस्कसिंग. सो वी हैड अ पेशेंट इन ओपीडी हैविंग दिस पिक्चर. दिस इज द ओनली इमेज बेस्ड क्वेश्चन व्हिच आई कुड गेट. देयर वाज दिस काइंड ऑफ थिंग, डिश नोड्यूल्स थे, है ना, कैफ्यूलेट स्पॉटेड. देयर आर सो मेनी थिंग्स. सो आई थिंक दिस इज स्ट्रेट फॉरवर्ड सजेस्टिव ऑफ NF1. ये ठीक था है ना बच्चे? आई थिंक दिस वाज ओके. एनीथिंग एल्स यू विश टू मेंशन हियर? Any options if you remember here? These three images were given, something like that was given, which was straightforward, telling us that this is the answer. How many minutes? क्या पूछ रही है बच्चे? Dr. Supraja, what are you asking? I didn't get you, beta. Minutes पूछ रहे हो. Central nystagmus lasts for more than 1 minute. This is the correct statement. This is the correct statement, बच्चे. So this is the difference. Yes. All right. यही पूछ रहे हो ना? Okay. Now, next question is something more about physiology again. So this was about dark adaptation. I think this was the language which I could get. A person stays in a dark room, तो dark adaptation हो गया. Now, which of the following changes occur during dark adaptation? So guys, my common sense is at least dark adaptation में pupil gets dilated. At least this is correct. I know that, है ना? When I am dark adapted, I'm in a dark room, my pupils are dilated. This is definitely correct. Now, retinol becomes vitamin D. ये ऐसी option है. Neither retinol becomes vitamin A nor vitamin D. So ये तो बिल्कुल गलत है. ऐसा तो कुछ भी नहीं होता है ना. Now, obviously, what do you mean by dark adaptation? Like I am in a dark room. So in a period of time, in few minutes time, my cones, my rods are both adapted to the dark. So can I say yes? My eyes are more sensitive towards dark now. My eyes are more adapted to dark now. If this is the language of the question, probably I will say this is also correct. Now, we know that during dark adaptation, what actually happens? It is formation of rhodopsin, है ना? Opsin or 11 cis retinal, they join with each other to form this rhodopsin. So this is also correct. So to the best of my knowledge, if this is the language of the question, I will go with A, B, and C. All three are correct here, but D option, agar aisi option hai, to this is a weird option. This was not like that. Okay. So any corrections you want to give here? If enter in a light room from dark. Abhi question hi ulta ho gaya. You want to say if the patient was dark adapted and now he enters a bright room, you want to say that, Dr. Rishabh. You want to say it was retinol to vitamin A, formation of retinol to vitamin A. It changes to photosensitive pigment. ये तो ठीक है. It changes to photosensitive pigment. I think this is okay. Yes. Retinol to vitamin A. ये तो नहीं है ना? ये तो नहीं है. This is not correct. This is not correct. Other options was change. Okay, okay. ठीक है. So I consider मोटा मोटा यही था, but this is not the option. ये तो बिल्कुल गलत है. Light eyes become more sensitive to dark, and opsin binds with ये. This is also correct. This is true, and this is true. So all three are correct here. I think this would be the best possible explanation here. Now comes a difficult question. So guys, this is the only ectopic question which I'm not very happy with that. See, I don't want my undergraduate students to learn about that Vogue lens, that Goldman lens, कि उसका कितना magnification है. But what INI CET people have done, Guys, do you remember 2 years back, they have given us a question from optics where they have asked us what happens if you increase the power of the lens? So there were two things. If you increase the power of the lens, the magnification will decrease, but the field of view is increased. This was the statement given in one of the questions 2 years back in INI CET. So they have used the same question, but they have twisted the question. Abki baar unhone lenses de diye. So my common sense says, what concept I have learned from earlier exam, my common sense says that if the power is increasing, the magnification should decrease. Yes or no? Magnification decrease karna chahiye and field of view should increase. So that is how a smart student could have answered this. Hai na? I don't want to go into details here today, but a smart student would have easily got this correct, because higher the power of the lens, lesser is the magnification. Okay, so if you know this concept, you should be able to answer that A, B, C, D ऐसे ही होना चाहिए. ठीक है भाई? Any doubts about this question? So this was a little tricky question. I can give you this. If you decrease the power of the lens, the magnification increases here. All right. This is the concept which they have asked us 2 years back in the exam. Okay. So thank you very much, guys. I hope you've got everything correct in Ophthal and in the exam, and you get your dream branch and very, very good scores. So best of luck from everybody at DocTutorials. So keep connected. And please write down if there is any query at your part, and if you can sort out with the more questions. All right, everyone. So we are done with Ophthalmology.
Hello, my dearest students. This is Dr. Rohit Daniel, your orthopedics faculty. I know that at least some of you would be a little disappointed because this time the question paper was a little bit on the difficult side, especially orthopedics. Generally, what we see is that orthopedics is a little bit easy in INI-CET, but this time it was a little bit tough. We had around 6 questions from orthopedics. So let's start the discussion of all those questions. So whatever questions we are discussing is based on recalls. So if you want to make or suggest any corrections either in the construction of the questions or in the options, you are welcome to do so. Okay. Yes. So let me just start with the first question. A 45-year-old came to the emergency with history of RTA, road traffic accident. He is hypotensive on presentation. He has sustained chest trauma. On examination, London sign is positive over the right lumbar spine. There is bilateral femur and bilateral tibia fracture. What is the next? What do you think is the answer here? See, here the patient is coming to the emergency department. There are bilateral fractures of the femur and the tibia. But is there something more here? See, this patient has a chest trauma and the London sign is positive. What is this London sign? Sometimes when there is a road traffic accident, the bike handle can or impinge against the chest wall or the abdomen, or the seat belt can press against the abdomen, or the gear lever or something can get press against the abdomen, and you can get a patterned aberration on the body there, isn't it? That is London sign. So London sign suggests that there is abdominal trauma as well. So this is not a simple case of orthopedics. This is a case of polytrauma, chest trauma, abdominal trauma, and multiple fractures. So a polytrauma patient, you have to treat by what? By damage control orthopedics. Damage control orthopedics. Okay. So generally orthopedicians always want to fix every fracture as early as possible. You see a fracture, post it to the theater. But this is one exception. Here, what will happen if you do an internal fixation It will take, just imagine the amount of time it is going to take to internally fix both the femurs and tibia. It will take at least 6 or 7 hours. And during that time, the patient is not going to survive this extensive surgery. No. So what we do is that immediately in the emergency theater or in the minor operation theater, we give a sedation or a local block to the patient and quickly temporarily stabilize all these fractures using external fixation. External fixation. Okay, we are not looking to perfectly align the fractures and beautifully reduce it and all. No, we are just putting external fixation to temporarily stabilize the fracture. Generally, external fixation is used for what? Open fracture. This is an exception here, where to save the life of the patient, we quickly, within 1 hour, we put all the external fixation in both the limbs and send the patient to the cardiothoracic surgeon or to the general surgeon to take care of the abdominal and chest trauma. So the answer here is external fixation of both femurs and tibia. So remember, this is a question on damage control orthopedics. Okay. All right. So Supraja is saying after internal fixation after hemostabilization. Yes, that is okay. But the first step in a polytrauma patient is always external fixation for damage control orthopedics. Okay, so that is the answer here. Next question. A postmenopausal woman complained of generalized body pain, proximal muscle weakness. Now the lab reports are as follows. Calcium level is normal. PTH is increased, phosphate is low, alkaline phosphatase is high. What is the probable diagnosis? We know of 3 out of the 4 options. If you have the 4th option, please tell me what that is. See, let's look at the lab parameters and each of these. See, primary hyperparathyroidism, what will happen to calcium? Calcium will be elevated. It will be very high, isn't it? In primary hyperparathyroidism, PTH again will be elevated, phosphate will be low, and alkaline phosphatase will be high. But here calcium level is normal. So this is not our answer. What about Paget's disease? All parameters will be normal except what? All parameters will be normal except alkaline phosphatase, which would be elevated. Then, so that is not our answer here. So what is the correct answer? Secondary hyperparathyroidism due to vitamin D deficiency. Yes, osteomalacia. Yes, osteomalacia. Osteomalacia is correct. Okay. So you might think calcium is normal here. No, calcium should be low. But actually, to start with, when there is vitamin D deficiency, calcium will be low. But over a period of time, when the compensatory mechanisms take over, calcium becomes normal. Okay, so calcium can be low or normal in vitamin D deficiency. Both in rickets and osteomalacia, calcium can either be low or normal. PTH is increased, phosphate will be low, alkaline phosphatase will be high. So everything is correct here. So the answer is secondary hyperparathyroidism due to vitamin D deficiency. Yes, if osteomalacia was the option for you guys, then that is the answer, osteomalacia. Okay. Next question. A 4-year-old child presented with unilateral genu varum. There is history of fall few years back. What is the diagnosis? So can you tell me the answers here? Can it be post rickets genu varum? Remember, in rickets, there will be bilateral genu varum. Rickets is a systemic condition, no? So both the limbs will be equally affected. So there will be bilateral genu varum and not unilateral genu varum. Can it be malunited tibial fracture? Yes, that is a possibility. What about non-ossifying fibroma? See, it is a very benign tumor, and generally does not cause any abnormalities also. Okay, very, very benign tumor. Hundreds of people will have non-ossifying fibromas in their body. Many students listening to me may have a non-ossifying fibroma, but it will not cause any trouble. You will never realize that it is in your body. Okay. Sometimes when you take an X-ray for a trauma, it will be seen as an incidental finding. It will not produce any problem. So it is not the cause of genu-varum. What about focal osseous dysplasia? Yeah, that is a possibility, but the thing is that this is a very, very, very rare disease which starts around 3 to 4 years, and then the deformities will develop only after 10 years. So that is again not the answer. Here there is a clear-cut history of a fall or a trauma. So obviously the answer is malunited tibial fracture. Malunited tibial fracture. Okay. Yes, I think most of you have got this correct. Yes. Next question. A 50-year-old male with history of pulmonary TB few years back completed his course of ATT. He later presents with low back pain and difficulty in bending down. What is the next step? So the MRA is given here. There is history of TB, pulmonary TB. So the possibility is that there could have been a secondary spread causing spine TB, isn't it? So what is the finding in the MRA? In the MRA, you will see there is disc destruction, isn't it? There is complete destruction of the disc. Along with that, there is destruction of adjacent end plates. Okay, so we are thinking of TB spine. But just an MRA is not the correct way to diagnose. No, best way to diagnose, the gold standard to diagnose TB spine is always a biopsy, and nowadays we do a CT guided needle biopsy. Yes, Dr. Anonymous, you are absolutely correct. Yes, so this is the answer. A CT guided needle biopsy for TB spine. Okay. Yes. Next question. A patient brought to the emergency department following RTA and injury to leg. Distal pulse to the lower limb was low at presentation. Pain was not resolving with medications. Later, pulse was not felt, followed by paresthesia in the affected leg. What is the next step? Very straightforward, multiple time previous year question. We discuss this very often, isn't it? What is this? Patient with an injury to the limb where pain is not resolving with medications. The classical symptom of compartment syndrome. Yes, very good, Anonymous, correct. So this is compartment syndrome. This is a case of, yes, traveler, absolutely correct. So this is compartment syndrome. And what is the first or the emergency thing that you'll do? Will you wait for hot fermentation and all those things? No, we have to do a emergency fasciotomy. Emergency fasciotomy. This is a straightforward question. Yes. Okay. Next question. See, this is a question where I need your help. I am not sure how this question was asked, and I am also not sure sorry, excuse me, what the MRA finding was. So from what I could gather from my students, I think the question was constructed something like this. A patient presents with pain in his right ankle. MRI is given below. Which of the following is true regarding the disease? And I think a sagittal MRI of the ankle was given, and there was some calcification near the Achilles tendon. Is that what you saw in your exam? Is this what was asked for your exam? Was there calcification? Near Achilles tendon? Yes. Okay. So thanks for confirming this. So you had an MRI something like this where there is calcification near the Achilles tendon. So this is an example of calcification in retrocalcaneal bursitis, which is also called as Haglund deformity. Okay. Here there is calcific deposition in the attachment of the Achilles tendon. So let's look at the options. What about Thomas test? Thomas test is a test for Achilles tendon tear. Achilles tendon tear. So it is not for Haglund, it is for Achilles tendon tear. That is not the answer. Plastering and immobilization, no. That is not a standard treatment for this condition. What about Gautier classification? It is used to assess the rotator cuff muscles in rotator cuff tears. Okay. So when a patient has rotator cuff tear, maybe the patient has rotator cuff tear for 2 or 3 years, and the patient has come to you, and you have decided to do a arthroscopic repair of rotator cuff, but you need to know what amount of rotator cuff is left. Most of the time, the rotator cuff muscle would have become atrophic. You won't be able to suture it properly. So in order to see whether the rotator cuff can be repaired or not, we use something called as the Gautier classification, and it is not associated with Haglund disease. So what is the option? Steroid infiltration. So steroid infiltration is the standard first line treatment for this kind of calcification near Achilles tendon. Okay, so that is our answer. All right, I think most of the students are confirming the question and the options. Thanks for that, guys. So that's it. Those were our 6 questions. So don't worry. Remember, INICET is a competitive exam after all. If it has been hard for you, difficult for you, it definitely would have been difficult for all your competitors as well. So don't worry. So let this be a starting point for all of you. So work hard, study hard, and all the best for your upcoming exams, and all the very best for the results as well. Okay, so keep believing, and if you have any doubts or any problems at all, you can always contact the team at DocTutorials and personally me as well. Okay, so bye.
Okay, so good evening, my dear students. So this time, as we have seen that there were plenty of questions from physiology, and that too, there were conceptual questions and also repeated from the same repeated topics. So we can see question number 1, biphasic flow in the right coronary artery is due to. So we know the basis of TMT, stress ECG, treadmill test. So every day we are getting the news that after doing treadmill, someone got the heart attack. The reason is that whenever heart rate is more, duration of the cardiac cycle become less, isn't it? So whatever may be the hidden angina, that will be precipitated. The reason is that during systole, actually heart is giving blood to the circulation, but coronary circulation on the left side is hampered because it is compressed. So we are not getting blood on the left side of the coronary circulation because it is compressed. Only during diastole, there is coronary circulation, not during systole. But on the right side, on the right coronary artery, it is biphasic. Okay, I mean, blood can go in both direction. The reason, what is the reason? The reason is, you know, that there is a low pressure on the right ventricle. So because of this, we are utilizing this concept for doing stress ECG or TMT, because on the left side mainly it is hampered. Okay, during systole, only diastole is there to give the blood circulation, but on the right side, okay, there is a biphasic curve because of the low pressure in the right ventricle. Now, increased permeability of glomerular capillaries will lead to appearance of which of the following in the urine? So as we know the structure of glomerulus and also about the afferent arteriole, efferent arteriole. So normally what is not filtered? Normally proteins are not filtered. Albumin is not filtered. Why? Because the basement membrane is having heparan sulfate, okay, and it is negative charge. it is negative charge. Okay, mainly the albumin. That is why albumin is repelled. So why albumin is repelled? Why albumin is normally not coming in the urine? Because basement membrane is negative charge. But whenever there is a diabetic nephropathy or any type of kidney disease, the charge is lost and albumin start coming in the filtration. So albumin is responsible for oncotic pressure. You know that albumin is responsible for what? Oncotic pressure. So if albumin is in the capillary, oncotic pressure will be high. It is the holding pressure. But if it is filtered, if proteins are filtered, what will happen? Albumin will be filtered and oncotic pressure here will be low. So filtration will be more. So I mean, there is increased permeability of glomerular capillaries will lead to appearance of which of the following in the urine. Answer is proteins. So normally they are not filtered. Normally they are not filtered. But when there is nephropathy, okay, albumin is the first thing to come in the urine. That is why microalbuminuria is the best test to check for any type of nephropathy. So this is the answer. Now renin is secreted in response to. So we know that JG cell, JG cell are part of JG apparatus. Juxtaglomerular apparatus comprises of JG cell, macula densa, and extraglomerular mesangial cell. So they are baroreceptor. They have same receptors which are in the heart. Beta 1. So beta 1 is in the heart, beta 1 is also in the JG cell. So whenever there is hypoperfusion, not only your heart is affected, but also JG cells are affected to release what? Renin. To release renin. And after that, you know the RAS whole renin, angiotensin, aldosterone system. But they are, remember the word, the baroreceptor. They are sensing mainly what? Blood pressure, perfusion. So what is the answer? Elevated sodium load? No. Elevated renal perfusion? No. When BP is less, RAS is there to increase the BP, not to decrease the BP. Reduced renal perfusion pressure? Yes. No. So answer is C. Plenty of time we have discussed these things in the video lectures. Hyperpolarization during sensory transduction is seen in. So we know the only exception is your visual receptor. So normally, you know, there are cyclic GMP dependent sodium channels which are open in the dark. So in the dark, they are open. In the dark, the cyclic GMP dependent sodium channels are open. So sodium start coming inside and sodium causes depolarization. But what happens when light falls? So when light falls, cis-retinol convert into trans-retinol. It convert into transducin, which is a phosphodiesterase, and that will convert cyclic GMP into GMP. So this will close the door. The door will be closed. Sodium will not come inside, and this will cause hyperpolarization. Plenty of time we have discussed in detail, but for now, remember hyperpolarization during sensory transduction by light is exception is your. See, normally everywhere there is depolarization. Whenever there is stimulus, there is depolarization, but here is the exception. Now, emotional prosody of the speech is mainly a function of. I always say, when we say heart, I mean, when we say that my mood is not good, my heart is not good, my heart is saying like that. So, who is the heart of your brain? Limbic cortex. The heart of your brain is limbic cortex. Emotional component of your brain is due to limbic cortex. So emotional prosody of the speech, the tone, emotional tone, I'm angry or I'm lovingly, whatever. So that tone is catched by limbic cortex, and cingulate gyrus is the part of limbic cortex. Superior temporal gyrus is the Wernicke's area. It is for comprehension. You know English, so you can understand my English. Okay. If I speak some other language, you cannot understand why. Comprehension is because of Wernicke's area for the language which you already know. Inferior, not parietal, but frontal gyrus is for Broca's area. So Broca's area is for word formation. Okay. So here, but answer is A, cingulate gyrus. Composition of intercalated disc, gap junction. Plenty of time we have discussed that topic. Okay. In the heart, we have intercalated disc, and they are connected to each other by gap junctions. Junctions are made up of protein, connexon, and one connexon is made of 6 connection. So it is a very common repeated topic. Answer is gap junction GS receptor. Whenever I'm talking about receptor, recently when I was talking about what are the topics that can come in your INI-CET, I say definitely 1-2 questions will be from receptor. Okay, so we know alpha 1 is GQ, alpha 2 is GI, all beta 1, beta 2, beta 3, all are example of GS. Then muscarinic 1, muscarinic 3, muscarinic 5 are GQ, M2 and M4 are GI. For every revision class, for every recap, I always say 1 or 2 questions will be from receptor. Definitely. So GS, all beta are GS. So answer will be beta adrenergic receptor, without doubt. Simple. Now this is a repeat question, but the options of recall, I'm not very sure about the options. The graph shows the filtrability of the molecule across the capillary with the respect to effective molecular radius. So we know that basement membrane is negative charge. Okay. And it will allow only positive charge between 4 to 8. See, less than 4 nanometer, they are freely filtered. More than 8 nanometer, they are not filtered. Between 4 to 8 nanometer, okay, it depends on the charge. If they are positive charge like X, okay, I will go to this topic in detail video more, but when I will get the whole option. But let me discuss only one point is that X is the cation. So it will be more permeability. Okay. Neutral will be also a bit permeable, but if it is, negative charge like albumin, it will be not filtered. So X will have more permeability than Y and Z. So X represent, positive charge molecule, but even Y have more filterability. So option, I'm not very much sure, but this is the concept about that. More care about that. Now again, the repeat question, which of the following transporter activities is increased during ORS therapy? So ORS therapy, it is having sodium and it is SGLT, sodium glucose transporter. So sodium is there, which is helping in the transport of glucose. So answer is SGLT. It is a type of secondary active transporter. In the kidney, we have both SGLT1 and SGLT2. But 90% of glucose reabsorption from the kidneys because of the two. But in the intestine, we don't have SGLT2, we only have SGLT1. So ORS is using this capacity so that glucose and sodium can be reabsorbed. So answer will be SGLT1. Which of the following areas can neuron regenerate and increase the number? We know hippocampus, short-term memory convert into long-term memory. So it is dentate gyrus. Dentate gyrus is the area where number of neurons can regenerate. Loss of hand-eye coordination is most commonly associated with the lesion of. This is the new question, and answer is the parietal lobe. The loss of hand-eye coordination is most commonly associated with the lesion of parietal lobe, and also eye, hand, ear coordination. You are listening, you are writing, and you are also seeing. It is by cerebellum. I have discussed in detail, but here the answer will be parietal lobe. Neuropraxia is caused by. There are 3 neuropraxia: exontemesis and neurontemesis. Neuropraxia is the mildest form, where there is only physiological conduction block. Then in exontemesis, axons are cut. In neurontemesis, whole neuron is cut. Okay, so this has been discussed already, but here it is simple, mild form, physiological conduction block. Okay, so this is it from my side. In the main video, I will discuss in detail every question. Thank you.
discuss the questions that came from Obs and Gyn in this INI exam, I would say the exam in Obs and Gyn was easy to moderate as it was not difficult as compared to other subjects. Much predicted question have come except for 1 or 2 jinx questions which are there, which was slightly tough. Majority of them were clinical expected likely questions that had come. This session, I won't be discussing the questions in detail. Yes, we do have a separate sessions for that. Here, I'm going to just give you the question with the answer so that you can quickly analyze like what were the questions, whether you got it right or wrong. At the same time, we are keeping on adding to the questions. Once I get all the questions, the final output as such, we are going to discuss this in detail again in the app. So let's go through the questions quickly. The first question, a woman has come 4 hours after forceps delivery. She has perineal pain, and along with that you get a tender fluctuant bluish swelling. Yes, after instrumental or difficult vaginal delivery, getting a tender fluctuant bluish swelling, this is suggestive of a vulval hematoma. This is typical of the vulval hematoma. In this question, patient has come with history of preeclampsia. They are asking you what is the most effective way to prevent the recurrence of preeclampsia. For preeclampsia prevention, the most important step is low dose aspirin. We usually give 75 to 150 milligram, which is given at the night time. This is the most important measure. That's the correct answer. Apart from this, even there is the role of this supplementation of calcium, especially if you have a patient who is deficient in calcium. In those patients, calcium supplementation also helps. There is no role of salt restriction and no role of low molecular weight heparin as well. Among this, the single best answer is low dose aspirin. Choose calcium only if the woman is deficient or that aspirin option is not there. Moving to the next question, they're asking you what is the reason behind mild physiological dyspnea during normal delivery. This is mainly under effect of progesterone. There is progesterone-induced stimulation of respiratory center, which leads to mild dyspnea during the time of pregnancy. Okay, so in this question, they had asked regarding the probable signs of pregnancy. Probable signs are those signs that is actually assessed by the examiner, but that doesn't confirm the pregnancy as such. The Goodell sign, Chadwick sign, Hegar's sign, Braxton Hicks, all these are probable signs of pregnancy. Whereas in confirmatory signs or definitive signs, it includes if you see cardiac activity, that is in ultrasound, or if you see the fetus in ultrasound, or X-ray shows fetus, or you can hear the fetal heart sounds. All these are confirmatory signs. The signs which is given over here are the probable signs of pregnancy. All right. So in this question, they had asked regarding the hormonal changes that you see in various conditions. In premature ovarian failure, ovary has failed, so estrogen level will be low. And again, the FSH and LH level is high, so A is 1. Second, in Sheehan syndrome, where there is pituitary apoplexy and pituitary necrosis, you will notice that all hormones are low. FSH is low, LH is low, estrogen is low. All these hormones are reduced. When you look at Asherman syndrome, it is nearly normal. All these hormones are normal. Whereas in PCOD, the main hormonal change that you get is high levels of LH, and even there is slightly low level of FSH, normal to slightly low level of FSH. Estrogen level is slightly increased, but it's especially estrone which is increased. Here the best answer that you can choose for our PCOS is going to be normal FSH, slightly higher level of LH, and normal level of estradiol. So here, yes, the correct answer would be A. So this is how the hormones are matched. Yes, shoulder dystocia, a very much predicted question as such. Even in the last INI also, we were having this shoulder dystocia. Any obstetric emergency, it is important. They're asking you, the baby has delivered, there is turtle sign, which is related to retraction of head. What will you do first? First one is Mac-Roberts maneuver. Next comes suprapubic pressure. First maneuver is going to be the Mac-Roberts maneuver that is done for these patients. All right. So in this question, again, this is from primary amenorrhea. As we discussed, disorders of sexual development, extremely important. You are noticing that there is normal breast development, absent uterus, and scanty pubic hair. I always tell this as buzzwords. If you see that a female has breast, no pubic hair, yes, no pubic hair, this is typical of your AIS. Even they are telling you that testosterone is in the male range, which is again pointing towards this AIS, androgen insensitivity syndrome. They are usually 46X. Y with well-developed breast, absent pubic and axillary hair. Very commonly asked clinical scenario. Even in the predictor series that we had done just before, I had discussed the most likely topics. Again, disorders of sexual development, amenorrhea is an extremely high yield topic for every exam as such. All right, so this next question is related to HPV vaccine and cervical cancer prevention. The primary target group for HPV vaccination is between 9 to 14 years. That's absolutely true. That's the target age group. Single dose schedule is used for the primary target group. As per the SAGE guidelines, even single dose can be given, minimum of 1 or 2 doses. Even that is true. Target vaccine coverage is 90% of eligible girls. That's true. We always discuss this point that even if a female receives vaccination, still she has to undergo the screening. The routine screening has to be followed even if she is vaccinated. So the final statement, the fourth statement, is false. So here correct answer is 1, 2 and 3. All right, so this question is from vaginitis. Again, INI loves vaginitis. Here patient has come with vulval itching. There is pruritus, greenish vaginal discharge, typical of your trichomonas infection. And if test is negative, if test is usually seen in the bacterial vaginosis, what do you get in trichomonas? You get this flagellated motile organisms which is there with the undulating membrane. This is pointing towards the trichomonas infection. All right, moving to the next question. A 26-year-old primary gravida undergoes an ultrasound. Which of the following is least likely to occur in this condition as such? You can see, you can't see the image over here. Yes. What you see in this? Yes. Basically, yes. What you see over here is the lambda sign which is there, which is suggestive of a dichorionic diamniotic type of twin. Cord entanglement is only seen in case of monochorionic monoamniotic twin. I don't think option C and D were the actual ones which came. So please do comment as well what was the actual other options that came. Usually in case of this DCDA twin, you can have this abortion, there is risk for the selective growth restriction, all these various abnormalities, but cord entanglement is only seen in case of MCMA twin, monochorionic monoamniotic twin. Yes, in this question, woman with history of obstetric defecation is evaluated. Imaging shows that there is protrusion of the anterior rectal wall into vagina. At what depth is the rectocele considered as significant? Less than 2 centimeter protrusion is not very significant. More than or equal to 2 centimeter protrusion is considered as significant. Similarly, there was one question again, second question from Prolapse. They are asking you regarding pelvic floor dysfunction evaluation, what degree of bladder descent below the pubococcygeal line is cystocele. So basically, if you see that descent is more than 1 centimeter below the pubococcygeal line, that is again pointing towards cystocele. So correct answer here is 1 centimeter. Finally, again, I don't know if it is a repeat question where the students have again given the same question where lambda sign was there. Less likely because they're asking the same thing twice. What you're seeing here is lambda sign suggestive of DCDA twin, dichorionic diamniotic type of twin. Maybe some of the students had recollected the same question again. We are still expecting more questions. There was good weightage from obs and gyn assets. I hope you did well in the questions which are related to obstetrics and gynecology. Majority of the questions were doable except 1 to 2 jinx questions which were there. So that's it. Thank you. So do send us regarding what other things that you found as well, any changes. We will be doing a detailed record of obs and gyn soon in the app.
Hi guys, I hope I'm audible. Yes, okay. Thank you. And I think we are currently with the recall for pharmacology questions, and I hope that we have done the exams in a good way. Without any further delay, we'll keep this particular session as much small and as much crisp as possible. We will be having a detailed session as the day progresses, because currently we need to know what exactly are the questions which we have answered. And even if we have answered, say this recall is primarily for knowing that whether you have been there on the loop or not. And of course, it's going to be important for the oncoming examiners too. But don't feel saddened by like, oh my God, this question I put it wrongly. No problem at all, because it's just what the students is coming up with us. It's just purely a recall based questions. So don't worry about what's going to be happening. We'll start with the first one. Okay, we'll start with the first one. The first question is lamotrigine is the first line anti-epileptic in. Lamotrigine is the first line anti-epileptic in. We have four different options here: tonic-clonic seizures, atonic seizures, myclonic seizures, and absence seizures. Of course, from this question, the answer is going to be tonic-clonic. If this question has been asked, the answer is going to be tonic-clonic, because for atonic or for myclonic or for absence seizures, we have certain other set of drugs. Lamotrigine, even though it can be used for tonic-clonic, we have multiple other options also. It is primarily based on how the recall is going to be. If this is the proper recall, we can opt for tonic-clonic, but again, we have to wait for the final recall of all the questions and all the proper options from it. Next question, the novel antidepressant. The answer for this is going to be Vilazod-1. Vilazod-1, you remember that from our usual mnemonics, which tend to say that if a drug name contains ONE1, it is acting up at 5-HT1A receptors. Yeah, 5-HT1A receptors. And we have estazolam. Estazolam is a zolam drug, which is again like a sedative hypnotic agent, which is a benzodiazepine agent. We have trazod-1, which is also an antidepressant. Trazodone also is an antidepressant, the drug which can be safely administered in young males who are suffering from erectile dysfunction, because an adverse effect of trazodone is priapism. So this recall is primarily based on whether they have asked about a novel antidepressant or just which of the following has got an antidepressant potentials. If the question is which of the following has got antidepressant potentials, then the answer is going to be both B and C. Both will be the answer there. But if the question is, if you want to choose one out of it, we will go for Vilazod-1, because it has been a little bit a newer drug as compared to your trazodone, because we can actually classify that under novel antidepressant agent. Blonanserin is as the name contains anserin, it is an antipsychotic agent. It is an antipsychotic agent, which is a newer drug. It's a novel drug, but it's an antipsychotic, not an antidepressant. This question is done. Moving on to the next question. Ticagrelor correct statement is. Again, this is again a queryable, like whether they have asked about the correct statement or the incorrect statement. We'll go with the options. Ticagrelor is a P2Y12 inhibitor. It is a P2Y12 inhibitor. No confusions there. So mechanism of action is P2Y12 inhibitor. This statement is a true statement. The second statement needs activation to the liver. This statement is a false statement, because the activation of ticagrelor doesn't need, there is no need for activation, because ticagrelor itself is an active drug. Whereas on the other hand, our clopidogrel and prasugrel, ticlopidin, these drugs needs drugs to get activated. We need the activation process to be happening. But for ticagrelor, there is no need for the activation process. Intracranial bleeding less than clopidogrel, which is again a false statement. All of these drugs will be having the potential to produce intracranial bleeding. Reversible drug, this statement is a true statement. Clopidogrel and prasugrel are irreversible inhibitors, whereas ticagrel are, remember that, if a drug name contains grel, it is a P2Y12 inhibitor. And if a drug name contains R, this drug is a reversible inhibitor. This is a reversible P2Y12 inhibitor. As simple as that. So if it is a multiple right option question, then the answer is going to be both A and D if they've asked about correct statement. If they've asked which of the following statement is wrong, then option B and C would be the answers there. So this is again based on what we have collected till now. If you find anything no, so this option was reframed in a different way, please put it up in the chat box. We'll follow that up in the full session. Okay, moving on to resmetirom. Again, I don't want to say the usual sentences. All of these drugs, we have discussed it already. Of course, all of these points is going to be there in your notes. So how much you're going to be retaining and like reverberating that in the examination, that's what matters. So resmetirom is a newer drug. We have discussed it under the drugs used for diabetes mellitus, and this is a drug which reserves as a THR, thyroid hormone receptor beta agonist agent. This has been approved for like MASH or even your non-alcoholic steatohepatitis or metabolic associated steatohepatitis. Resmetirom has been approved. This is the mechanism of action of resmetirom. It is a THR beta agonistic agent. Moving on to the next question. All are ligand gated except. So here, usually we will be having a basic knowledge that 5-HT3 receptor is an ionic channel, ligand gated ionic channel. That's what it means. Ligand gated ionic channel. Your 5-HT3 is an ligand gated ionic channel. Nicotinic is again an ligand gated ionic channel. What is the ligand there? Serotonin is the ligand. Nicotinic, what is the ligand there? Acetylcholine is the ligand. But here the query comes whether it is H2 or GABA A. Again, as usual, as we have discussed it multiple times, GABA receptors might be of three major subtypes, GABA A, B, and C. GABA A and C both are ionic channels, whereas GABA B is a G protein coupled receptor. GABA B is a G protein coupled receptor. Actually, to say it is GPCR type C. Okay, if you want to explain that more from our notes. So it is GPCR type C. GABA A is an ionic channel. And what is the ligand there? GABA is the ligand. So this is also an ionic channel, and the ligand here is GABA. Answer for the question is going to be H2 because histaminergic receptors are all G protein coupled receptors. This is the question equally shared by both pharmacology and physiology. And of course, we know physio, pharma, medicine, all of this goes like interlinked. So we can't actually categorize which question comes under which subject. Moving on to the next question, buddy, again from our directly from our notes itself, we are talking about cilnidipine. Of course, the first one, the drug name is ending with dipin, which means this is a calcium channel blocker. Fantastic. Usually, these calcium channel blockers will be having L-type calcium channel blockade. But here, the beauty of cilnidipine, L and L, I hope you remember that. Yeah, cilnidipine blocks both L and N-type calcium channel blocker drug, L-type and N-type calcium channel blockade. And that is the reason why there will be no reflex tachycardia. So simply N-type calcium channel blockade is the answer for the question. Yes, there will be L-type calcium channel blockade, but that is not the reason for the absence of reflex tachycardia. The absence of reflex tachycardia is primarily due to it has got additional N-type. What is the drug of choice? Here I have lots of questions to be answered. See, the question is very much simpler. Here they are asking about sensitive to cefoxitin and oxacillin. This is directly from our notes, guys. This is a question regarding MSSA. I hope you remember that. This is directly from our notes. MSSA stands for methicillin sensitive staph aureus. Methicillin sensitive staph aureus, and we have already explained methicillin sensitive staph aureus can also be named as OSSA. OSSA stands for oxacillin sensitive staph aureus. And also, as we have explained already, cefoxitin is the surrogate marker. Cefoxitin is the surrogate marker for methicillin sensitivity. Surrogate marker for methicillin sensitivity. So if a particular patient is been landing up in an infection and those culture is coming back and saying that it is sensitive to cefoxitin and oxacillin, we are actually talking about MSSA. And of course, we also know one more point. If a patient is suffering from MSSA or methicillin sensitive staph aureus, there the treatment of choice would be cloxacillin. Even though it is methicillin sensitive, we cannot administer methicillin because of the severe interstitial nephritis. Even though it is oxacillin sensitive, we cannot administer oxacillin because it is producing a severe hepatitis. So the better drug is going to be either cloxacillin or flucloxacillin. Either it is going to be cloxacillin or flucloxacillin. So if this question is primarily based on this word, as we are noticing it up here, sensitive. If the question is regarding sensitive, then the answer is going to be cloxacillin or flucloxacillin. If the question is regarding resistant, then the answer is going to be MRSA, and then the answer would be vancomycin. So if it is sensitive, if the question contains sensitive, the answer is cloxacillin. If the question contains resistance, then the answer is going to be vancomycin. Yes, moving on to the next one. A drug user presented with pinpoint pupils and respiratory depression. So direct, guys. I think there is no need to explain a little bit further of it. Pinpoint pupils and respiratory depression is nothing but opioid overdose. This is opioid overdose. And this patient is suffering from OUD, which is opioid use disorder. He is landing up in acute overdose of opioid. How do we manage it? We have to administer an antagonist agent to prevent the respiratory depression from progressing on. Here, the answer is going to be naloxone. Here, the answer would be naloxone. Naloxone is an opioid antagonist agent which can be used to prevent the or treat the respiratory depression associated with opioid overdose. What is option C and option D? Please put up in the chat box, guys. We'll go for the full discussion later on. Please help us out. That's going to be very much. I'm saying advance thank you for that also. Next question, we have bradycardia, hypotension associated with sweating and pinpoint pupil. Which of the following drugs act by binding to acetylcholinesterase? Which drug will reverse acetylcholinesterase? Again, I'm not having that much better feel like this might be the question which has been asked in your exams, because what I feel it is too much revealing. They have revealed all the points about this primary option pralidoxin. So there might be some ifs and buts in this question, some ups and downs, some peaks and troughs. Please find out what are the points which has not been there in the question, and please add up certain points which has been added or additionally been put up in the question. Please help us out. I think we can go for the complete, but of course, this question is primarily regarding the mechanism of action of pralidoxin. That's the primary one-liner of this. Till now, we are discussing a lot of one-liners, and I hope you can see the pattern. All these patterns are PYQs and PYTs. There is nothing which is coming out of it. Of course, we know like around 70 to 80% is going to be from PYT, 20% going to be new drugs like resmetirom. But again, as we have explained, certain drugs we will be expecting, we'll be giving you in that notes. All those drugs also been there in our notes itself. Okay. Which antibiotic is concentration dependent killer? Again, a direct question. Which drug follows CDK, concentration dependent killing? I hope remember that farm CM mnemonic, my dears. Farm CM mnemonic. F is for fluoroquinolones, aminoglycosides, rifampicin, metronidazole, cell membrane synthesis inhibitors. Fluoroquinolones, aminoglycosides, rifampicin, metronidazole, cell membrane synthesis inhibitor. Here we have this aminoglycoside, and that is the answer for the question. This is what CDK stands for. The other drugs, all these will be following TDK, time-dependent killing, concentration-dependent killing, aminoglycoside, as per the options is concerned. Mechanism of action of pretomanid. Again, it comes under the famous group which we have explained it already under delamanid. Delamanid, pretomanid, both of these drugs are mycolic acid synthesis inhibitors. That is the answer there. RNA polymerase inhibitor. RNA polymerase inhibitor is nothing but your rifampicin. Rifampicin mechanism is it inhibits DNA-dependent RNA polymerase. DDRP inhibitor is rifampicin. ATP synthesis inhibitor is your bedaquiline. Bedaquiline, again, that drug which has been used for like resistant forms of tuberculosis. Bedaquiline. Arabinogalactan inhibitor is your ethambutol. Ethambutol or ethambutol will tend to inhibit arabinogalactan. Here for this question, if this question is regarding pretomanid or delamanid, then the answer is going to be mycolic acid synthesis inhibitor. And I'm getting certain things from the chats also stating that, sir, image-based questions have been asked from this. If there is an image-based question, finally, the concept is regarding the mechanism of pretomanid. I hope you're following that. Okay. Which is not used for mucormycosis. This is one more question. Which is not used, of course, for mucormycosis. We can use lamb, we can use isavuconazole. We cannot use voriconazole. Voriconazole will not be effective for mucormycosis. Actually, when you administer voriconazole, it might actually induce some withdrawal, or it might induce more incidence of mucormycosis. That's why voriconazole can never be used for mucormycosis. Again, everything is already been there from all of our different sessions itself. Again, this is the question I have seen. I have seen certain students asking, stating that they gave some image-based question for this. Whatever be the image, the point was regarding the question for therapeutic index. The question is for therapeutic index, which is the ratio of LD50 by AD50. But if this is the direct question, then the answer is going to be 400 by 100. The answer would be 4. But again, I have seen lots of students who are putting up currently stating that, so here it is not actually 400, it is 200 and it is 100 or it is 300 or 50, whatever be that, don't worry about it. The point is regarding therapeutic index is the ratio between LD50 by ED50. If they have given toxic dose, then the answer is also going to be toxic dose and 50% by effective dose and 50%. There is no multiplication here. There will be only division involved in it. Fenfluramine adverse effects. Fenfluramine, I hope you remember that. Yeah, you remember that a very severe BP loss. Remember that mnemonic? We'll explain that once again. Very severe BP loss was the mnemonic for fenfluramine's adverse effects, my dears. Very severe. V stands for valvular heart disease. Severe stands for serotonin syndrome. B stands for blood pressure is going to be raised. P stands for pulmonary hypertension, and loss is for weight loss. The 5 classical adverse effects of fenfluramine. Very severe BP loss was the mnemonic again from our notes itself, my dears. So again, the question is for fenfluramine, as we have discussed, cardiac adverse effects are very much severe. That's why cardiovascular monitoring will be the answer for the question. Okay, that's it about fenfluramine. Newer anti-cancer drugs are famous set of questions, right? Newer anti-cancer. I hope that we have discussed. I think the question was regarding some match the following, or they have asked about which of the following statement is correct. I'm very much damn sure these 4 are the drugs, but I am not sure what of the options which they have given on the right hand side. Sunitinib is a drug which tend to inhibit tyrosine kinase associated with vascular endothelial growth factor. Of course, it is used for any preventing the blood vessels from landing up in that. Trastuzumab, I hope you remember that it is targeting HER2 receptors, which is used for CA breast. Gefitinib, a drug which is targeting tyrosine kinase linked with HER1. Tyrosine kinase linked with HER1 is gefitinib. And nilotinib, remember that mnemonic? Nimda. Bosude was the mnemonic, yeah. Nimda Bosude was the mnemonic. MI, these drugs are used for CML, tyrosine kinase, which is used for CML, nilotinib. NI is for nilotinib, IM is for imatinib, dasatinib, and bosutinib. One more drug, which is ponatinib. All these has been taken up from our notes. Again, I'm not here to simply say that all these things has been covered up in the notes. Of course, all of the notes and all of the platforms, every individual professors will be having this basic phenomena to cover up all the points. Again, it's not about which note is bigger. It's about whether you have followed your notes in a detailed way, in an in-depth way or not. Please make sure that you do that in the oncoming exams also. With this, we finish the pharmacological discussion, buddy. And thank you so much. Bye-bye.
Yes, good evening, guys. Let's have a quick recall on the biochemistry part. I would say that the questions not very difficult, and most of them were from the notes. What the recall has I have got, and the first question will not be going into detail. I will directly come to the point. Directly, we'll have a detailed discussion afterwards. Which of the following is used for gene editing? And they have given the image where we are cutting the double-stranded DNA. It's a CRISPR-Cas9 as a Cas9, and in fact they have I have got an input that they have mentioned the name of the enzyme here itself of the Cas9. So it was the CRISPR-Cas9 that was there. The gene editing is used for that. Then hypertriglyceridemia is seen in all of the following except hypertriglyceridemia. It is seen in type 2 diabetes. Yes. If we take a high fructose diet, yes, more fructose will lead to more acetyl-CoA. There is more fatty acid synthesis, more triglycerides will be there. In nephrotic syndrome, the liver compensates and make more triglyceride. But in A beta lipoproteinemia, there is going to be decrease in the chylomicron. There is going to be decrease in the triglyceride. So, which condition is not having hypertriglyceridemia? It's A beta lipoproteinemia. The next question was, which of the following vitamins or coenzyme plays the most important role in the transamination reaction?
The transamination reaction requires the vitamin B6, that is pyridoxal phosphate, PLP. The active form of vitamin B6 is required for the transamination reaction, that where we convert the different amino acid into glutamate. That is a transamination reaction. Now here is a question from ABG where we have to match with the different things. The first was the bronchopneumonia. Whenever we are having the pneumonia-like situation, there is increase in the carbon dioxide, and that will lead to respiratory acidosis. The second was pyloric stenosis. In pyloric stenosis, the patient will have a lot of vomiting, and because of the vomiting, the acid will go out. That is metabolic alkalosis. Then hyperventilation. Because of hyperventilation, there is going to be CO2 washout, and CO2 washout, if the acid will go out, that will lead to respiratory alkalosis. And the ethanol poisoning, glycol poisoning, that will lead to metabolic acidosis. So we just have to figure out that what is matching in that. And the first option was matching based on the recall, but this is how you would have figured out the answer. So the answer is going to the first one in this case, according to the option. Benedict test is used to is positive in all of the following substances except. See, Benedict test is going to detect the reducing sugar, but it also detects some other things also. So it was actually a PYQ. It also detects vitamin C. It can detect uric acid also, but it will not detect the non-reducing sugars. Glucose is a reducing sugar, so Benedict test is going to be positive. Fructose is monosaccharide. It is a reducing sugar, so Benedict is going to be positive. Whereas sucrose is a non-reducing sugar. And ascorbic acid, yes, vitamin C, the Benedict is going to be positive. So the Benedict is not going to be positive for sucrose. It is a non-reducing sugar. Which of the following enzymes are active in dephosphorylated state during the glucose metabolism? Now, who leads to dephosphorylation? Insulin leads to dephosphorylation. And what kind of reactions the insulin is going to stimulate? Actually, wherever you consume the glucose consuming reactions, the insulin is going to activate that. For example, if you see glycogen synthesis, means what we are doing is the glucose is converting into glycogen. This is glycogen synthesis. Yes, the insulin is going to stimulate that reaction because insulin wants to do all such reactions where you are converting the glucose into something else. When it comes to glycogen phosphorylase, what the glycogen phosphorylase is doing is actually converting the glycogen into glucose, which the insulin does not want to do. The insulin does not do that. These reactions happens when the enzymes are phosphorylated, which is done by the glucagon. Then the PFK2, yes, PFK2, it is going to stimulate the glycolysis. And yes, the insulin wants to do the glycolysis. So I can say that the PFK2, yes, it is also stimulated when it is there in the dephosphorylated state. Fructose 2,6 biphosphatase, it is the enzyme of the gluconeogenesis, and the glucose does not want to do the insulin does not want to do the gluconeogenesis. So these two reactions, or you could have figured out the answer like this, that insulin leads to dephosphorylation, and the way they are asking that which reactions will be done by insulin, or you can say which reaction is not done by insulin. The gluconeogenesis, the insulin does not like to do that. Insulin does not like to do the glycogen phosphorylase, means the glycogenolysis. Insulin wants to do the glycogen synthesis. Insulin wants to do the glycolysis. So the answer is going to be A and C. So the answer is going to be the third one, A and C. Oncogen addiction refers to a phenomena in which cancer cells. Now, what is the meaning of oncogen addiction? It means that the cancer cell is mainly dependent on single survival pathway. And that is how we are allowed to use a targeted therapy, because the insulin, the cancer cells, they are particularly dependent on one particular pathway for their energy formation. This is called as the oncogen addictions. So oncogen addiction means they depend predominantly on a single oncogenic pathway for the survival. And this is called as the oncogen addiction pathway. This is the oncogen addiction hypothesis. Which of the following statement regarding hormones and their metabolic action is correct? Insulin increases the protein synthesis. Yes, insulin is an anabolic hormone. Yes, it is going to increase the protein synthesis. It is true. Thyroxine decreases basal metabolic rate. No. decreases, rather it is going to increase the basal metabolic rate. It is a false statement. Insulin decreases blood glucose level. Yes, true. Epinephrine increases the glycogenolysis. Yes, epinephrine, norepinephrine, calcium, catecholamines, they leads to cutting of the glycogen. It is a true statement. Glucagon increases gluconeogenesis. Yes, glucagon loves to make the glucose. So which of the following are true? Except of B, everything is true. So the answer is going to be the third one. Except of B, everything is true. Which of the following the classification of amino acid is correctly matched? Uncharged amino acid, cysteine, yes. The charged amino acid are the acidic amino acid and basic amino acid. They are the charged one. Acidic is having the negative charge, basic is having the positive charge. Cysteine is a uncharged amino acid. Yes, it's a sulfur-containing amino acid. Is uncharged. This is a true statement. Non-polar amino acid means water insoluble. Proline is an amino acid, and amino acids are water insoluble. Yes, it is a true statement. Basic amino acid. What is the mnemonic for basic amino acid? We remember, do you remember? His last urge is very basic. Histidine, lysine, and arginine. So lysine and histidine, yes, they are basic amino acid. Yes, they are basic amino acid. They are true. So they're asking which of the following are correctly matched or which of the following are true. All of them are true. There were some more questions were there, and I'm getting still some recalls. There were one or two more questions were there. We were not very sure whether they were there or not there, so I have not added. But these were the questions that we have got, and all of them were from the notes. So we will have a detailed discussion soon, and will be uploaded on the DocTutorials app. And wish you a lot of luck for your results. Thank you, guys.
live? Is this live? Please let me know.
Please start.
Hi, everyone. Very good evening to all of you. So today it was INI CET exam. I hope all of you have done a good job. And in psychiatry, they have asked approximately 7 or 8 questions. I feel all questions were moderate level only. Like frequently asked question like opioid poisoning was there, related to alcohol, there was the Korsakoff. This time some extra question, okay, which we are going to discuss one by one. So first question, which I'm going to discuss here now. Which of the following is considered as a novel antidepressant agent? Means like which is having some special ingredient here, right? So here answer is vilazodone. This is what? This is, I hope you are able to recall that this is Sperry, right? What is this actually? You can say here, this is serotonin agonist and reuptake inhibitor. Okay, fine. So out of these here, answer C is the best. C is the right answer here. Next question. A patient presents following a recent divorce with associated depressive symptoms and a history of alcohol use. He reports feeling of hopelessness and expresses that life feels meaningless. I think some students also mentioned कि sir, suicidal tendency was also there. कि he had suicidal tendency also. So I can add suicidal tendency also here. Now remember here, first of all, this is a severe symptom, feeling of hopelessness, helplessness, worthlessness, 100% depression, major depression here. If suicidal tendency was also there just after the divorce, see what is the best here? First of all, admission, hospitalization, and then you have to continue the treatment. Hospitalization is first. Most important is hospitalization, I would say. Okay. So here, hospital admission with the further treatment. Next. A 5-year-old child is brought with the progressive loss of eye contact, repetitive hand and the clapping movements and slowing of head growth compared to age norms. Basically, microcephaly, size of head small. Developmental regression is noted after a period of apparently normal early development. Okay, this is one of the autistic spectrum disorder. Autistic spectrum disorder, right? Autistic spectrum disorder, what we have learned that there will be a triad of social, like there will be impairment in social interaction, language and behavior. Fine. But all these are more commonly seen in males than females. Only one is like exclusively seen in female, that is Rett syndrome, where you can see microcephaly, Rett syndrome, exclusively seen in female, gene mutation, MECP2. Remember, for this, up to 2023, up to 2023 and 23rd March, there was no any medicine. But now there is a new medicine for this. This new drug is called as trofinetide. Now, what are some other symptoms here? First of all, symptoms like autism with microcephaly. And after that, loss of the acquired skills after 5 to 12 months. Means whatever a child has learned, now the child will start forgetting it. Okay, there can be breath holding spells also. There can be seizure also. Next question. Which statement represents right clinical guidance regarding nicotine replacement therapy? Nicotine replacement therapy and smoking cessation. Now, see here, out of these options, when you look here, okay, like option number 1, nicotine gum is always superior. Varenicline can be used as first line. Non-nicotine therapy. Remember here I think one option was this also, there should be like the person should not be taking tea or coffee 15 minutes before taking nicotine gums or lozenges. Fine. So I think there can be mismatch in the options here, but this option was also there, and this will be the best answer here. Okay. No tea, coffee should be taking. Remember here, like patient should not be taking tea or coffee 15 minutes before taking nicotine gums and all. Next question. A 28-year-old known substance user is brought to the emergency department in an unconscious state. On examination, patient has a respiratory rate of 6 breaths per minute, means respiratory depression, and the pupils are found to be pinpoint meiosis. All right. So we have learned mnemonic of CPR. Patient is in coma, pinpoint pupil, respiratory depression. This is a case of opioid overdose. Antidote of choice is IV naloxone. IV naloxone, where half-life is only 30 minutes. Okay. For relapse prevention, we can use naltrexone. So this was the case of opioid overdose. Next, see classical conditioning. We have learned about classical conditioning. Okay, whenever we are going to pair up, we have learned about like that experiment Ivan Pavlov. If you are only see, suppose if you are going to provide the food, there will be salivation. Okay, if you are ringing only the bell, no salivation. But first of all, you are going to ring the bell. After that, if you are going to provide the food, right? If you are going to repeat same thing for 2 times, for 3 times, 4 times, after that, even if you are going to ring only the bell, now there will be conditioned response, right? So here, out of these 4 lines, actually all these are almost similar. So I will go with option number D here, right? A conditioned stimulus provokes a conditioned response after learning. Right? This is classical conditioning. We also have learned about the operant conditioning on the basis of result. I gave you the example like if you ask a child that if you study for 1 hour, I will give you 1 chocolate. Now the child will say, I will study for 2 hours, give me 2 chocolate. Right? That is called a positive reinforcement. That was operant. Here, the question they have asked about classical conditioning. Wernicke line, okay, like this question was also there. What is the true statement regarding Wernicke line? Some students said, sir, this was also, but some students said, sir, this was same in that nicotine question only. But one option was also neuropsychiatric symptoms. Say, remember, if you are able to recall about Wernicke line, for smoking cessation, we can use bupropion, which is NDRI. But the best is Wernicke line. But Wernicke line is given with black box warning. Why? Because only in a few cases, not in all, only in few, it can cause neuropsychiatric symptoms like suicidal tendency. So, like if this was the question, here better option will be neuropsychiatric symptoms. See the Korsakoff syndrome, like due to deficiency of vitamin B1, right? Thiamine deficiency. Acute case will be Wernicke, symptoms will be Goa, global confusion, ophthalmoplegia, ataxia. But if you are not going to treat, long standing will be the Korsakoff syndrome, right? Where anterograde amnesia will be there with loss of recent memory. There will be the confabulation also, making false stories to fill memory gap, right? Fine. So how to treat the Korsakoff syndrome? You have to give oral thiamine at least for 6 months. This much point is clear to everyone, right? This is actually a long-standing case. I hope you people have done good job in psychiatry. I wish you all the best. Thank you so much. Bye-bye.
So friends, let us quickly look at the INI-CET possible questions which came out of ENT. And there's a disclaimer, it's a very initial recall. We do not have the exact number of questions which came and what exact choices were there. Just to, share with you what sort of topics have been asked over there. But yes, list is yet to come in a complete manner. One topic which was really, a very interesting topic, trans-tympanic injection of gentamicin, trans-tympanic injection of the steroids for certain SNHL. It has been discussed, multiple number of time in the class. There is a recent advances. You must be remembering this picture was there in our INI-CET NEET PG, online live classes also and the recorded lectures also, that microwics are used for the trans-tympanic delivery of drugs. And we discussed in the class also that the two indications of this for trans-tympanic injection of drug, one is gentamicin injection for intractable menials, and the second one is for the sudden SNHL when patient loses hearing on one side mostly. And you can give the, the trans-tympanic, intertympanic installation of the, dexamethasone using microwics. So best method to give the sudden SNHL treatment will be, intertympanic steroid injection, of course, using the microwics. Like this was like a very nice question. And let me tell you, this was asked previously in the AIMS examination also when INI-CET was not there actually. This question I'm not sure about, to be very honest. I would like leave it to, more, we'll do the detailed recall later on because the picture is not clear. But, around the eustachian tube, some tube opening was created and they asked some muscle. If you got any input on this particular, thing, they asked that what was this muscle and where this marking was. We'll come to that once the proper recall happens. But, eustachian tube anatomy, the levator palatii, levator villi palatini muscle, Ostman pad of fat has been, definitely the discussion, where we have been really drafting the question also in our, in the grand test and the subject test also. So we'll come back to you again. I don't want to really claim that this is the exact picture. I would prefer to wait for you guys to give inputs to us that what picture came in this thing. And again, see, look at the beautiful thing they ask sometimes and very nicely ask question, but patient having the laryngeal anatomy question, but they ask in a clinical way that after thyroidectomy, the respiratory distress, and you feel like they're going to ask about the Arlen injury, but they gave one, very clear question was that which of the following is the solo abductor vocal cord? Even if you don't know the picture and all that, the answer is, what is the answer is the posterior cricoretinoid is the only abductor vocal cord. And I think we know about that. This was a very scoring question over there. And there are four reductors: lateral cricoretinoid, thyroretinoid, interretinoid, and of course the cricothyroid. And there are two tensors. Cricothyroid is the main tensor and vocalis pus. This was scoring question. I'm sure you would have scored all of them. This one correct. And everybody who has attended the, the NEET PG online live classes or the recorded lectures, you will be having awareness about the, microwick, assisted trans-tympanic or intertympanic gentamicin or steroid injection at different indications actually. So two questions I'm expecting to correct, but this one will come back on it. I mean, there are many other questions which actually I got from various students, but I'm not clear about the exact terminology used or exact picture. We'll come back to you with the proper recall also. The next question, again, beautiful question, and I'm so happy this was there in the LFT discussion also, and in one of the grand tests also, that I have been telling time and again, only one nasal mass which does not bleed is enterocoinal polyp, and there is a epistexis given there. If you remember, we had done the differential diagnosis of 4 nasal masses in our classes also. That all nasal rhinosporidiosis, inverted papilloma, angiofibroma, all of the nasal tumors, they will bleed a lot. But enterocoinal polyp is the only nasal mass which does not bleed. I told you any unilateral nasal mass growing backward, without any stereoepistexis, is enteroconal polyp question. And angiofibroma bleeds a lot because of the vascularity of the tumor, and the blood vessels of this tumor do not have muscular layer, and they bleed really, too much. Profuse epistexis is there. And inverted papilloma, it's not inverted papilloma or Ringet's tumor, it's a reddish firm nasal mass with smooth surface with epistexis. And other tumor like olfactory neuroblastomas or any common cell carcinoma of the nose or the sinuses, they will be absolutely the epistexis. So one nasal mass which doesn't bleed is enteroconal polyp. Till now I'm expecting you had corrected this question for sure, because you must be remembering one mask which does not bleed is, please tell me in the chat box in the comments down that could you score this one correct actually, because this will be really something you'll be reassured also that, like learning in a proper format definitely works. The art of differential diagnosis, which all faculties keep stressing in DocTutorials, is of huge, humongous importance. And this one, I'm sure you would have done that. And please do comment on this thing that could you really recall the transtympanic gentamicin injection and the delivery of drug through the intertympanic route actually. And I would like to know your, the comments on this one. Now, this one I'm not sure about, to be very honest. What was the word over there? Because every time, INICET would have some, very big googly over there, which actually has never been talked in the PG circles also. I'm not sure this word was there or not. Was it lateral skull base surgery or fracture of the lateral skull base? Was it actually Glasgow coma scale? I don't know. I mean, but this is the recall which we have got from the, initial, discussions around. I would prefer to keep this in the cold box for a while. We'll work on this and we'll definitely come back with a proper recall with the organized this thing about this particular question also. So I will not comment on this because I'm not sure about it. Similarly about that picture also. And there are two more questions which people have sent me about ENT, but I'm yet to really get the complete grip on that. Now, this one, I'm sure you would have done correctly. The sinuses X-ray we discussed number of times that, water view is good for maxillary sinus and the cardinal view is best for the frontal followed by ethmoid sinuses. And you can see it is not the water view, it's cardinal view. And which of the following is the X-ray best for frontal sinus visualization? The answer will be cardinal view because water view is best for the maxillary sinus over there. Guys, I would not say this is the end of the, question list over there, but this is the very, like sure question. Like, so this one question I'm sure from multiple different student recall that water view and cardinal view question came over there, and I'm sure you could really answer it correctly. Number one. Number two, you could have correctly answered this question of enterocoinal polyp also. Any nasal mark not bleeding is enterocoinal polyp. Tell me in the chat box. Number two. Number three, only abductor is posterior cricoternoid. You would have done that also correctly. And the transdermal delivery of drugs, steroid, the intertympanic gentamicin injection or steroid injection for certain SNHL. These are four, but there are very, like other question also of anatomy with the pictures and all that. Just wait for a couple of days. This is a very initial recall. We'll get back to you in different subjects. We'll work on that and we'll give you more sure, more organized recall in the coming days. But yes, we do know there's anxiety, in everybody's mind that what actually was. And I did one survey about the INICET question level this time in one of the WhatsApp channel I have. And, majority of the people have commented that there were a lot of, newer set of topics across the subjects. And this was a tricky exam, actually, as per many students. I know it's a mixed feeling right now, but, what I could gather from that poll was like this. So thank you very much. Please do not really waste too much of time. NEET PG is coming for all of you. And let us really now take 1 day rest and then jump up to the occasion and let's make a good strategy for the NEET PG. If you see clearly, the NEET PG is on end of the August. Leave last 10 days. From this day, we are left with June, July, August. Three months are left. Last 10 days for last book revision. And very soon we'll come on this channel back with the proper strategy for these remaining days also. Thank you very much. Good luck. Wait for proper recall.
Okay, so I think we are live. So can you please let me know in the chat box if my audio and video is good? Please let me know in the chat box if my audio and video is good. All right. Let me just check if I can see the chat box. See the chat box. So I think we are live. Okay, right. So I think all good to go. We'll have a quick discussion of the INI-CET medicine questions. Okay, so first of all, at the outset, let me tell you, these are all recall-based questions, and we are doing this session on the day of the exam. So based on whatever data I've got from the students, this is what best I could, put it before you today. So if at all you have got certain changes in any of the questions or the options, please do let me know. And I'll just let you know my Instagram ID. You can message me in Instagram as well. So my Instagram ID is dr_Rahul_Rajiv. Okay, or you can send me a WhatsApp message as well. I'm sure that you already are there in my academic WhatsApp group, so you can message me personally as well in case there are any changes in any of the questions that I'm putting forward. And I'll do a recall session very soon, if possible tomorrow, after getting the more elaborate form of the questions. But this session, I'll be going in a quick manner just to tell you the answers of the questions that I've got. Okay, so no detailed explanation. I don't want to keep you waiting for long, and we'll finish this quickly. Just the question and the answer, no detailed explanation. Detailed recall coming up soon, right? Let's go. And do let me know in the chat box how the exam was for you, right? So coming to the first question, all the following disorders in the options, they are associated with Parkinsonism, dystonia, and basal ganglia involvement. Which one requires a distinct treatment approach compared to others? And please look at the options as well. So basically, all the etiologies that have been given in the options, they are all Parkinsonian disorders. They can all cause Parkinsonism. You remember in my lectures, I've discussed this under others section. Now, if you look at option A, pantothenate kinase associated neurodegeneration. Option B, the PLA2 G6 associated neurodegeneration, as well as Kufor-Rakib syndrome. Well, the last two, option B and D, are actually not NEET PG or INI-CET level. They're actually of a super specialty level. But again, you can have a couple of questions at that level for an exam like INI-CET. But whatever it is, these three disorders come under the umbrella of NBIA, that is neurodegeneration with brain iron accumulation. The most common type of NBIA is option A, right? Option A is the most common type of NBIA. Now, Wilson's disease also can cause Parkinsonism. Now, look at the question. It is about the treatment approach. So please understand that if you look at the options, there is only one disorder that has a definite disease-modifying treatment, and that is Wilson's disease. So with regards to treatment strategy, whether it be using the copper chelators or zinc, disease-modifying therapy, that's the key word here, that is available for Wilson's disease. Now, coming to option A, B, and D, you only have got symptomatic or supportive treatment. So the treatment approach here means, yes, you have got a disease-modifying therapy for Wilson's disease, and that is going to be the answer for this question. Coming to the next question. Resting tremor in Parkinson's disease is attributed to the loss of. Now, this is what I could gather from the students. Again, let me tell you, if you have got any changes in the options, please do let me know either in my WhatsApp or in my Instagram. But based on this recall that I've got, the best answer is option B. Because you know that in Parkinson's disease, the problem is with direct pathway. There is a damage to the direct pathway and a facilitation of the indirect pathway. So what can happen is that, there is a loss of the inhibitory influence on subthalamic nucleus, because of which, in case of Parkinson's disease, the reason for the tremor is that the STN nucleus, the subthalamic nucleus, okay, there is an overactivity of the STN, okay, overactivity of the subthalamic nucleus. And this is responsible for the activation of the tremor loop. So the tremor loop gets activated because of the STN overactivity. Answer is option B. Coming to the next question. So this image we have already discussed in class about the direct, indirect, and hyperdirect pathway. Coming to the next question. 24-year-old man, recurrent stereotypical episodes characterized by behavioral arrest followed by certain abnormal movements of right upper limb and piloerection over the same area. Okay, what is the likely diagnosis? So there is a behavioral arrest of sudden onset, and you can see there are certain motor movements, and along with that you have got autonomic involvement in the form of piloerection. So this is definitely a case of focal seizure, correct? Because you have got a focality to it, right upper limb. So it's a focal seizure. And since there is a behavioral arrest, you remember in my lecture, I've told you behavioral arrest is a feature of what? Seizure with preserved awareness or impaired awareness. Seizure with the impaired awareness. So it's a focal seizure with impaired awareness. Now, what does piloerection suggest? It suggests autonomic involvement. Which lobe is involved? Temporal lobe. I've told you, again, you remember a story that I've told you in class. Okay, I've put that story in, that Instagram as well. I told you a story about a case that, I've seen during my residency. So I hope, you've got this right. So basically, this one is correct. Focal seizure with impaired awareness, as well as there is a temporal lobe involvement. So 2 and 4 are correct. So the answer will be option D, focal seizure with impaired awareness, and it is temporal lobe involvement, right? Okay, right. So coming to next question. 35-year-old man with HIV/AIDS, fever, seizures, headache, focal neurological deficits, CD4 count 40. Okay, so MRI shows multiple ring-enhancing lesion in the basal ganglia with surrounding edema. What is the most likely diagnosis? So what do you think is the answer? So HIV patient, significantly immunocompromised, CD4 count 40, ring-enhancing lesions. I've always told that the topic of ring-enhancing lesions are important. Now, look at this. The location of the ring-enhancing lesion is crucial here. It is in the basal ganglia. So if you get a ring-enhancing lesion in the basal ganglia, you should definitely think about cerebral toxoplasmosis in this case. You should definitely think about cerebral toxoplasmosis in this case. What about progressive multifocal leukoencephalopathy, that is a non-enhancing lesion, correct? And what about tuberculoma? Tuberculoma can cause multiple ring-enhancing lesion. It can occur in HIV patient, but basal ganglia is not a characteristic site of lesion. And primary central nervous system lymphoma as well, to produce such multiple ring-enhancing lesion is unusual. Answer is cerebral toxoplasmosis. Lamotrigine is considered as the drug of choice for which type of seizure? Among the given choices, this is something which we have discussed in class. The best answer is generalized tonic-clonic seizures. Among the choices, it's not that it cannot be given in absent seizures, but again, as a preferred drug, first-line drug, you can consider in generalized tonic-clonic seizures. Child with Dravet syndrome, plan to start on fenfluramine. Again, I've told you about Dravet and fenfluramine in one of my MCQ discussions as well. Which adverse effect should the physician specifically monitor for? So it should be valvular heart disease and pulmonary arterial hypertension, which can occur with the use of the drug. So that is going to be the answer, option A, right? Coming to the next one, this is again a straightforward case. 2-year-old girl, a loss of previously acquired developmental milestones beginning at 12 to 18 months of age, repetitive hand wringing and hand clapping movements along with failure of normal head growth. What is the likely diagnosis? Straightforward case of Rett syndrome. Topics are getting repeated. Rett's was asked before. Ring enhancing lesion again, previous question. So the thing is that you can get questions in a different manner, but again, topics remain important. Which of the following is considered as a novel antidepressant? Yes, it is vilazodone, which is a novel antidepressant. 45-year-old male patient with palpitation, ECG taken. So not the exact ECG, but this is a representative ECG, which I understand from students was irregular narrow complex tachycardia with absent P waves as seen in the rhythm strip here. And the answer is going to be atrial fibrillation from the recall that I got from the students. Okay. 50-year-old man presents to emergency department with severe retrosternal chest pain radiating to the left arm for 2 hours. So it was a scenario of an acute coronary syndrome. ECG was shown. Coronary artery, which is most likely involved, was the question. This again we have discussed in our lectures. So the common blood vessel that is involved in inferior wall myocardial infarction is the right coronary artery. But please also have a look at the pattern of ST elevation. If the pattern of ST elevation in the inferior leads is in such a way that it is lead 3 more than lead 2, which means the ST elevation in lead 3 is more than lead 2, then that would mean it is right coronary artery. Whereas if it is lead 2 more than lead 3, then it can be left circumflex artery as well. That also can cause inferior wall MI. But from what I could understand from the students, this one was inferior wall ST elevation MI, lead 3 more than lead 2. But please do let me know in the comment section or in my Instagram inbox if there is any other difference or any other data given. But otherwise, the answer is going to be right coronary artery. Okay. So please do let me know if there are any changes in the questions, because I'm going to do a detailed recall very soon. So please do let me know. This question also we had discussed in class. Resmetirom exerts therapeutic effect through which mechanism? So resmetirom, we know that it is a drug that can be used in the metabolic syndrome associated steatohepatitis. And this drug acts by being an agonist at the thyroid hormone receptor beta. Then another image-based question with, I think, capillate macule and Lisch nodule, straightforward question on neurofibromatosis. Then you have to just help me with this question if this is the actual recall, because I've got different versions of this question from different students. I'll be very happy if I can get the exact version. But is it like this? Malar telangiectasia was a recognized feature of systemic sclerosis. A similar facial appearance is associated with which of the following cardiac conditions? So if this is the right recall, well, a similar sort of purplish pigmentation in the malar area can occur in case of severe mitral stenosis. And this is what is referred to as the mitral facies. Okay, so this is what is referred to as the mitral facies. So I hope you have remembered in my workbook as well, I have discussed this point about mitral facies. This happens in severe mitral stenosis only. Extensive mitral stenosis with decrease in cardiac output, you may get the mitral facies, okay, which is similar to that of a malar telangiectasia, again, provided the question was like this. Okay. A complete heart block in a neonate is most commonly associated with transplacental passage of which maternal antibody? Well, the answer for this question, again, we've discussed in class, it is anti-Rho antibody. While taking the history of a patient, certain words can hint towards etiology. Which of the following is suggestive of congestive heart failure rather than obstructive lung pathology? So this is what I got as the recall from students. Again, please correct me if there are any changes. Well, if this is the right recall, then air hunger is the answer. Inability to take a deep breath, very non-specific feature. Chest tightness, more a symptom of bronchospasm. Again, intermittent wheezing as well, not suggesting heart failure. Mostly it says obstructive lung pathology is likely to produce wheezing. So among the following, air hunger will be the answer. True about Korsakoff syndrome. First option, anterograde amnesia with loss of personal identity and no residual deficit, which is wrong. So it is not that the patient does not have residual deficit. You can definitely have memory loss as a residual deficit. So this I am eliminating. Ophthalmoplegia, ataxia, acute confusional state, more goes hand in hand with Wernicke's encephalopathy. But the next one, anterograde amnesia with marked impairment of recent memory appears to be the better answer for this question. The classic triad of Melkerson-Rosenthal syndrome includes all except. So this is a scenario characterized by recurrent facial palsy. You've got orofacial edema and fissure tongue. The answer would be proptosis. Coming to the next question, scenario of, I think, a simple one, which is post-streptococcal glomerulonephritis, the clinical presentation, the nephritic type of presentation, the immunofluorescence finding, electron microscopic finding, all are suggestive of post-streptococcal glomerulonephritis. Picture of the abdomen, I assume that there was a image shown of a patient with violaceous stria, and the screening test was already done, and hypercortisolism was established by the dexamethasone suppression testing. The next test would be serum ACTH. Again, I've told you in class, this topic is very important on Cushing syndrome evaluation. Then next, which lobe lesion is going to cause an impairment in the hand-eye coordination? Well, this again is a repeat question of INI CET 2021. The answer is going to be parietal lobe. Involvement of medium vessels are seen in all of the following except. Again, I just want to know from you, was this the exact recall? Was the term classification mentioned? I want to know all those stuff because, look, leukocytoclastic vasculitis, it's basically a small vessel vasculitis that affects the postcapillary venules. So actually, it is a small vessel vasculitis. Okay, we have discussed this under the Henoch-Schonlein purpura as well, the IgA-mediated vasculitis. You can have a leukocytoclastic pattern there. Now, that is actually a small vessel vasculitis. Berger's disease, it can involve medium vessels as well as small vessels. So it can involve medium vessel. Polyarteritis nodosa can involve medium-sized vessels. Granulomatosis with polyangiitis categorized as a small vessel, but can rarely involve medium as well. Okay, so it's categorized under small vessel, but it may involve medium. Now, if it is to choose between A and D, provided the question framing was like this, if it was something specific on the classification or so like that, please let me know. But if the wording was like this, I feel the better answer would be option A, for the reason that GPA may also have medium vessel involvement. Okay, that's the reason. Okay, right. But I know that at least some students might have found this question a bit controversial. Okay, actually speaking, option A and D are going to involve small vessels only, but leukocytoclastic pattern, you're not going to get in any medium vessel vasculitis. It is small vessel vasculitis. Secondary systemic amyloidosis, again, simple question. Answer is option B, AA type of amyloidosis. A diabetic female from Assam presents with chronic cough, fever, weight loss, cavitary lesion, lung biopsy, granulomatous inflammation, Langerhans giant cells. Liver biopsy shows caseous necrosis with histiocyte-rich infiltrates. So you can see that it is more likely going, towards a tubercular picture. But considering the history from this endemic region, Assam, histoplasmosis can have a very close mimicker. It can be a close mimicker of tuberculosis. So given this presentation and with this option, I think the better answer would be histoplasmosis. It can very well mimic tuberculosis in endemic regions. So the answer for this question is histoplasmosis. So these are the questions that I could gather from medicine. But in case I've missed out on any question, please reach out to me in my Instagram ID. You can message me or you can inbox me in my WhatsApp number as well. Please do so that I can come out with the detailed recall very, very soon. Thank you so much, everyone, for joining, and keep learning well. Wish you good luck and keep trying well. Thank you so much, everyone. Bye-bye.
Okay. So hi guys. So you've heard all the recalls in all the of all the subjects now, and it comes pathology now. So as everyone has said, pathology. So basically, the purpose of recall is not for judging or making you tense. The purpose of recall is just to make you more prepared for your NEET PG exam in the future, and to know some more facts, and to just let you know what more can be asked from this. Okay. So the uniqueness of this time paper was that there were no questions on the polyps of the intestine, which is again a very, very important trigger question. But yes, there were a lot of previous year topics which were there, so it was a mixed paper as far as pathology was concerned. It was okay paper. I think most of you were able to do it well. So let's start straight. So question number 1 on the screen. So what is the image here? So this is the basic thing which we teach in the histopathology. Whenever you see these whitish color glands, they contain mucin. So there are a lot of mucinous glands which are shown here. So when you see so many mucinous glands together, so this is usually a mucinous gland, which is probably a sublingual gland. Okay, so that is one thing we have to be clear. So thyroid, we have seen so many times. Pancreas has islets which can be seen. Lacrimals does look like this. So that is why it was a sublingual. Some students also told that the options that were given were, let me keep seeing your options also. So some people were also saying that they were options on submandibular gland. So remember, this is more of mucinous gland, so it goes for sublingual, right? Go to the next question here. So let me look at your comments too, if there is something. Okay. Yeah. So question number 2. Okay, so the question says that which of the following is correct? Okay, so type. So this was if you know your basics well, you would be able to answer that very well. So here it is type 3 collagen replaces type 1. No, it is ulta. Type 1 collagen replaces type 3 eventually. Okay, so that is a wrong option. Angiogenesis happens in proliferative phase. Yes, definitely. Angiogenesis is a very important part that occurs in the proliferative phase. So that's true here. Okay. Inflammatory is followed by exudative phase. Wrong. It is an opposite way. Type 1 collagen is present in immature state. No, type 3 is present in the mature state, and it is arranged in random manner. So that point you have to be very, very clear. So here, this is what is wrong here. Okay, so that is what you have to be very, very clear. So that is where we go for the answer. Okay, so that here the answer to this question is B. Angiogenesis occurs in the proliferative phase. So that is the only answer that is appearing to be correct. Rest are appearing to be wrong. Okay, coming to the next question here. Okay, so question number 3 was basically your basically prostate and Gleason scoring was asked. So this was a question which is asked, and we have practiced this question so many times in the quizzes that I gave in the group. And this was the exact question I had given. I had also given 5 plus 5. So those of you who have attended the quizzes would know that this is one of the questions which was an expected question which can be asked in the exam. I've given this so many times. So I've taught you this always, that remember the scoring always. So whenever we have 4 plus 4, it goes to the grade group 4. Okay, so that is what we, and I had in the quizzes, I had also given 5 plus 5, that is grade group 5. So this is 4 plus 4, this is 4 plus 4, it goes to the grade group 4. Okay, so that was the answer to this quiz question. Now, this is another question which I gave in the Jinx question yesterday. Yesterday, this was the chart, exact chart that I gave. So remember, color typically asked, and this is also very easy question also. For liver fibrosis, you use Masson trichrome stain. And trichrome, basically, this is the classical image that is also there in the workbook, if you have seen that. So that's very classical. This is Masson trichrome stain. Blue color is collagen. Red color is basically the Masson's, but here the red color is the liver cell, and here blue color is the collagen. So that is Masson's trichrome, which is there, which is typically given. Okay, so gene size you see for mast cells, Zeel-Nielsen, you know it is for acid fast bacilli. Prussian blue is for hemocytin. Although Prussian blue is a blue color stain, it is seen inside the cells because it identifies the iron. It can be outside also, but it's a very granular stain. Okay, it is not for fibrosis. Okay, so that is what you have to be very, very clear. Okay, now Which of the following is the wrongly matched? So when we talk about wrongly matched, you have to be very, very clear. This is again a very, very tentative question. It is not tricky at all. It's tentative question. We know that Epstein-Barr virus is typically associated with Burkitt. That's very true. HHV8 Kaposi. Kaposi was a jinx question which I gave yesterday in the image, but it didn't came that way. So it was HHV8 with Kaposi. HTLV1 typically adult T-cell lymphoma with flower cell, and CMV doesn't cause nasopharyngeal carcinoma. Nasopharyngeal carcinoma also is caused by Epstein-Barr virus. Okay, so that is the answer here. It is absolutely wrongly matched. So infections, I told you yesterday also, very tentative question. Viruses are given either as an image or match the following. You should be very clear with all the parasites and the infective organisms. Okay. Okay, come to the next question. So this was a tricky question. I would say this was actually a tricky question. So what is incomplete penetrance in genetics? So I've told you this so many times when I talk about incomplete penetrance. This means that you have the gene but you don't express it. That is what is called as incomplete gene. Okay, penetrance. So you have the gene but you don't express it. So what is correct in this? Multiple person in one generation are affected. So this is not there. Multiple person in one generation are affected. This is a feature of autosomal recessive pedigree. Okay, in autosomal recessive pedigree, multiple people in one generation can be affected. This is an autosomal recessive pedigree, that you remember. And this is incomplete penetrance is seen in autosomal dominant inheritance. So that is one thing which we should be very, very clear. Now, disease will not be present in one generation. So you can say like this, that disease will not be present in one generation. Some people will be affected, some people will not be affected. So disease will not be present in one generation. Let's keep it as a choice. Okay, pata nahi, ho bhi sakta hai. Let's look at that. Alternate generations are affected. So alternate generations are affected. You can't say that particularly for any kind of inheritance. Ki bhai alternate generations affect ho rahi hai. Incomplete penetrance can occur very randomly. It's an autosomal dominant inheritance. So if you have the gene and you don't express it, that is incomplete penetrance. So it is not alternate generation express hoti jayegi. It doesn't happen that way. So alternate generations are affected cannot be true in this context. Okay. Disease will not manifest in next generation. It is also not true. This statement is not true that, okay, if you have incomplete penetrance, autosomal dominant, disease will not go to next generation. Aisa nahi hota. In autosomal dominant, usually the disease will manifest. Any one person in every generation will be affected. So this is also wrong. So if you go by exclusion, only this option appears to be correct. Only this option appears to be correct. Okay, other options does not appear to be correct, right? So if there is any change in the option, please let me know. Okay, but what is the change in the option? So according to this, the disease will not be present in one generation. Okay, so some people in one generation will be affected, some will not be affected. So I think that can be taken as this. Okay. Okay. So Supraja is saying, ma'am, there was an option telling no one will express the gene. It is not like this. No one will express the gene is not a statement at all. Ki koi bhi express nahi kar raha hai. So no one will express the gene is not correct. Incomplete penetrance means you have the gene but you don't express it. But it cannot be made as a generalized statement that nobody will express it. That is not correct. Again, right, Supraja? So that is, you have to understand, you have to deal the option in that way. You have to think in that way that, okay, some people might be affected, some people might not be affected. So that point has to be very, very clear, and we have to be understanding in that context. We have to be understanding. Okay. So once we are clear with this, we know that this is it. Okay. So let's go to the next question here. So when we go to the next question, so this was a very easy googly question. If you look at it, a patient has a hemoglobin of 8, MCV of 62, and ferritin is low. So what type of anemia it is? So when I'm talking about MCV, which is low, and the ferritin is also low. Okay, so then I'm not having any doubt. Ferritin low ka matlab ho gaya seedha iron deficiency anemia. Finished. Okay, because megaloblastic anemia also will have usually iron levels will be normal. Aplastic anemia, sideroblastic anemia, all will have a better ferritin. So that point has to be clear. So here the answer is very simple, iron deficiency anemia. And this kind of question is not expected out of INI CET. But yes, they gave this so good. Be happy about it. It was an easy question. Okay. So this was the jinx question which I gave yesterday. Myeloid hamesha main bolte, it's one of the very, very important topic. Always, even in NEET PG or in INI CET, there's always a question that comes from it. So you have to be super clear with that. And there'll always be a question on it. So which of the following is seen in patients with chronic inflammation? You know that it is ET. So I've told you this yesterday also. This is one of the jinx question. AL is in primary. We have studied that. Okay. And we always know that when we talk about A beta 2, this is in patients with chronic dialysis and transthyretin. If it is normal transthyretin, it is an aging. If it's mutated, it causes neuropathy. So here the answer was A amyloidosis. I hope everybody did that correctly. Now this was another tricky question. So this is a patient from Assam who's HIV positive, and he has cavities in the lung now. And they're nodules, and sputum examination is negative. There is a caseous necrosis, which is granuloma, and also there is Langerhans cells. ESR is also raised. What is the diagnosis? So I've taught you this so many times. Okay, even in the lectures I've told you this. So whenever there is caseous necrosis and cavities, it's not unique to tuberculosis. It can be seen in histoplasmosis also. So whenever you're looking at the caseous necrosis with cavities, histoplasmosis should always be in your list. Okay. So that is it. So, and plus it is HIV positive. That means the patient is immunocompromised. That again takes you towards histoplasma. So here the answer was histoplasma, and TB was not in the option that was told to me by students, right? Okay. Coming to the next one, this is very interesting. Okay, so this is very interesting. Okay, so this is something which is very close to the heart. Okay, so what is seen in beta thalassemia major? I think it was a multiple option type question. And, whenever we talk about beta thalassemia major, the main problem here is it's a couple disease, you know that, and beta gene to hota hi nahi hai. So when there's no beta gene, okay, what will happen when there's no beta gene? Obviously, alpha will get so sad, and all this alpha chains will start accumulating in the red cells, and they will start dying in the bone marrow. Okay. Okay, Rahul. Granulomatous like was it? Okay. So, Nikhil, the question was secondary amyloidosis. That also is I'll just go to this point again. Chronic inflammation, or if it is secondary amyloidosis, then also your answer is the same only. That is AA, right? So that goes here only. Okay. Coming back to this, so remember, so what will happen? All these red cells who have accumulated alpha chains will start dying in the bone marrow itself, and this is called as infective erythropoiesis. That will be seen here. Intravascular hemolysis will not be a feature of thalassemia major. It usually undergoes extravascular hemolysis. So it's spleen, which is the major culprit. So patient will have splenomegaly. Intravascular hemolysis nahi hota. Obviously, because there is destruction of so many red cells, okay, everywhere. Eventually, what will happen is iron overload. So, lot with iron, plus the patient is getting a lot of blood transfusions also, because to survive, he needs blood transfusion. So, there will be iron overload. Now, hepcidin levels. Now, this is a very, very interesting story here. So, normally, what is hepcidin? Hepcidin is a negative regulator of iron. That means it controls the gate of iron entry, that is ferroportin. So, it controls the ferroportin gate, okay? So what happens? What do you expect? You expect that if thalassemia hai, iron overload ho gaye, the body hepcidin levels ko badha degi. It doesn't happen that way, okay? So in beta thalassemia, it's the reverse story. Hepcidin levels are decreased, okay? Because the hepcidin levels are decreased because of ineffective erythropoiesis, hepcidin levels are decreased. Because hepcidin is decreased, ferroportin is not stopped, and iron absorption increases. And that also causes iron overload. So that's true here. Hepcidin levels are low. Okay, so that is one point that we have to be very, very clear. So when we talk about beta thalassemia major, remember there is ineffective erythropoiesis, there is iron overload, and hepcidin levels are low, not high. Okay, so please remember that. That's a very, very classical feature of beta thalassemia major that you should be super clear. Okay, I think it's a multiple option type answer. Okay, so this. I was thinking of adding question as a junction yesterday, and I somehow didn't add that. I added microRNA. So yes, this came here today. So this is guide RNA. So once you see gRNA coming into action, okay, so whenever gRNA is seen, it can be nothing else except CRISPR. Okay, PCR to aisa dikhta nahi hai. All of you have seen PCR. PCR doesn't look like this. So definitely it is not PCR. Southern blotting doesn't look like this. Okay, so southern blotting, I've added an image on your Instagram also. Southern blotting, how it is done. It's like a blot. Okay, RFLP also doesn't look like this. Okay, so it's a length polymorphism where you see the lengths. So here it guide RNA was seen. So if you could have applied your logic and you've seen gRNA, then it can be nothing else except your CRISPR. So that point has to be very, very clear. So whenever it's gRNA, it has to be gene editing tool, that is CRISPR. Okay. Okay, now let's come to the next question. So this I had added yesterday in the Jinx question. So MI, okay, so MI ka stain, MI ka stages. So you have to be, you have to know that. Okay, so thank you, Nikhil. So you have to understand this point here, that whenever I'm talking about post-MI, you have to be clear that neutrophils are the first. So we have a reversible injury first that happens here, and then it goes to irreversible injury. Reversible injury progresses to irreversible injury. And after reversible injury comes, neutrophils are the first cells to come, and usually starts from 24 hours at the maximum peak in 1 to 2 days. So that is what is neutrophils. Okay. So that is typical neutrophils which come here. By then it is replaced by macrophages on day 3, and then granulation tissue on day 7, and then collagen deposition starts. And then collagen deposition starts after from 2 weeks to 2 months. That's it. So that's the rule that we have to study and remember. It was a very easy thing. Neutrophil, macrophages, granulation tissue, and collagen. Khatam. So neutrophils are the cells which come early, 1 to 3 days, and you know that 1 to 2 months में तो collagen आएगा, 4 to 6 weeks में भी again there'll be collagen only. 0 to 4 hour में just waviness will be there. So the answer was 1 to 3 days, and I'm sure all of you marked. Okay. So Rahul says 7 to 10 days was also one of the options. Okay, taken. 7 to 10 days is a time for granulation tissue. I told you this story every time. Whenever in the local wound or the granulation tissue comes on day 3, but in heart the granulation tissue always comes on day 7. So that's difference from the that is a difference from the local and the local wound repair and the heart wound repair. Okay, so granulation tissue in heart comes on day 7. Okay, so that was one thing which we need to be super clear with. Yes, perfect. Okay. Now coming to the next one here, this was a lot of question trauma came this time, and it was a question that came was on massive blood transfusion, and there was a question which is a lethal triad of trauma that was asked to you, and we should remember this as what is a lethal triad? It is always hack. Okay, so it's a hack of trauma, which you should remember. So we have hypothermia, we have acidosis, and we have coagulopathy. So we have hypothermia, acidosis, and coagulopathy. So that is very typical feature. That's a lethal triad of trauma. So when somebody is asking lethal triad of trauma, it has to be BNC. Some people may argue with me why hyperkalemia is not in the option. So hyperkalemia is seen in massive blood transfusion, but it is not a lethal triad of trauma. So when the question is very specific, you have to answer it very specifically. So yes, it's not a lethal triad. So the answer to this is your hypothermia and coagulopathy, which are typical lethal triads, which we should be very, very clear. Okay. Okay. The next question was which is not using the diagnostic criteria of Kawasaki, and I saw Sandeep sir has also discussed this. So it's simple purulent conjunctivitis nahi hota. So this I have already told you in the lectures also. It is cream. Okay, so we have conjunctivitis, we have rash, we have erythema, we have adenopathy, and we have mucosal lesion. So that's very, very typical that is there, and fever should always be present. So fever plus cream. Okay. So, so that is one thing which we have to be clear. So patient will have fever plus cream. So it's not purulent conjunctivitis that is there. Okay, so purulent conjunctivitis is not a feature. Lymphadenopathy hoti hai, rash hota hai, desquamation hoti hai, all that happens, right? Okay, so here was a question, and there is a tricky thing. Some people say which is not a medium vessel vasculitis. Okay, so which is not a medium vessel vasculitis. So remember leukocytoclastic vasculitis, I told you this when we divide. So when we divide the medium vessel vasculitis, we always say that it is Kawasaki and Pan. Kawasaki and Pan is medium. When we say small vessel vasculitis, we say it as immune complex mediated or non-immune complex mediated. So again, non-immune complex mediated, may we have this microscopic polyangiitis, which is ANCA mediated. Okay, microscopic polyangiitis, okay, which is P-ANCA mediated. And then we have C-ANCA mediated, that is vaginous. That is vaginous. Okay, that is vaginous. Okay, and immune complex is HSP. Okay, so HSP and microscopic polyangiitis both are a type of, I have told you this so many times, they are a type of leukocytoclastic vasculitis. They're a type of leukocytoclastic vasculitis. So they're small vessel. So leukocytoclastic vasculitis is a small vessel disease. Microscopic polyangiitis ho, ya vaginous ho, GPA ho, they are all small vessel vasculitis. Okay. What about Berger's? Okay, so what about Berger's disease? So Berger's disease can affect small as well as medium vessels. So it can affect both small and medium vessel vasculitis. So it is small and medium. So PAN basically is a classical medium vessel vasculitis. So PAN is classical medium. So you have to help me with the option. Was it a Was it a multiple choice type? Because leukocytoclastic vasculitis is also a small vessel. And microscopic polyangiitis is also a small vessel. So if it was a multiple choice type answers, then yes, the A and C should always be there. But you have to help me with that, because if it is not a medium vessel vasculitis, then the answer should be your this. Okay, leukocytoclastic vasculitis and microscopic polyangiitis both. Okay, so yes. Okay, and Burgess is both small and medium vessel vasculitis. So that is about the question here. You have to tell me whether it was a multiple choice type answer, and then I'll be able to help you with the answer better. Okay. Coming to this, so serotonin is one of the most tentative questions that is always asked. Okay, and this was also a Jinx question which I gave in the PDF yesterday. So this serotonin is asked nearly every time. It's one of the favorites of the INI CET exam. And you look at this, so this time they ask you which is the chemical that can be used. Okay. Okay, Nikhil, what is it? MPA, microscopic polyangiitis, no? Yes. So, correct, no? So, yeah. So, microscopic polyangiitis was not in the option you want to say? Okay, right. Okay, so this was about serotonin. So, what is the chemical here? It is very typical resveratrol, which is basically found in your red wine, in your grapes, in your berries. And they are the ones which basically induce the gene called CET, which basically increases longevity and it improves the insulin metabolism. So that's the chemical which is there, which it helps you inducing serotonins and it provides longevity. So that has to be very, very okay. Okay. So then there was this question which was very tricky and typically asked. So this enteritis with mucosal image was given, and this is from your Jinx PDF that I just took a snapshot of it. So I thought that क्योंकि ऋतिक रोशन की गर्लफ्रेंड को आइसोस्पोरा हुआ था and it was a okay. So match the following. Supra Vishwas is saying match the following. It was serotonins with the resveratrol and more were there. Okay. So the answer is resveratrol with serotonins. Apart from that, what else was there? You have to tell me that. Okay. Okay. So Jagasu, was leukocytoclastic, so there's only one answer and it was not medium vessel, right? So if leukocytoclastic vasculitis or microscopic polyangiitis, anything was there, that is a typical small vessel vasculitis. That should be the answer. Okay. Okay. Now coming to this, so I thought this should be a question. So I had typically given you these acid-fast organisms and which came, but according to the recall of the students, I think the answer was entamoeba. I think like that. So there was an enteritis with mucosal image, and was it the people? It was very red color, big spore, ma'am, which had some RBCs inside it. So from what I can recall from the students, it was entamoeba. That is what I am getting from the students, if I'm correct. Okay, but you know, entamoeba ही मैंने नहीं डाला था in the Jinx and rest everything डाला था. Okay, so I had added cyclospora, isospora, cryptosporidium, which will be attaching to the tips of the epithelium, and giardia डाला था, which was sickle cells like which will be shedding here. Isospora डाला था जो कि elliptical होता है. Cyclospora डाला था acid fast rounded होता है. So I had added all of them. I had not added entamoeba. So if you had seen the PDF and you've seen all of these, you would have realized that इसमें तो entamoeba nahi hai. So I think we could have marked it by exclusion also, right? So these are common malabsorption questions which can be asked. Okay. And so according to what recall I'm getting from the students, you have to tell me. So cryptosporidium will always be attached to this small, it is a very 4 to 6 microns to the tip of the epithelium. Entamoeba will be big spore with which will be eating the RBCs, and giardia was these sickle cells which you see, and vermicularis तो appendix में होता है, तो ये malabsorption करवाता ही नहीं है. Okay, so that is one thing which was there. Okay, so I'm glad Sandeep that Jinx question helped you. Thank you so much for saying that. And yes, okay. So yeah, this was your one thing which you have to be very clear. Now this is a very straightforward question, and I am sure all of you would have answered this correctly. Okay. So this was basically a very classical pattern. It was there. Some students says, ma'am, it was given C3 was deposited. Some people said the child had fever, and after fever, respiratory infection, kidney lesions were there. Okay, so this is a snapshot from the quiz that I had given for kidney, and very typical question that is, I told you this, they will not give you post-streptococcal glomerulonephritis because the name has changed now. It is now called as post-infectious glomerulonephritis. So even if they are saying humps or starry sky appearance, all those things, okay, so that is very, very typical of post-streptococcal glomerulonephritis, which is now called as post-infectious glomerulonephritis. So that point you have to be very, very clear. So this is typical question that you have to understand here. Okay, Goodpasture syndrome is a type of RPGN. It will show you crescents. It will not be there. Membranous will show you subepithelial deposit, but here the basement membranes will be thickened. IG nephropathy, I've told you so many times, there will be deposits in the mesangium and it will be IgA. Here, IgG and C3 will be classically deposited, okay, in PSG. So, or PIG. PIGN is post-infective glomerulonephritis. So, that point has to be very, very clear. So, the answer to this is A, which you have to be very, very clear. Okay. So, the next question that was given was this: which of the following is the diagnosis as per the histopathological image? So these are the depositions in the CNS, which I always tell you before starting the CNS, and I tell you that these are basic things that you should know in the CNS before you start. And what do I tell you this? So I tell you that whenever you are given this pink color, I have drawn a diagram also. So this pink color deposits, when you see like this, these are basically can be of two types. If they can be neuritic plaques or they can be diffuse plaques. Okay, so these are all plaques which can be deposited. So there is basically a myeloid which deposits here, that is A beta amyloid, and along that there are neurites which can deposit here. So these are neuritic plaques. Okay, so something like this, which you can see here. So pink color deposit with rays coming out from this. These are neuritic plaques, which are very, very typically in Alzheimer's disease. Okay, why it is not Parkinson's? I've told you this already. Parkinson's, you will typically see the inclusions, okay, here in the pigmented neurons. Okay, so that will be very typical inclusion which will be seen inside the neuron. In Huntington's, the inclusion will be seen inside the nucleus. I've told you this. Huntington's is a trinucleotide repeat. So CAG polyglutamate repeats deposited in the nucleus of the neuron. It's not fixed disease again. That's very classical here. So here we have to understand whenever they're giving you these are neurites, which you have to understand. And it is so typical for Alzheimer's disease. Okay. Now this is a googly question, and I'm sure all of you marked it correct. This is one question which everyone would be so happy seeing. So this is an HPE of the gastroesophageal junction was given, and a typical, you could see this goblet cells in the esophagus. So whenever there is an esophageal, gastroesophageal junction with goblet cells, I think there's no doubt, everybody knows that it is Barrett's esophagus. So that is Barrett's esophagus, which you should be very, very clear, and that is answer here. I think everybody would have marked it very correctly. Once you see goblet cells, it's Barrett's esophagus. Okay, coming to this question here, peripheral smear was stained. Which of the following stain is used here? This is so typical that is given here. So if you look at this, I have talked again. First thing is, whenever you have to stain the red cells, and I've already told you this in all the session, all the class, all the time, blue colored stain in the RBC is usually a supravital stain. So these supravital stains can stain the reticulocytes or the globin chains. So if you can see this globin, which is attached to the borders of the red cells, so these are basically golf ball inclusions which are given here. These are your reticulocytes here, which are like threads here. These are reticulocytes, and these are your golf ball inclusions that are so typically given here. So whenever they're staining globins and reticulocytes, it has to be a supravital stain, that is new methylene blue. I think the answer was new methylene blue. So it has to be new methylene blue or brilliant chrysal blue that you have to use. The classical staining of the RBC is with Romanowski stain, that is Jamesa or Hishman or Diffwick. They are Romanowski stains. So they will stain, they will give the red cells red color, pinkish reddish color, pinkish color. Whereas when you see this kind of blue color stain in the RBC, it has to be neomethylene blue. I hope everybody marked this correctly. Okay. Now, Benedict duct test is not shown by, so which is not a reducing sugar, will not show that, and that is sucrose. Okay, so that would be discussed, already would have been discussed. Now look at this. So students were confused in this question. They told me, ma'am, because इसमें protein पूछ लिया गया. It was so simple. So they had given formalin-based paraffin tissue sections. See, when they give you this, that is a paraffin tissue section. I've told you this so many times. Okay. So all the antigens are also proteins only, right? So whenever you have to see anything on the formalin tissues, it has to be immunohistochemistry that has to be done. And this is the first thing we have to understand here. So that is immunohistochemistry that needs to be done here. So that is done here. Okay, so it's histopathology. Formalin में अगर किसी चीज को डाल दिया, उसके बाद it is IHC which will take over. Okay, immunohistochemistry. Western blot is not done in formalin fixed section. Flow cytometry is usually done in blood and bone marrow in the flowing cells. In situ hybridization is fish. Again, for fish we don't do that. Do it on usually. So whenever we have to do it. Whenever we have to see, we have to do in situ hybridization, we can do it on paraffin fixed sections also, but it will see the DNA. Okay, it will basically not see the proteins, it will see the DNA directly, it will see the genes directly, HER2 gene, EGFR gene, that will be seen. So that is why when they are seeing formalin fixed paraffin tissue sections to identify the proteins, and you want to see the proteins, it has to be HC. Okay. So what is the mechanism of carcinogenesis of UV light? So whenever we're talking about mechanism of carcinogenesis of the UV light, you have to be very, very clear that UV light typically causes formation of pyrimidine dimers. Okay. So pyrimidine dimers are so classical by UV light. So that is the mechanism of carcinogenesis by UV light. That is what is the classical answer. So this is one thing which we keep teaching to undergraduates again and again. The mechanism. Okay. Okay, so this was given here. So they gave the lesion, plexiform neurofibroma, Lish nodules on the eyes, and caffulate spots. Okay, so what is the answer to this? I hope everybody knows this and they had marked it correctly. What is the gene that is mutated here? NF1. This is neurofibroma. Okay, so that's very, very typical. That's neurofibroma here. It's not Downs, it's not tuberous sclerosis. Okay, so that's very classical features of your neurofibromas, NF1. Now, next question was oncogene addiction. And this I've taught you so many times, you know. I've told you the example of people when people are smokers and they smoke. Okay, so there are people who smoke and they say, if I don't smoke, I'm not able to focus on my work. So they're addicted to smoking. Similarly, some cancers are addicted to some genes. And if you kill that gene, the cancer cells will also die. So they are so dependent on single activated oncogenes for their survival and proliferation. If you kill that gene, the cancer will also die. And I've given you a typical example for this also, like BCR-ABL. So CML is addicted to BCR-ABL. Like I've told you the example of CML, which is addicted to BCR-ABL. That's what I've told you so much. Burkitt's is addicted to CMYC. Okay. So if you kill them, the cancer will also die. So that's a typical feature. That's why I've written this. Okay, so oncogene addiction is basically when the cancer cells are addicted to one gene. That's what's called as oncogene addiction. Okay, now let's come to this question here. So this time they didn't give you Hodgkin cells or something like that, which they always give you. And somehow I was feeling Hodgkin cells nahi aayenge. I didn't added this also in my genes question yesterday. But they gave you the staging and they asked you what does X in the staging means. Okay, so last time, I think 2 to 3 years back, they had asked B. So they have asked what does B mean. So there are some stage modifiers in Hodgkin's which we should be very, very clear. So B symptoms means fever, night sweat, weight loss more than 10%. This was one of the questions that was asked a few years back. What does X means? X means bulky disease. X always means bulky disease. So whenever you have a node more than 10 centimeter, or if it is in mediastinum, you have a mass more than 1/3 the thoracic diameter. That is what is called as X. Okay, so whenever we say X, that always means bulky disease. Okay, so that is the point that you have to be clear. X is bulky disease. Okay, so if you look at the other options is googly option. They wanted you to answer this. Okay, so that is what is X here in Hodgkin's lymphoma. Okay, and that's all, guys. I think we finished mostly all. So a lot of questions from pathology this time. I think 30 questions from pathology, and it is always like that. So pre and paraclinical forms a very, very strong part in your INI CET exam. I hope you did well, and yes, keep revising. Don't stop at this stage. Take a break 1 or 2 days now. And after that, keep preparing for your NEET PG exam, because INI CET should always be taken as a grand test for your NEET PG. So with that, signing off, guys. Bye-bye and good night. If there are any doubts, feel free to contact on my Instagram, that is Dr. Vandana Pathology, or you can message at the DocTutorials WhatsApp groups also. So, or you can ask in the chat box also here. So anywhere, we are always available for you. So if you have any doubt, wherever you are, you can ask us. Bye-bye, guys.